Muito bem. Olá, bom dia a todos, bem-vindos. O meu nome é Rita Faden, sou presidente da Fundação Luso-Americana para o Desenvolvimento e é um gosto ter-vos aqui na FLAD hoje para esta conferência sobre o Long COVID, enfim, sobre os problemas, implicações e a forma de lidar. Gostava só de dizer duas breves palavras sobre a FLAD. A FLAD é uma Fundação Luso-Americana para o Desenvolvimento, criada há quase 40 anos, com o objetivo de aproximar Portugal e os Estados Unidos, e nós trabalhamos a nossa missão é contribuir para o desenvolvimento de Portugal através da cooperação bilateral com os Estados Unidos. E trabalhamos em áreas como ciência, educação, cultura e relações transatlânticas. Sejam muito bem-vindos à FLAD e espero que seja um dia de trabalho muito proveitoso. Now, just a few words in English. Welcome all, everyone. Thank you. It is a pleasure to have you here at FLAD, Luso-American Development Foundation. FLAD is a Portuguese foundation created almost 40 years ago with a very specific goal of contributing to the development of Portugal through the bilateral cooperation with the United States. We work in 4 main areas: science, education, cultural and transatlantic relations, and it is really a pleasure for us to have you here today, in present here within FLAD, but also online by streaming around the world. So I hope that you have 2 days of very fruitful work, and you are very much welcome at FLAD. Thank you so much. And now I give the floor to Dr. Jaime Branco.
Bom dia, good morning. Apologizing our international guests. This first session, these speeches are going to be done in Portuguese. And as my director is coming from Nova Medical School, I am going only to present Joan Hoffman, is the second presenter. Joan? Okay. Joan Hoffman from the Alliance, Millions Alliance. Is representative from the patients' associations.
Bom dia. Vou pôr os meus óculos para poder ler. É o meu privilégio... desculpe, tirar a máscara também. Bem, vamos tentar de novo. É o meu privilégio dar-vos as boas-vindas a esta primeira conferência sobre o Covid longo e a encefalomielite miálgica. Esperamos que esta conferência marque um antes e depois no nível de sensibilização e também nas abordagens clínicas e interesse na investigação sobre estas doenças que têm sido tão subdiagnosticadas em Portugal. Esperemos também que isto inicie uma resposta do terceiro setor e da sociedade civil muito mais vigorosa em prol de um grande e, infelizmente, um crescente número de portugueses afetados pela encefalomielite miálgica e a encefalomielite miálgica induzida por Long COVID. Por muito tempo temos permanecido invisíveis. Esta conferência surgiu da iniciativa de um coletivo de pessoas vivendo com estas doenças, sem afiliação formal ou institucional, que, vendo a falta de respostas baseadas em evidência, resolveram ir à procura de aliados e soluções. Ao pedir ajuda, fomos batendo porta em porta. O primeiro a abrir foi o Dr. Vaz Carneiro, do Instituto Baseado em Evidência. Ele abriu a porta para nós, deixou-nos entrar e, desde então, eu vou ficar chorando, tem-nos acompanhado nesta iniciativa, caminhando juntos. Conseguimos reunir os maiores especialistas do tema ao nível mundial e organizar, quiçá, o evento de maior nível na Europa sobre este tema. Isto é testamento ao ativismo não só de doentes, mas também os médicos e os pesquisadores pioneiros aliados, trabalhando em conjunto. No caminho, encontramos muitos colaboradores e voluntários que ajudaram a concretizar o sonho desta conferência. Muitos estão presentes nesta sala e muitos outros online, desde as suas camas e casas, em Portugal, no Brasil e outras comunidades lusófonas internacionais. E no vídeo que mostramos no início, temos uma série de testamentos e bons votos de pacientes em Portugal e em todas as partes do mundo. Mas preciso agradecer particularmente a doutora Susan Levine e o Dr. David Systrom, que inicialmente apoiaram este esforço ao pedido de uma paciente sem reservas e que nos orientaram em todos os aspectos clínicos e científicos do programa. E aos demais palestrantes aqui presentes que nos acompanham nesta jornada. Temos o luxo de ter entre os palestrantes as pessoas com maior compromisso e maior trajetória clínica e investigação neste tema. São numerosos demais, porque eu só tenho 3 minutos para dizer os nomes. Peço desculpas. Em Portugal, o Dr. Jaime Branco e o Dr. Germano de Sousa foram os nossos grandes campeões. E também o Nuno Sepúlveda, professor e grande pesquisador português da encefalomielite epidemiológica, apoiado pelo Centro de Estatísticas e suas aplicações. E, por último, primordialmente, agradeço aos integrantes portugueses dos grupos de apoio e disseminação de informação clínica e científica de ponta e os membros do nosso coletivo lusófono e luso-brasileiro, Millions Missing Aliança, que, ante a falta de respostas institucionais, resolveram se organizar e agir. Este é apenas o começo. Desejo-vos 2 excelentes jornadas de aprendizagem e solidariedade. E obrigada à FLAD. Vocês foram também os primeiros a abrir a porta. Muito obrigada.
For whom doesn't know, Joanne is the body and the soul of this meeting, okay? Inês Serra Lopes é a presidente da MIOS, Associação Portuguesa de Fibromialgia e Síndrome da Fadiga Crónica, e é, enfim, a apresentadora seguinte, vai dar-vos as boas-vindas, também em nome da associação, desta Associação de Doentes. Inês Lopes is the president of MIOS, the Portuguese Association for Fibromyalgia and Chronic Fatigue Syndrome.
Bom dia a todos. Eu quero agradecer em nome da MIOS, da Associação Nacional contra a Fibromialgia e Síndrome de Fadiga Crónica, e em nome de todos os doentes com síndrome de fadiga crónica, encefalomielite miálgica ou Covid longa em Portugal e no mundo fora que nos assistem de forma online, através do streaming, a presença de tantas instituições e de tantos médicos que aceitaram abraçar esta causa. A associação vai fazer agora 21 anos, em maio, mas tem sido uma grande luta para fazer chamar a atenção e trazer à atenção a encefalomielite miálgica, síndrome de fadiga crónica em Portugal. E há um ano, já há um bocadinho mais de um ano, quando fomos convidados para integrar esta iniciativa, abraçámos de coração e alma, e tem sido mais de um ano de muito trabalho árduo, de vários voluntários dentro da associação, e nomeadamente o nosso grupo de trabalho de encefalomielite miálgica, síndrome de fadiga crónica, na MIOS, que vários voluntários estiveram a ajudar na implementação deste evento, que muito nos honra. Este é um evento importantíssimo para nós, doentes, e para instituições, para poder trazer para Portugal e para o mundo também este coletivo de grandes especialistas mundiais, e que se possa chamar a atenção para estas síndromes que são tão desconhecidas e tão pouco reconhecidas. Há milhares em Portugal e certamente milhões pelo mundo que não estão diagnosticados, não sabem que têm estas doenças, e é muito importante passar a informação para médicos, para faculdades de medicina, para que os próprios doentes saibam, pelos sintomas, reconheçam, procurem apoio médico e consigam ser acompanhados. Da parte da associação, quero agradecer a presença e envolvimento de todas as instituições. A Joan já referiu várias, portanto não vou estar aqui a repetir, mas muito obrigado pela vossa dedicação e por vosso interesse, por estarem aqui e por tantas pessoas que nos estão a assistir online. Muito obrigada.
Thank you, Inês. Obrigado, Inês. Now, I call the director of, the dean of the Nova Medical School, Professora Helena Canhão. Professor Helena Canhão is a medical doctor, rheumatologist, and now she is professor of this school of medicine, and now she is the director. Thank you.
Muito obrigada, professor Jaime Branco. Muito bom dia a todos. Welcome to Lisbon. Bom dia também e agradecer aqui à FLAD, a doutora Rita Faden, a Joan Hoffman, o senhor bastonário da Ordem dos Médicos, o Dr. Carlos Cortes, cumprimento também o professor João Eurico Fonseca, diretor da Faculdade de Medicina da Universidade de Lisboa, a Inês da MIUS e todos vós aqui presentes, professor Mano de Sousa, e todos vós aqui presentes. Da minha parte, e enquanto reumatologista e diretora de uma escola médica, lembrar que a pandemia foi para todos inicialmente uma surpresa e virou as nossas vidas do avesso, de toda a população, mas também nos ensinou formas de trabalhar em conjunto, em colaboração, e aí mostrou-se como é que a sociedade civil, os profissionais de saúde, a população em geral e todas as instituições conseguem, a ciência, conseguem, se trabalharem juntas, ultrapassar dificuldades. E nós passamos a ter comportamentos diferentes, a tecnologia entrou ainda mais nas nossas vidas, quase uma nova ordem mundial, mas agora estamos no pós-pandemia. Há pessoas que ficaram com sequelas, que ficaram com novos sintomas, com sofrimento, e é preciso continuar a desenvolver, a trabalhar e a conhecer. E, sobretudo, a trabalhar em conjunto. E, portanto, dar-vos os parabéns por esta organização e felicitar-vos e desejar-vos 3 dias de trabalho. 2 dias e depois sei que têm mais um ainda com um grupo de trabalho mais restrito de trabalho. E muito obrigada. Bom dia a todos.
E agora a outra escola de medicina de Lisboa, que de resto é a mais antiga escola de medicina de Lisboa, a Faculdade de Medicina da Universidade de Lisboa, que é também uma das organizadoras desta reunião. O professor João Eurico Fonseca é, curiosamente, também reumatologista e o diretor desta escola. Isto é um lobbying importante, pelos vistos, mas e vai dar-nos as palavras seguintes. Professor João Eurico Fonseca is the Dean from Faculdade de Medicina of the Lisbon University. He is a medical doctor, he is a rheumatologist also, and this medical school, also with the Nova Medical School, is one of the organizers of this meeting. João?
Good morning to all of you. I don't know how many of you are known Portuguese speakers, so you understood that the presentation during this phase is due to be in Portuguese. Anyway, you understood that we both are deans and we both are rheumatologists. I assure you that this is not a prerequisite to be a dean in the Portuguese medical schools, okay? We can guarantee that. Well, the comment I will make in Portuguese, but I would like just to make an additional comment in English, because looking at you, I see that many of you don't speak Portuguese, just looking at you. And what I would like to highlight is that by a huge coincidence, the fact that we are both rheumatologists and leading two of the largest schools of medicine in Portugal, I think it's important to better let our medical students understand this problem. Because one of the issues that we have nowadays, at least in parts of the world, it might not be completely equal all over the world, is the lack of understanding of the public, but also of the medical doctors on this type of issues. And patient associations like MIOS had to struggle a lot and to impose a little bit diseases like fibromyalgia or chronic fatigue syndrome, because there are people, in fact, that don't believe on that. It's a little bit like I don't believe or I believe, which is something strange in the world of medicine. We're not speaking about a religion, so it's not a matter of being an atheist or believing in God. Okay, now you've understood more or less what I want to say. I'll come back to Portuguese. E, portanto, cumprimento todos que estão na sala. Esta nota, para mim, fazia sentido pelas coincidências várias. Quero fazer um elogio forte aos organizadores pela liderança que tiveram no processo, evidentemente. Faço menção, outra vez, à Associação de Doentes, porque eu, como reumatologista e como clínico, noto muito a ferrugem que existe na engrenagem da compreensão de que existe um conjunto de pessoas que têm sintomas do aparelho locomotor, têm sintomas que são, na verdade, neurologicamente expressos, são algumas vezes também psicologicamente expressos, são fisicamente e sistemicamente expressos, sendo difícil o diagnóstico diferencial entre muitas situações clínicas, entre doenças neurológicas, doenças médicas sistémicas, doenças reumáticas, e o workout disso está, de facto, na mão do médico e depois o entendimento por exclusão, muitas vezes em termos de atitude diagnóstica, e perceber que existe uma entidade clínica que está no contexto exatamente do que é discutido hoje nesta conferência. E, portanto, o awareness, independentemente do desenvolvimento intelectual à volta desta temática, parece-me muito importante. Por isso, os meus cumprimentos a todos os envolvidos. Muito obrigado por terem também partilhado com a Faculdade de Medicina da Universidade de Lisboa este momento, e venho aqui, no fundo, dar uma menção ao sentimento de relevância que isto tem na educação médica também, não só na educação da comunidade, ou seja, na literacia da saúde da comunidade, que também é preciso ser trabalhada. Muito obrigado a todos.
Por fim, mas não menos importante, queria apresentar-vos o Sr. Bastonário da Ordem dos Médicos, Dr. Carlos Cortes. É para nós uma satisfação e uma honra, Carlos, ter-te aqui. Last but not the least, now I present you the President of the Portuguese Medical Association, Dr. Carlos Cortes. Please, Carlos.
Muito obrigado, muito bom dia a todas e a todos. Obrigado, Jaime. Foste a primeira pessoa que me falou neste evento, que tem aqui umas características, enfim, particulares que eu passarei depois a desenvolver. Cumprimentar a nossa anfitriã, doutora Rita Faden, e agradecer. É a primeira vez que venho aqui à FLAD e são instalações magníficas do pouco que eu vi, e agradecer realmente por ter disponibilizado estas instalações para este acontecimento de um evento que é muito importante. Eu, cumprimentando, enfim, todas as pessoas que estão aqui neste painel de abertura, não me queria esquecer de cumprimentar também mais duas pessoas, o professor António Vaz Carneiro, que está ali no fundo, muito bem, está a controlar as operações, e o nosso sempre bastonário, o professor Germano Sousa, que está aqui também presente e cuja presença, obviamente, nos honra. Eu não sou reumatologista, eu sou patologista clínico, portanto, estão aqui duas representações que eu julgo que são relevantes da patologia clínica, que também teve um papel aqui absolutamente fundamental, e o próprio professor Germano Sousa foi um dos grandes impulsionadores, um dos grandes protagonistas da resposta da luta à Covid. De facto, este acontecimento, este evento internacional, tem aqui características curiosas que eu vos queria também aqui transmitir, que é, em primeiro lugar, e não é habitual, quem estimulou este acontecimento foi, para não me enganar no nome, a primeira pessoa que falou comigo foi a doutora Joan Hoffman, que veio ter comigo à Ordem dos Médicos, e achei curioso, e estava na expectativa de ver aquilo que ia acontecer. Porque veio falar comigo à Ordem dos Médicos, e não é habitual ser um doente, ser alguém que passa por esta dificuldade, que estimula e que acaba por conseguir concretizar aquilo que é o primeiro grande evento internacional sobre a Long COVID. Isto é um facto absolutamente maravilhoso, e eu até pedi uma salva de palmas por aquilo que fez. Muito obrigado. Mas, de facto, este acontecimento é importante porque junta a comunidade científica e junta as várias associações de doentes que também aqui estão representadas. E há aqui um sinal muito relevante, que é quando o mundo está, muitas vezes, em incertezas, quando há dificuldades à nossa volta, quando não sabemos, muitas vezes, qual é o caminho, quando as pessoas se juntam, e foi aqui muito bem focado numa intervenção anterior, nós conseguimos ultrapassar todos os obstáculos. E, de facto, a comunidade científica, como sempre, demonstra que não precisa dos políticos, não precisa dos governantes para desenvolver e para fazer mais e para tentar dar as respostas que são absolutamente necessárias. E, de facto, a Covid foi um período interessante, enfim, nós passávamos bem sem ele, mas é um período interessante da nossa história, não foi o único. A história da humanidade é a história de pandemias e de epidemias, mas, de facto, esta foi a maior pandemia dos últimos 100 anos. E, juntos, conseguimos ultrapassá-la. Mas houve aqui um facto que eu vos confesso que, para mim, é curioso. Depois de ultrapassarmos, enfim, este período difícil para todos nós, em termos de saúde pública, surgiu uma espécie de apagão. Quisemos virar a página e quisemos esquecer. Colocámos isto na despensa e não queríamos mais pensar sobre isto. Mas, de facto, a Long COVID, e tive a oportunidade, antes de chegar aqui a este evento, tem mais de 200, impressionante, sintomas, em mais de 60 áreas orgânicas. É absolutamente impressionante e não há nada, pelo menos em Portugal, que esteja organizado no sentido de dar uma resposta à Long COVID. Mas não é o único apagão, já que assim que terminou a Covid, curiosamente, nós não quisemos refletir sobre aquilo que fizemos. Sobre aquilo que fizemos de positivo, sobre aquilo que fizemos de negativo. E é muito importante nós fazermos balanços deste tipo de acontecimento. E não o fizemos, infelizmente. A Ordem dos Médicos, ela própria, por várias vezes, pediu ao Ministério da Saúde para nós refletirmos sobre a pandemia e nos prepararmos sobre um próximo acontecimento que possa surgir, uma próxima pandemia, uma próxima crise sanitária, para estarmos preparados com a experiência que nós tivemos, podemos dar uma resposta mais eficiente àquilo que aí vem. Infelizmente isso não foi feito, mas mais uma vez os profissionais de saúde, os médicos, a comunidade científica e, obviamente, este binómio absolutamente essencial, que são os doentes, que estão sempre juntos com os médicos e com a comunidade científica. Em conjunto, nós conseguiremos certamente ir mais longe, também neste período de incerteza em que Portugal está a viver. O novo governo tomou posse, o Serviço Nacional de Saúde, como nós sabemos, tem tido imensas dificuldades, mas eu estou certo que este tipo de iniciativa, de pessoas que não desistem, de pessoas que querem sempre uma melhor saúde, uma melhor resposta para o desenvolvimento das nossas sociedades, tenho a certeza que iremos sempre conseguir chegar a bom porto. Muitos parabéns mais uma vez e muito obrigado.
I thank all the speakers of the opening session, and now we are going to initiate the scientific session, and this would be all in English. I welcome you, all of you, those who are present in this room, and we have here for the today's 140 inscriptions, and also all the other which are well in various parts of the world, America, Europe, Africa, and which are at this moment I think 1.5 thousand people by YouTube, and I can say to you that mainly patients, of course, but also health professionals, doctors and other medical doctors and other professionals, families and caregivers, researchers, and medical students, and also some students of other health professionals, and I can say to you that 5% of them are simultaneously patients and health professionals, which are a number, for me, very impressive. Our program is very hard, and so we are going to initiate the clinical sessions. And the first speaker is Susan Levine. Susan Levine is a medical doctor from the Center for Solutions at Columbia Mailman School of Public Health, Research Fellow Center for Innovating Disorders at Cornell University, private practice also in myalgic encephalopathy and encephalomyelitis and chronic fatigue syndrome and related disorders. Susan is going to present to us a brief history of pandemic-related ME and CFS, Punta Gorda, Florida, and Royal Free Hospital in London, origin of current case definition. Please, Susan.
Hello, everybody. Can you hear me? I'm going to hope this works all right. Thank you for that very nice introduction. As many of you know, I've been seeing and evaluating patients with chronic fatigue syndrome for many, many years. And with the onset of the long COVID epidemic, we've hoped to shed some new light on this very ancient problem. So I have some prepared slides, and then I'm going to make some off-the-cuff remarks afterwards. You know, after all these years, things are pretty much the same. I've been in practice 30-plus years, and the initial case definition of this illness pretty much still stands with some minor changes. Generally speaking, what we call now ME/CFS, chronic fatigue syndrome, is mostly, I'd say 70% of cases, preceded by a viral or indolent bacterial infection. Why it is that in certain patients symptoms persist for years afterwards and other people get over it is still a large unknown. But it's thought to be that people who get ME/CFS first come down with viral infection, usually upper respiratory, and sometimes gastrointestinal symptoms are the prominent features of this. Later on, we find that, based on laboratory testing, that some of these acute viral infections lead to autoimmune sequelae. So you have things, like you clinicians are well aware, of low-level positive ANA tests, thyroiditis, and other signs of autoimmune illness. And this is thought to be because the immune system, in trying to fight the active viral illness, makes antibodies and cross-reacts with some what we call autoantigens. So thus, there's a low-level autoimmune reactivity that's going on. Now, as I said, 70% of cases we believe are caused by an acute viral illness, but in some minority of cases, there's a hormonal dysregulation that can prompt this. For instance, some patients after treatment with Graves' disease or postpartum or at the time of menopause will spark the onset of ME/CFS. Now I'm hoping this will move the slide forward. Can you give me the next slide, please? Whoops. I know somehow I'm not able to move this forward. Okay, I'm going to just go very quickly through the Los Angeles 1934 epidemic, which is one of the few earlier pandemics that we know of that was well characterized. At that time, patients exhibited fatigue, post-exertional malaise, and some neurological symptoms. These are very interesting, by the way, so I urge many of you to go through the archives. You can go on PubMed or Google Scholar and really read some of the firsthand accounts by doctors back then who did not have the luxury of the laboratory testing that we have available to us now. They really went in there, you know, and pulled up their shirt sleeves and interviewed patients and tried to get, like medical detectives really, and did the best they could with what they had. And some of the descriptions of these earlier pandemics are remarkably similar to what we see today. So in any event, in the Los Angeles epidemic, this was characterized by neurological symptoms mainly. It occurred during the time frame May through December. Again, 75% of people affected were female, 39 years of age or younger, and the attack rate was 4.5%. Another famous epidemic that has been written about took place in Akureyri, Iceland, and this was more community-based as opposed to institutional. And this epidemic occurred in the winter months. 70% were age 20 or older, and this was classified as at the time as a benign meningoencephalomyelitis. If you read some of the literature, you'll see that Melvin Ramsey, who was a big champion for ME/CFS, really objected to the description benign. He said, this isn't benign. This is a really debilitating illness. So even back then, there were some champions of the illness that could attest to the debilitating symptoms of this disorder. There were some young children affected, spared patients, but interestingly, the nursing staff was affected. And this is also true of the Punta Gorda epidemic, which I'll describe a little bit later. And this epidemic was clinically characterized by fasciculations, muscle fasciculations, and diminished concentration and photophobia. So we see here a lot of neurological symptoms being described, which is in somewhat contrast to what we see today, where people, when they describe ME, they talk more about sore throats, glandular swelling, cognitive deficits, but we don't hear as much, I think, which may be an oversight, it's hard to say, about neurological symptoms. And then the other interesting thing that was described in Iceland and also in Punta Gorda were some laboratory findings that, frankly, I don't see that much in ME/CFS or even in long COVID, which are the atypical lymphocytes, glucose imbalance, and EMG abnormalities. London had a similar epidemic in 1955. It was institution-based, occurred between July and November. Punta Gorda, Florida, that I'll go into in a little more detail in a bit, was mixed institution and community-based and occurred between March and June. Again, 74% female prevalence, and patients affected were 20 to 49 years old. In 61, there was an epidemic in upstate New York, which was institution-based, this time all female, and a 37% attack rate. Many of you know or are familiar with the Lake Tahoe epidemic in 84, 85, and this time, by then, there were more laboratory testing available than in previous epidemics, and elevated EBV titers were noted, abnormal T-cell ratios. Unfortunately, sorry, Beth, the CDC did not investigate as thoroughly as was hoped, and the people involved, including Dan Peterson, asked that investigators come and really investigate this epidemic, and apparently it was kind of a cursory job, and at that time, really not enough was done. One hypothesis that I found interesting was, as one of the causative factors, was the green algae in Lake Tahoe whether that had anything to do with the onset of the illness. Okay, now I'm going to, I think these are kind of repeat slides. Oh, okay. So the sequelae that were seen back then in some of these previous epidemics are somewhat similar to what we see now. Sequelae, or in addition, what we call comorbidities. Irritable bowel syndrome, dysbiosis is common. Some of the earlier descriptions of the Punta Gorda epidemic and Royal Free Hospital include descriptions of palpitations and insomnia and other symptoms that sound much like what we call now orthostatic intolerance in POTS. So even back then, there was some hint of some of the comorbidities that we have now better characterized, mast cell activation syndrome, and some others. Unfortunately, we face similar problems now. The prevalence of what we call ME/CFS is really not known. There's some estimates in the U.S. of more than 3 million people affected, but we really don't know in rural areas in particular, and I believe in the middle part of the country, and I'm sure the same is true here in Portugal and other parts of the world. The underserved communities, we really don't know what the prevalence is because the clinicians are likely too busy to really take the time and understand in detail what's going on with their patients, who may unfortunately often be mislabeled as having some psychogenic illness. And so I believe that the rural and the Midwestern parts of the country, in our country, are underrepresented by epidemiological statistics. And once again, certain ethnic groups, African American, Asian, and American Indian people, I think are somewhat underrepresented. And the illness may indeed be more prevalent in those groups. Now, I'm just going to go into a little bit of detail because I found this interesting as time went on after I did these slides. The Royal Free epidemic took place in 1955. And once again, it affected the medical staff, less the patients. So you had about 70% of the medical staff affected with a serious upper respiratory, gastrointestinal, fatiguing, neurological illness. And they had to close the hospital down because there literally wasn't enough staff to take care of the patients. Again, the female prevalence was there. This occurred in the July, spanning the July through November timeframe. And an interesting other fact about some of these earlier epidemics is they tended to occur in cooler climates and not so much in you don't hear much about it in tropical areas. Some theories include the fact that ironically, under less sanitary conditions, infants or babies are exposed to a lot of viral illnesses and gain immunity early on. So therefore, they're protected from getting ME/CFS or something like it later on. So that's one thought as to the underrepresentation of this illness in tropical areas. Anyway, the Royal Free epidemic was characterized once again by upper respiratory symptoms, nausea, and vertigo. Now, I found some interesting differences. Diplopia, double vision, neck stiffness, and tinnitus, which I think we see some of now in long COVID, were some symptoms that were, I think, a little more unique and not so commonly seen in ME/CFS as we know it today, but were described in the earlier epidemics. Similarly, no more slides. And some of on physical exam, so one of the frustrations, I think, for younger clinicians who are new to this area of ME/CFS is that there are, but not really, physical findings in patients with this. So therefore, it can't be real, right? But of course, that's not true. In the earlier epidemics, they found evidence of extensor plantar reflexes, for instance, and some other things like the atypical lymphocytes, abnormal EEGs, and elevated LDH levels, which frankly I haven't seen in the current ME patients so very much. One explanation could be that when we see patients, typically they're 4, 5, 7 years into their illness, so we don't see them in the early acute stages. I'll just take a moment to mention other pandemics over the centuries: the Spanish flu in 1918, Asian epidemic in 1957, the Hong Kong flu in 1968, swine flu, and SARS, of course, in 2003. Not much has been written about the sequelae of these other epidemics, but there must be many sufferers around the world that have what we call ME/CFS as sequelae of those epidemics. So Melvin Ramsey was involved in investigating the original royal free epidemic in 1955. He and others went back in 1990, and this was published in Postgraduate Medicine, and examined those 400 or so patients that they could still get their hands on almost 35 years later. And they found that in some cases, those patients who initially got ill in 1955 recovered, and in some cases they had a relapsing, remitting course, which we still see today in our ME patients, and then some people didn't recover at all. So you have these 3 different sequelae, which I think still holds true in our current population. And many of those patients from the royal free epidemic did demonstrate cardiovascular, endocrine, and central nervous system sequelae as well when they examined them more closely. Once again, 73% were female, and mostly healthcare workers were involved. Relapses were common and were brought on mostly by stressful situations, another new viral infection, or by vaccinations. So in closing, I want to just mention, as many of you are aware, long COVID now brings us, the only silver lining I can think of is that it brings us an opportunity to study the immediate sequelae of a serious viral illness. The differences between long COVID and ME/CFS, the main difference, I would say, is the potential for organ involvement in long COVID. As you know, many patients are left with pulmonary and cardiac involvement, and we don't see that in non-COVID related ME/CFS. And there may be some other subclinical entities that differentiate long COVID and ME/CFS, such as the microclotting, which is often very difficult to demonstrate clinically. Long COVID is also undergoing somewhat of a transformation in terms of case definition. How do we define long COVID? Is it 3 months after getting COVID? 6 months? We really haven't arrived at a complete definitive answer, although a lot of clinicians feel that persistence of fatiguing symptoms 3 months after acute COVID infection qualifies as quote-unquote long COVID. So a lot of clinicians have adopted this long COVID sequelae as kind of a way out, because when patients ask, do I have long COVID? No, you have maybe the sequelae of long COVID, because branding somebody with that can be kind of like a lifetime sentence. So we're still in the investigative stages of categorizing people with the sequelae of long COVID. And of course, I think many of those patients are going to have similar long-term, the natural history is going to be similar to what has been described in these previous epidemics. you're going to have people who recover completely and others that don't and have more of a relapsing, remitting course, and then some people who really don't get better at all. And the other confusing part of this, as many of you know, is that people are often getting second, third, and fourth COVID infections on top of their first infection. And some of the sequelae of the so-called lesser variants are just as devastating as the initial infection. I'll just mention in passing vaccine injury as well. This is being seen a lot and has some overlap in terms of sequelae to actually getting long COVID. So in summary, we've had epidemics very similar to what we call MECFS for many, many years, at least a century in the literature, but there may be even more that we just don't know about, underrepresented, again, in rural areas and in minority ethnic populations. But I think COVID and long COVID now gives us the opportunity to really investigate from the beginning what are the sequelae and how we can potentially prevent some of the serious debilitating effects of this illness. Thank you very much.
Thank you, Susan, for this excellent revision and extensive revision of several pandemics with recorded post-infection syndromes. Before presenting the next speaker, David Systrom, I will tell you that in the hand of these first three speakers, we had a small period of maybe 30 minutes for discussion with all the panel, with questions and answers. And if you don't want to put your questions orally, you have in your bags some cards to do it, okay? You can write your questions, and then they are going to be presented to the speakers. Now, the second session is about the nexus between ME and CFS and long COVID, insights from the NIH Recovery Initiative and the NIH ME and CFS and long COVID comorbidities task force. These presentations are going to be made by David Systrom. He's a medical doctor, PhD, director of the Dyspnea Center and Advanced Cardiopulmonary Exercise Testing Program, BWH co-director, Ronald Tompkins, Harvard ME CFS Collaborative Research Center, and assistant professor of medicine at Harvard Medical School. Please, David.
My man. Thank you so much for the very kind introduction, and a special call out to the organizers of this meeting. Joan Hoffman in particular, who had a kernel of idea that we would do this session when I met her in Boston back in the Ice Age, pre-COVID era, at least 5 or 6 years ago. So this has come to fruition, and I'm very grateful to be able to share some of our findings of our work in Boston. This is also a little bit of a reunion for me. In the audience are several of our co-investigators, some of whom have gone on to greatness elsewhere outside of Boston. In particular, I point out Mario Santos, who's in Porto, and fabulous cardiologist there, did some great work with us in Boston. So it's really gratifying to see some of our work with kernels in Boston grow and propagate to other countries such as Portugal. So thank you so much for having us. When the dean said he looked around the room and spotted people who don't speak Portuguese, I know he was looking directly at me. But obrigado is the one word I do know, so obrigado for the invitation here. So as you just heard, my mission today is to tell you a little bit about a project that was an offshoot of the NIH Recover project. This was a $1.4 billion project launched by the NIH, a U.S. congressional mandate to find a cure for long COVID. And although we've made some headway, it's not been perfect. Several thousand patients have been enrolled in that study. They've been well categorized in several different ways and then increasingly categorized over time with further work, and some randomized clinical trials are just now getting launched. So I'm going to tell you about a little piece of this that we were involved in, and that was an effort to determine commonalities that Sue Levine just talked to us about between ME/CFS and long COVID. And I'll restrict my comments to my world, which is largely the exercise pathophysiology world. So what I'll cover is really two large categories here. One is some, I think, relatively established now notions about circulatory abnormalities during exercise in ME/CFS and more recently in long COVID. We'll attempt to link those. And then I'll end with a session that's really intriguing and late-breaking, and that is the notion that the skeletal muscle mitochondrion may actually be dysfunctional in both diseases and worthy of diagnosis and treatment. Diagnosis and treatment would be very, very different from the vascular abnormalities that we know about. But first, a tiny bit of history. There was a place nearby where we work with an interesting title, given what's come around here with ME/CFS and more recently long COVID, the Harvard Fatigue Lab. And it was actually in the business school along the banks of the Charles River, and they put many of the basic tenets of exercise physiology that we now know to be true on the map way back in the day. I was not part of this, a little before my time. This is what I am a part of, and several of the co-investigators here. This is in the basement of the Shapiro building at our hospital, the Brigham and Women's Hospital and Harvard Medical School. So this is an invasive cardiopulmonary exercise test, and I'm going to introduce it. Several of our speakers tomorrow will rely on this technology, and we'll tell you more about it. But in the way of an introduction, many of you may know about the non-invasive cardiopulmonary exercise test, which involves the mouthpiece in this gentleman's mouth, measurements of ventilation and pulmonary gas exchange. But what's special about the invasive part is two catheters, one in his left wrist, which is a radial artery catheter, and another in his right internal jugular vein and pulmonary artery catheter. And those two catheters, as you'll see, allow us a deep dive into the pathophysiology of these patients, without which, at least with current knowledge, we'd have no idea what was happening. So although it may seem intrusive, our patients are actually quite satisfied at the end of the test. We ask them regularly who is worse, the dentist or us, and 99% of them say the dentist with drilling is worse than what we do. Also, I know there is concern occasionally out there about precipitating post-exertional malaise with this test. I would reassure you that only a handful of probably the 3,000 cases that we've done have had post-exertional malaise that could be linked to this. It's a quick test, 5 or 6 minutes. Only the end is intense. Now, here's an overview of the diagnostic algorithm that we derive both from the non-invasive variables and the invasive variables. And I'm not sure if you can see this pointer. You can. So up here at the top is a non-invasive variable. It's a time-honored number that we get from a cardiopulmonary exercise test to tell us how impaired the patient is. It's the maximum oxygen uptake at the end of the exercise bout. And I'll quickly point out 3 other things that we're not going to talk about today, but they are very useful, and in deference to what Sue Levine said a few minutes ago about long COVID affecting a subset of patients with parenchymal lung disease, they would land here. With cardiomyopathies, the left heart, they would land here. And then occasionally pulmonary vascular disease, probably pretty rare in long COVID, and probably non-existent in pure ME/CFS unless you had a prior abnormality. These things can be ruled out with this exercise testing: lung limit, classic left heart or right heart limits. Where we end up in this diagnostic algorithm are these two buckets in ME and long COVID, as I'll show you, a little bit of a preview. Something we call preload failure. It may not be a perfect term. It's one that we're working on, but I'll tell you why we call it that. And then peripheral abnormalities that may reflect both circulatory abnormalities and possibly mitochondrial dysfunction. I'll come back to all of this. We got in this business about 5 or 6 years ago with the help of Will Oldham, who's shown here. This was our first stab at all of this. We were being referred in an increasing fashion with referral patterns, patients with mystery reasons for exertional intolerance. We couldn't find anything wrong with the heart or the lungs. And when we did this type of testing, what we found was something very different that differentiated them from normal individuals. We have a handful of normal individuals who come to us with exercise intolerance, but we can't find anything wrong with them with the catheters. So this is something we ended up calling preload failure. The thing that differentiated these affected individuals with, yes, dyspnea, but also fatigue and orthostatic intolerance was low filling pressures on both sides of the heart. This is the right atrial pressure, and I would emphasize in the upright position. If any of you are doing supine right heart caths, you will miss this signal. And most important, at maximum exercise, not as apparent in the resting state shown here. So this is the right side of the heart, the filling pressures. They are lower, and these distinguish the impaired from the normal individuals, low VO2 max from normal VO2 max. And additionally, on the left side of the heart, we have a surrogate for the left atrial pressure, the so-called pulmonary capillary wedge pressure that we get every minute during this testing, and it additionally differentiates normal from different. The affected individuals, when we attempt to regress the time-honored VO2 peak or VO2 max and the cardiac output at the maximum exercise against the filling pressures, there was a relationship. The lower the filling pressures in these groups, the more affected the individual, and the way they're affected is a decrease in peak cardiac output across the board. But as it turns out, it's not quite as simple as that, and with the help of Philip Joseph, who is sitting toward the back of the room here today, we took a little deeper dive into the pathophysiology 2 summers ago, where we had an expanded database. We went from about 500 patients in that initial database to 3 times that number. And we looked a little more firmly, as it were, at exercise pathophysiology subtypes. We better defined those patients with ME/CFS. And additionally, we were becoming aware that a fair number of patients referred to us with preload failure had by skin biopsy something called small fiber neuropathy. Small fiber nerves, if you're not aware of them, they've been around forever. They mediate pain, nociceptive fibers, unmelanated fibers. But more recently appreciated is that they also have an autonomic role. And amongst other things, they regulate blood vessel tone and therefore blood flow systemically. So we began to systematically look at these patients in a slightly different way. We divided these patients with well-defined ME/CFS into 3 tertiles of blood flow versus VO2 slopes. So here are the 3 tertiles. Here's a group of normal individuals, I think 16 of them in all told. By definition, we had these 3 tertiles. The interesting phenotype that fell out of this was this group in the red. And this has been defined, or something very similar has been defined in POTS, postural orthostatic tachycardia syndrome, with an upright tilt table test, low flow at the left end in the blue, high flow at the right end. And the high flow is what got our attention here. So they have a higher slope of cardiac output versus VO2 during incremental exercise. They have similar depression of VO2 peak. Their cardiac output is about the same, is a little bit higher than the low flow group. And then the other hallmark of this patient group is impaired systemic oxygen extraction. And I'm going to keep coming back to that term, but what I mean in English, not Portuguese and English, is that this is the ability of the muscle to take up and use oxygen that's been delivered to it, in particular at peak exercise. They all have preload failure. This is ubiquitous in ME/CFS. So this is the group I'll focus on, the high flow group, and I'm going to keep coming back to this measurement of oxygen extraction. This is the arterial oxygen content. This doesn't change in these individuals. This is the mixed venous oxygen content at the end of that pulmonary artery catheter that we're measuring as an index of extraction. I want you to remember, please, the type of blood flow we're measuring with the catheter is pulmonary blood flow. This is the amount of blood going through the lungs, and then we measure how much oxygen is extracted. So what we have found is this subtype with a lot of pulmonary blood flow and very poor oxygen extraction. I'll come back to that in a second. We looked at those who had had skin biopsies for small fiber neuropathy and those who had definite or probable small fiber neuropathy by a single biopsy, tallied up to about 44% of patients. This is very similar to fibromyalgia and very similar to POTS. So we think this is the same animal. One second thought here, just for a second. This phenomenon of high pulmonary blood flow and poor oxygen extraction is the hallmark of left to right shunting. This is ineffectual blood flow that goes out to the periphery of the exercising human being that is not being taken up properly by the muscle, and it goes around and around in the lungs. It's ineffectual. So this is peripheral left to right shunting. These are late-breaking data, and kudos to a variety of our co-workers here listed down below, but in particular Johanna Squires, who's going to present this at American Thoracic Society in a couple of months in San Diego. What we found was something interesting according to sex. So the peak VO2s in females and males in an expanded database of patients, 287 males and 79 males, recent data, has a depressed peak VO2 about 80% across the board, modest depression of VO2 peak. They all have, most of them have preload failure, low right atrial pressures at peak exercise, and there's no sex difference. But if we look at this high flow versus low flow phenomenon, there is a sex difference. Females are much more likely to have this high blood flow at peak exercise here expressed as a percent predicted, and they have a high slope of cardiac output to VO2. So I suggest to you that this is one example, perhaps, of a major gender difference or sex difference that affects the systemic circulation. We don't know the reasons for this. A lot of hand-waving about autoimmunity that Sue Levine mentioned earlier, more predominant in women, perhaps more inflammation, perhaps more microclots, perhaps an influence of estrogen metabolites and even progesterone on the systemic vasculature. So this is something that we hope to pursue. All right, so what about long COVID? So we're informed by Indy Singh, who's shown here. This was a study of a smaller study. He'll present to you a larger subsequent study, I think, tomorrow, of long COVID. So these were patients who were at least 6 months out from their acute illness. They did not have any heart or lung disease, so this is the subtype that Dr. Levine mentioned, without heart or lung disease that could be documented. We had 10 of them, and we compared to 10 normal individuals. And some of this will look frighteningly familiar. This is a commonality, I believe. So VO2 peak is depressed, but oftentimes just modestly in long COVID. The pulmonary blood flow, cardiac output, is actually the same as the normal individuals. And what is wildly different is impaired oxygen extraction peripherally compared to controls. There was probably a type 2 error here. I believe they had preload failure with low right atrial pressures as well. Come back to that in a bit. So this is where they end up in our diagnostic algorithm. Both ME, CFS, and long COVID have elements of preload failure or low filling pressures that are abnormal, and additionally, at least a subset and a predilection for the female sex of impaired systemic O2 extraction. So we would have an interim conclusion here that at play in the exercise pathophysiology of both ME and long COVID is something we would call neurovascular dysregulation because of its association with small fiber neuropathy and these vascular abnormalities. So that's part one. Part two is shifting gears toward the mitochondrion and the muscle. We began to get into this with a couple of other collaborators here in the audience today. This is Mario Santos and Rudolf Oliveira from Sao Paulo, and Katie Melamed, who's now at UCLA in the pulmonary division there. And we basically took our invasive exercise algorithm, such as it was back in the day. We ruled out heart and lung disease, and we ended up identifying a subset of patients whose exercise intolerance appeared to be exclusively due to impaired systemic oxygen extraction. We learned later that many of them had ME/CFS. And this is what they look like with a direct measurement at the tip of that pulmonary artery catheter. This is the mixed venous O2 saturation, which should go down, down, down to low levels, about 28% at peak exercise if you're normal. And these individuals failed to do so. So this is impaired oxygen extraction. We were reminded by the UT Southwestern group, who had a fabulous neurology group doing both exercise and muscle biopsies, that the hallmark of a mitochondrial myopathy, a muscle problem whose major issue is the mitochondrion, is impaired systemic oxygen extraction, shown over here. They were able to quantify back in the day the mutation load of muscle mitochondria, shown here. And the more severely affected shown out to the right here, and what you can see is then there is failure to widen this AVO2 content difference read, more muscle mitochondrial abnormalities, more impaired systemic oxygen extraction. So we began to think that perhaps the muscle mitochondrion was at play and perhaps responsible for some of the oxygen extraction problem, perhaps in addition to left to right shunting. This was reviewed recently by the group at the Griffith University Hospital in Australia. I can tell you what they say at the very end. They reviewed 19 studies in this review recently and concluded we don't know enough about the mitochondrion in ME/CFS. So we've taken a couple of initial stabs at this. One was immediately pre-COVID. We had 11 patients with poor systemic oxygen extraction, shown over here. These are the numbers and their VO2 peaks here, with muscle biopsies from the thigh sent to Baylor, frozen, and interrogated for electron transport chain abnormalities. And all but one of them had something called citrate synthase deficiency. This is thought to be a global marker of mitochondrial dysfunction. So we think perhaps we're onto something. We followed that up with a randomized placebo-controlled clinical study with a company named Astellas from Japan. And we were targeting 40 patients with ME/CFS with poor oxygen extraction. We got to number 32, and the company took an interim look at how well their drug was doing. The answer appeared to be not so well, and we stopped at 32. But along the way, we were able to get muscle biopsy results from 32 patients. And you can see the randomization into placebo or the drug, and here are the baseline values. This is the citrate synthase activity shown here, 61% here, 72% here. Every one of the patients that we recruited with ME/CFS and poor oxygen extraction on an invasive CPET had citrate synthase deficiency. So perhaps there's something there. What about long COVID? I have to turn back to Indy Singh and his paper, and I would remind you that what he found as the hallmark of long COVID in the smaller study was impaired systemic oxygen extraction. So I would hold out to you that perhaps this part of this is left to right shunting, but perhaps the other part is impaired oxygen extraction due to a mitochondrial defect, again, whose diagnosis and treatment is totally different. Last little blast here, this is from a recent study that many of you have, it had great notoriety in the press. This is the Amsterdam group whom I saw present at Santa Fe last fall, and in Nature Communications in December they published this paper on long COVID, and they took several different angles to define mitochondrial dysfunction per se. So they had time-honored VO2 peak. No surprise, it was down a bit in the patients with long COVID. But additionally, they had near-infrared spectroscopy, and I'll just cut to the chase and tell you this is a measure of systemic oxygen extraction in the exercising muscle. It was depressed. Additionally, they did muscle biopsies, and they found an upregulation of fast-twitch glycolytic muscle fibers in the long COVID patients. These are patients without heart or lung disease. So fast-twitch glycolytic fibers not so good for endurance, not fatigue resistant. So you could begin to read fatigue issues there. They also looked at replicate muscle biopsies after inducing post-exertional malaise with prior exercise. They had 2 measures of mitochondrial function, one OXPHOS capacity, and the other succinate dehydrogenase activity. And you can see that in the long COVID patients on day 2 after exercise, but not in normal individuals, there was a depression of mitochondrial function. So mitochondrial dysfunction may play a role in PEM, would be one of the potential take-home messages here. So I would end by saying that both in ME and in long COVID, we have evidence of this preload failure with low filling pressures. We additionally have this potential left to right shunting, but I would add to the list mitochondrial dysfunction. So here's our final conclusion. For those of you who are interested, meaning our collaborators and I, published this paper in a cardiopulmonary journal, Chest, last fall. This covers much of what I've said and more. Here's the take-home message that in ME and long COVID, there's probably more in common than not, at least in the exercise world. So I will end by thanking a few people, Aaron Waxman, who helps us with catheter placement, the aforementioned Philip Joseph and Indy Singh and Johanna Squires, Sarah Alzair, who's one of our young investigators going off to medical school, and then the Mass General Harvard ME Consortium organized by the late Ron Tompkins, Donna Felsenstein, a famous and incredibly talented infectious disease doc. Our computational group was represented here by Wenzong in the audience you'll hear from tomorrow, and a fabulous group also, Montreal, doing transcriptomics for us, Maureen Hansen at Cornell, Jonas Bergquist, whom you'll hear from tomorrow, is the granddaddy of this group, and Ron Davis out at Stanford. A special call out to Linda Tannenbaum and Open Medicine Foundation, whose funding has helped leverage much of this. And I thank you. Obrigado.
Thank you, David. I now ask Elizabeth Unger to present us the public health approach to ME, CFS, and post-acute infection syndromes, experience of the U.S. Centers for Disease Control and Prevention. Elizabeth Unger is a medical doctor and PhD, Chief of Chronic Viral Diseases, a branch division of high consequences pathogen and pathology, National Center of Emerging and Zoologic Infectious Diseases, U.S. Centers of Disease Control and Prevention. Please, Elizabeth.
Thank you very much for the wonderful invitation to be here and this conference. It's very exciting to see this group starting up. So I need to start out. I don't have any conflicts of interest to declare, and I need to be clear that I'm speaking as an individual, and my comments do not represent the official position of CDC. So my outline, I hope to explain to you why I put ME/CFS and post-acute infection syndromes together, and I probably don't have to spend a lot of time on that because the first two speakers kind of made that pretty clear. I'm going to talk briefly about the public health framework for action, some examples of epidemiologic studies, just tiny little vignettes and their contributions. Examples of our education and the importance of partnerships, and then hope to close with just a few closing messages. So first of all, why ME/CFS and post-acute infection syndromes? As been emphasized in the prior talks already, and I think you'll hear it again and again at this conference, A wide variety of infections have been known and recognized to trigger an ME/CFS-like illness, and many patients report an onset following acute illness. But the infection is often unknown or undocumented, and that's why we ended up with this ME/CFS kind of designation. However, there's a striking similarity to the syndromes that follow other known infections: an overlapping symptom profile, a female predominance. They are all chronic, complex illnesses, and the routine tests are often normal. These unexplained post-acute infection syndromes were really just first recognized as a failure to recover from a whole wide variety of infections. We expect most people to either recover or die, right? We don't expect this middle ground of something continuing along. And the core symptoms, you're going to hear these over and over again. They're the same ones: exercise intolerance, activity limitations due to this disproportionate fatigue, neurocognitive problems, sleep problems, and recurrent flu-like symptoms. A wide variety of additional insults or additional symptoms may be present. And some of these are trigger specific, and you already had a little discussion about this. The SARS-CoV-2 may have some certain other things with it. Each kind of infection may have its own kind of specific symptoms. But the net result is a very heterogeneous picture. Even with SARS-CoV-2, known single insult, there are more than 200 symptoms that the patients report. And these chronic complex illnesses really require symptom management at this point because we don't have an intervention. The ME/CFS and post-acute infection syndromes share many challenges. And the biggest one for physicians is the diagnosis relies on the symptom profile and perhaps a temporal association with an infection if it's known. It requires really good medical care, and I think all ME/CFS physicians are excellent physicians because they have to take into account the medical history, the physical examination, and testing, and know when to stop testing, looking for things. Because what the idea is, you want to identify treatable conditions and illnesses that could contribute to the symptoms. There's a lot of overlap, and these patients have many comorbid conditions. Patients all have difficulty finding healthcare providers that understand their illness. And chronic complex illnesses don't fit into our current clinical frameworks very well. There's no approved drugs for therapy, and the clinical guidance remains at the level of expert opinion because there have not been enough clinical trials to make the evidence-based literature. So when SARS-CoV-2 pandemic occurred and COVID was happening, pretty much the community was anticipating that here we go again. There's going to be a long COVID kind of problem. And it's the silver lining, as Dr. Levine said, out of all of this is I think we're coming together as multiple communities recognizing that we share more problems than not, and they could be better addressed together. And so having a clinic that could address all of these conditions would increase the access to multidisciplinary care. And our goal is to empower primary care physicians to at least diagnose and manage these patients, refer them to their appropriate specialties as they need. And clinics could be established that would see the full spectrum of post-infection syndromes and related overlapping conditions. We need to work together to develop case definitions that are appropriate for their use, right? And they could differ between what is helpful clinically and what you want to do for research or surveillance applications. And infection, again, I'm going to say this over and over again, the infection is not always recognized or documented. That doesn't mean it hasn't happened or isn't active. And we, of course, need research to clarify mechanisms of disease. And studies that include all of these groups as comparisons are really essential in order for us to understand similarities and differences. So briefly, public health approach to all of this. We use a lot of epidemiologic studies, and these are done to I guess, primarily document the burden of disease. How much is it in the population? Who gets it? What are the consequences? But we also hope to identify risk factors. That's classic epidemiology, because if you can identify risk factors, that's where you can intervene and prevent. And so that's our goal. And it also generates data that we can use for education and awareness, right? But we need to do this with partnerships, and these partnerships are important to both inform and implement, but it's not, easily separable, because a lot of our partners are involved in the epi studies and work together. And probably our most important partner is those with lived experience. They have so much to tell us. But we also need to partner with other government agencies, and this is both at the state and the local level, as well as clinicians and academics. So a few examples of epidemiologic studies. And one that I want to share with you is results that we recently got from the National Health Interview Survey, and the data is from 21 to 22. And the National Health Interview Survey is given to US adults, and it's representative, and we included a question about ME/CFS. Have you been told by a healthcare provider that you have had ME/CFS? And 1.3% of US adults had ME/CFS, had been diagnosed, and still have ME/CFS in the United States. And again, we see the same female predominance in the population. Now, self-report has its limitations. You have to have had a diagnosis by a clinician. The clinician may or may not be correct in their diagnosis. And so we have those limitations, but it does give us a national representative picture right now of what we can call ME/CFS. We did a very different kind of study, and we called it the multi-site clinical assessment of ME/CFS, and this was conducted between 2012, pre-COVID, finished up sort of abruptly because of COVID. And this was a collaboration with ME/CFS clinical experts in the United States. And we relied on their clinical diagnosis of the patients having ME/CFS. And the little stars are where these clinics were located. And this avoided the bias of a case definition. Now, people will say bias, but if you only look at a certain case definition, you might miss other people. And the question was, do these clinics all recognize the same kind of patients, or are there differences in the clinical patterns? And at the time when we studied, there had been very few multi-institutional studies of ME/CFS, so that was a real burning question. We collected standardized information on all of the illness domains of ME/CFS, and this allowed for cross-clinic as well as cross-illness comparison of measures of fatigue and pain and some of the other things. And the data was also used to inform the 2010 IOM case definition. As a result of this, we were also able to share how our questionnaires worked, and it supported the Common Data Elements Project that is a collaboration with NIH, CDC, and internationally. And we plan to have the biospecimens and data shared through the NIH-funded platform of Map ME/CFS and Search ME/CFS, and this will be a resource for investigators. Shifting again to another project, we collaborated with the Emerging Infections Program at CDC. And this is a relatively high prestige program. So anytime we can get ME/CFS into programs that are recognized, it is really important. And we included an ME/CFS project that was designed to be a syndromic surveillance of fatiguing illness. Our goal was to try to understand the early phase of the illness. And as Dr. Levine said, most patients come very late in their illness, so we didn't have a good view of what happens early on. Now, we didn't know that the pandemic was coming, but the pandemic has now given us a whole lot of early cases. And so The study was rapidly modified to include COVID, post-COVID ME/CFS-like illness. The goals of the study, which we call STOP ME/CFS, is surveillance to optimize protocols for early identification and subgrouping. And it is in collaboration with the California Emerging Infectious Program site, as well as Kaiser Permanente Northern California. And the Kaiser representation is really important. It's a very big managed care organization in the United States, and it has really helped focus their thoughts on ME/CFS and how to really care for these patients. And so we have a view of ME/CFS in a managed care organization like Kaiser. And through a sampling and survey approach, they identified that 1.7% of their population met criteria for ME/CFS. And of those, the majority were diagnosed and were not from COVID. Examples of education and partnership. And this is one of our favorite projects. It's the Long COVID and Fatiguing Illness Recovery Program. And we call it LC and FERP. We couldn't come up with a shorter, cooler name, but we tried. It is a contract with the Family Health Centers of San Diego, which is a federally qualified health center. This is in the United States, sort of a clinic, safety net clinic. People that don't have health care insurance, they provide services and care for. And the goal was to evaluate a multidisciplinary team approach to delivered via telemedicine to see if this could improve care for patients with long COVID, ME/CFS, and post-infection fatiguing illnesses. And when we started this project, the focus was on the long COVID. And the federally qualified health center said, yes, okay, sure, we'll include ME/CFS, but we really don't see those patients. After about 6 months of the program, they realized they do see those patients. And so it's, again, once you start thinking about it and looking about it, there's so much to be learned. And our goal is to empower primary care providers in these safety net clinics to provide care. And if we can do that, that will amplify and improve access to care. And so this was organized actually as a clinical trial, a demonstration project, because while everybody believes Project ECHO and telemedicine is going to make a big difference, having data to show that it works is, of course, what we want. And so it's organized to have 3 components. The first is a weekly case-based ECHO session, and this is kept only to the providers that are enrolled, very small. A provider presents a case, and depending on the case, then the ECHO program invites a didactic lecture and a panel of experts to discuss the case and help. And so this weekly session needs to be very small and intimate to allow trust and sharing. Then there's a monthly ECHO webinar that's open to everybody, and these are didactic sessions followed by question and answers, and the recording and resources are available to all. And there's finally quarterly courses that offer continuing medical education, and these are also open to all. Each of these are available for 12 weeks. And the comparison for the clinical trial is to look at the patient outcomes of the patients cared for by providers who either were randomized to the weekly ECHO, the webinar, and the course versus only the webinar and the course. And in addition, the outcomes at the clinic are going to be compared to specialty clinic at the University of Washington. And what we learned very much so from this project is the ME/CFS experience really helped the project. The lived experience experts were included in absolutely every session, and they made a tremendous difference in helping the clinicians understand from the patient's point of view what the patients were going through. They shared their experiences and were able to identify with the problems that the long COVID patients were experiencing. And it really shifted this to be a very patient-centered dialogue. The clinical consultants that all volunteered their time, and we had a tremendous outpouring of support for this, were able to right away emphasize the importance of avoiding post-exertional malaise. And that's something that's often hard to get across. And then they noted that the triggering pathogen is often not known or documented. They shared information on diagnosis and symptom management that they learned from MECFS, and this is available through the MECFS Clinician Coalition that has a very nice website. And they suggested inclusion of the nasal lean test as a way to screen for postural orthostatic hypotension. Another shift now to our Medscape collaboration. Medscape in the US is a really important provider of medical education. They are able to target their advertisements and their educational delivery to their different audiences, and we've asked them to focus on primary care providers. And so we support Medscape to develop the CMEs, and you can see they've picked some really good people like Dr. Systrom and Dr. Bateman. This is our current one that's up. We've done several with them, and this is a much bigger outreach than if CDC created its own content. But CDC does create its own content, and this is available on our website, and we hope that it's useful to people. We have, these are just several of the pages. We have toolkits for patients. We have information targeted for healthcare providers, including their resources for medical students, and as well as a special section on MECFS in children. And I will tell you, those web pages were very controversial, and they only got really well put together through partnerships. We achieved this through a series of roundtable meetings, 2016, 2018, and then in 2021 we had the last one, and that had to be virtual because of COVID. The other ones were in person. And before the meeting, the contractor had facilitated small group discussions to really focus what the questions were and people's opinions. And even in the small group discussions, we were sure that we had differing points of views, right? We made sure it wasn't all patients or all caregivers or all clinicians or all government. It was a whole variety. And this broad representation in small dialogues really made a difference, because the conversations and the discussion really started to allow people to understand differing point of views and why they may be. And we all need to work together. And so, just my closing messages. MECFS and post-acute infectious syndromes remain poorly understood complex illnesses. First and foremost, clinicians need to listen to and believe their patients. Increased awareness and progress is urgently needed in all of these areas, because inability to find health care from providers with an understanding of these illnesses still remains the biggest problem faced by the patients. And progress requires multifaceted collaboration and everybody working together. Illness heterogeneity is a key feature and very inherent in these illnesses, and we can't underestimate the complexity of this. This means that individualized care plans are helpful, and standardized measures of illness characteristics are encouraged to help stratify and focus research questions. And last but not least, the people with lived experience provide invaluable insights and need to be included at every phase, from the beginning of a research project through the end and interpretation as well. So thank you very much.
Thank you, Elizabeth. Now I invite you, both three, to come here. And
we sit.
Please be seated.
Okay.
Susan and David also. And we have now 15 minutes of discussion of those three talks. Anyone on the... Oh, okay. I didn't see.
I don't know if I have the microphone or... My name is Biobank. I'm from Portugal. I would like to ask Professor Systrom, and I thank you all for your excellent talks, about the role of CPAT in the management and evaluation of these patients with long COVID. So do you think that we should all do invasive kind of CPAT, or do you think that, at least as my knowledge, the two-day kind of consecutive two-day CPAT is also an important evaluation for this patient? Could you expand a little bit more on these two-day CPAT? How we can do that on our clinical, real-world kind of data? Thank you.
Sure.
No, no.
If this is on.
Okay.
Is it on?
Yeah.
Great. Thank you for the question. The good news for Porto is that you have Dr. Mario Santos, who is setting up invasive CPAT as we speak. So I think that's wonderful. But having said that, I don't think it's for everyone. And I think it really does inform us about the disease and allows us to identify subtypes, as you just heard from Dr. Unger, to perhaps create some precision medicine. But I don't think it's scalable. It's not for everyone. So the two-day CPAT has evolved, I think has been blessed by the CDC. Back in the day, the Betsy Keller Ithaca protocol. So it's non-invasive, and for those of you who aren't aware of it, it's 2 days of day one does an incremental non-invasive CPAT measuring VO2 peak, heart rate, anaerobic threshold, ventilatory anaerobic threshold, and then repeat on day 2. And that's an effort to capture post-exertional malaise, which is probably the most specific amongst our symptoms for ME/CFS. And a subset of long COVID. So I think that is much more scalable. We do in Boston sort of a modified, and Yale progeny as well, a non-invasive test that's very simple. I own no stock in this. It's called SHAPE. It's a 3-minute step test with a metabolic cart piece, very similar to the non-invasive portion of what I showed you. And it gives you many of the same variables. We're actually using that in a planned randomized clinical trial called LIFT, which is funded by the Open Medicine Foundation in ME/CFS as a major outcome. But that is very scalable. It's something one can do in a primary care office. The metabolic cart costs about $40,000 US. But I see that as having huge potential. Thank you.
Thank you. Well, I remember that you have, if you don't want to put it questions orally, you have in your bags small cards, and you can do it by right. Please, Dr. Dora. Thank you. Microphone.
Hi, my name is Dora. I'm a physician, and first thing of all, I'm very pleased to be here, and I want to congratulate all of you for this excellent initiative, and I think it's the best that can happen here in Portugal, because as a physician and as a patient, I'm with a long COVID. I think all in Portugal, here in Portugal, we don't know anything about long COVID and the consequences and the sequelae that this may happen to all of us. And as a physician, and I've been 3 years in the front office of long COVID, assisting to patients. I have 5 times COVID, and I have a long COVID now. I'm asking you, I think it's for you, sorry for my question. It's a question that I think all of us that deal with patients after long COVID and after COVID simply. I didn't heard you mention a manifestation that the COVID by itself has in the heart, the myocarditis and the pleural effusion. It's a complication very dramatic for the patient and for us that deal with that and have to have answers for our patients. You told us about a complication, like the effort, that it's not measurable by echo, simply echo. Correct me if I'm wrong. And when the patients went to the cardiologist, they don't find anything. Okay, you are tired, but it's not by the heart. The heart is no offended by the virus. And when the patient accidentally has a myocarditis, okay, the heart is done, the heart is harmed. And when they are pleural effusion, okay, the heart is harmed. But there's no way the tired, the fatigue, there's no way it's the heart. How do you explain that complication if you know something about it? We heard and we learn a lot with the papers that is published, like it's a spike protein, it's similar to the COVID, that it's a reaction, autoimmunity, a long response, inflammatory complication, but this sounds like, what's your name, sorry? Unger said. Someone recover rapidly and others have recurrences. And these people with affecting the heart, with myocarditis and pleural effusion, probably they don't ever recover. And this is probably the complications. And there are other complications that we saw, the eyes. Yes, COVID, the neuropathy of the COVID in the eyes, it's a target also. Eyes, hearts, and pulmonary complications, and neuropathy complications. Sorry for all of these questions, but I think we have all of this.
Who is going to? David?
Sure, Dr. Levine would love to chime in. Do you want to go first?
You go ahead.
Okay.
Just approach the microphone, yes, please.
Better? Okay. So, no, you had a lot of good questions, really good questions, and obviously, no pun intended, from the heart as a person with lived experience. So we get all of that. My mission in my 20-minute talk was not to cover all of long COVID. It was to point out some of the things that we have found that are common to ME, CFS, and long COVID, in particular in the exercise world. And I think it was said a couple of times by my co-speakers here that what is common is not inflamed heart and pleuritis in the two diseases. That would be particular to long COVID. So anyway, but good questions, and we're happy to try to field them. I think that our approach to both diseases really is to rule out everything under the sun. And the papers, 3 of them that I presented today, buried in the methods, was doing exactly that. And part of it is the invasive CPET helps us do that. I rule out left heart disease with things like pulmonary capillary wedge pressure, and I rule out pulmonary hypertension. But that isn't the entire story. I think the patients that we're seeing, we do the time-honored history, physical exam, routine labs, and with cardiomyopathy, cardiac markers like troponin as a screening test. And you do that all up front. And the patient population I was focused on was where those things are all negative. So, but there is a ton of discussion to be had about your other questions and, you know, what drives long COVID, what drives the subset of patients with heart disease and pleuritis, what's their prognosis, et cetera. But I'm going to turn to Sue Levine, who's seen 8 billion more patients than I have, and she may have a comment.
Yeah, very well said, David. I mean, I feel that irrespective of organ failure, that the fatigue can be caused by the pro-inflammatory cytokines that are obviously secreted. I call it like a low-level cytokine storm. That term was in popular use right after COVID hit, that people in the hospital were in cytokine storm, but I feel that the long COVID folks have elevated pro-inflammatory cytokines. And of course, that can account for some of the prolonged fatiguing symptoms. In addition, the endotheliitis, which is some of the vasculature, is impaired. And again, that's also kind of a pro-inflammatory type of thing. I think probably at play are other major systemic abnormalities, such as the hypothalamic pituitary axis, diminished cortisol responses, and neurotransmitter impairment, such as low serotonin levels, all of which, can cause prolonged fatigue in these patients.
No, okay. I have now two questions. One is, can we get the CDC materials or resources in Portuguese? For example, Medscape in Portuguese? Or, well,
I think mine's still on.
It's a very tricky question, but
Right.
well, it's
Well,
not
that would be
mine.
wonderful. That would be wonderful. We did translate them into Spanish for our population in the U.S., but we would need assistance probably. But that's if you need them and want them, I think that's definitely doable. Yeah.
Oh, thank you.
Yeah.
And also for you, Elizabeth, what precautions should I take to be able to do activity and not have pain, fatigue, brain fog, and diarrhea? It's one of
I can't answer that one completely. I would say that the precautions that the patients have learned over and over again it's very hard to live with, but they need to understand themselves. And I've had different people explain it different ways, thinking of an energy envelope or a certain amount. They have a certain bag of pennies, and they can spend their pennies only a certain way, and then you're out, right? And then you go into debt, and that's when you run into trouble. So it is this pacing is another way of phrasing it. It's very, very difficult to implement because particularly with the disease being relapsing, when you have a good day, it's natural to want to go. And that introduces the problem of sort of the next day crash. And so you want to try to avoid that, and it really is the best answer that we have. Now, as far as the dysbiosis or the irritable bowel, that's a poorly understood even condition all the way around. People are hopeful that understanding more about the gut microbiome may help that, but it could also be an autonomic problem. So we don't have really good answers. I'm very sorry.
We have not complete answers, of course. Any other question? If not, okay. Last question. We are just in time for one.
This is for
question, please.
This is for Dr. David Sistrom. So you're talking about the high pulmonary blood flow and the low extraction groups. I was going to ask if there's two things you looked into. Oh, sorry. Okay, this is better.
Okay.
Yeah, sure.
Repeat it, please.
Okay, so the high pulmonary blood flow, low extraction groups. You're saying about peripheral left to right shunting. Were they tested for a partial anomalous pulmonary venous return?
So great question. I did not say, but all of them at the time of their resting right heart catheterization have what we call saturation run. So we look at the SVC saturation, the right atrial saturation, right ventricle, and the distal pulmonary artery saturation. So there we are looking for intracardiac or partial anomalous venous return would be loosely included. Any evidence of intracardiac shunting, and we never find it. But great question.
If there are no more questions, we are going to have now another. The very last question, okay.
Last one. Another one for Dr. Systrom. Besides the mitochondrial myopathy, are there other conditions that seem to have the similar results? And I'm also wondering about deconditioning. How does that compare?
So really good questions. Impaired systemic O2 extraction, I'm going to try to answer both questions with one answer. Impaired systemic O2 extraction, interestingly, is not a feature of simple deconditioning. And that was shown way back in the day with our Scandinavian colleagues at the Karolinska, putting athletes to rest and doing replicate invasive CPETs. And the major feature of detraining is a decrease in left ventricular end diastolic volume, stroke volume, cardiac output, but is not systemic oxygen extraction impairment, strangely. And that's been replicated. Peter Wagner has done a nice review of that in the last 10 years or so. So deconditioning, though, affects every chronic disease that I've ever met, and it sure doesn't help things. What's unique, of course, with both ME and a subset of long COVID is post-exertional malaise, and we address those issues. We don't have the great answers for that. Honestly, and I know this is intensely controversial, hand up here, we do not simply send people back to the gym and tell them to work their way out of it. That won't work. Everybody in this room knows that. Our hope is that we can properly medicate patients, get them to a place where they can resume more activity and eliminate at least part of the deconditioning confounder.
Well, thank you for your questions and, of course, for the speakers. And now we are going to have pause for coffee and refreshments. I don't know where is the site. It's right there. Okay, thank you. And 30 minutes we are coming to this room again. Okay, thank you. Thank you very much. Thank you so much. Thank you. It's great to be here. And good questions, too. Yeah. You can put it here, David. Okay, thank you. Perfect.
os cartões de perguntas que estão ali que nós podemos entregar.
Ok.
E depois vai-se recolher no fim.
Ok. We are now going to reinitiate this scientific session, and I remember the cards for the question in your bags, and if they are not in the bags, because I think the first bags were not equipped with those cards, you have it in that table, and Ines can give it to you also, okay? Now, we're going to initiate the second session, and Lucinda Batman is not with us, and she taped previously and personally a video which is going to be presented to you. Lucinda is MSMD, medical director of Batman Owen Center in Salt Lake City, Utah, United States of America. And his speech is about COVID-long hours, presentation of long COVID and post-viral syndromes, common comorbidities of long COVID, and the design of simple treatment plans.
The invitation to come speak. What a great conference. Some of the best people in the world have gathered here. I'm going to share with you today more of a practical approach from the perspective of a clinician, but let me begin with just a few slides. But we really, at Bateman Horne Center, we do some clinical trials, but we will not be discussing them in today's presentation. And I'm not going to tell you too much more about Bateman Horne Center, but we are a nonprofit organization that does clinical care research and educational resources, specifically for people with ME/CFS, fibro, long COVID, and related comorbid conditions. And I'm hoping by the time I finish, you will recognize the presentation of long COVID and post-viral syndromes, identify common comorbidities, and design simple treatment plans for individuals with long COVID and related comorbidities, specifically through the lens of ME/CFS. So we know that SARS-CoV-2 can impact almost every organ system. And this has been our journey in medicine to understand more about acute COVID. And now we're really trying to understand long COVID. And there are really two main groups of post-COVID conditions. The people who had severe infection, often hospitalization, organ damage, and a lot of objective markers. But there's a growing number of people with mild to moderate infection initially, but lack of recovery or even increasingly worse symptoms and impairment, yet without apparent biological markers. And this group can easily be overlooked and more confusing. Because there's so many names and definitions of post-COVID conditions, I'm going to use the term long COVID, and I also want to talk primarily about group 2 today in my talk. What causes long COVID? That much is still unclear, and I think you'll hear a lot more about causes and physiologic manifestations in the conference today. And so I'm not going to delve into too much what the causes are, because we already know many things about post-viral syndromes and comorbid conditions, but especially from studying ME/CFS. And ME/CFS, in case you're not familiar with it, is myalgic encephalomyelitis. And in the US, we often combine the old-fashioned term chronic fatigue syndrome with the term ME, or myalgic encephalomyelitis. From what we know about this illness, it's a chronic, complex, debilitating multi-system illness that involves the brain, the peripheral nervous system, the immune system, the circulatory system, and there appears to be impaired cellular metabolism. Now, this illness manifestation is often a post-viral or post-infectious syndrome, but diagnosis is typically made late or ever, and thus the evidence of the acute infection gets lost. And diagnostic studies of common potential pathogens were not always done at illness onset. And immune triggers can also be associated with the onset of ME/CFS. So this is challenging for clinicians. We know historically that ME/CFS specifically can be triggered by a variety of pathogens, certain viruses, and I've listed a number of viruses here that can be culprits, including earlier coronaviruses, SARS-CoV-1 and the MERS virus, before we have our acute COVID-19 outbreak. But post-infectious syndromes have also been documented after Giardia, Q fever, Lyme disease, and others. And like I said, ME/CFS is frequently diagnosed very late in illness or never diagnosed or misdiagnosed. But we know that people with ME/CFS, although it's a heterogeneous condition, share the same core or common symptoms, likely due, but the heterogeneity may be due to the systems affected, how long they've been ill, the development of comorbid conditions. And it's been challenging to study. But with long COVID, we have the opportunity to look at illness in the first stages of illness, and when we have a much better idea of what the pathogen was that triggered it. So let me teach you about the U.S. National Academy of Medicine ME/CFS clinical diagnostic criteria. They're mostly used within the U.S., and there are other criteria for ME/CFS or for ME, but these have proven to be really clinically useful criteria for physicians. So in order to make a diagnosis, a patient should have these core first 4 to 5 symptoms. They need to all be present, and they must be moderate to severe and frequent, which is defined as present greater than 50% of the time. That is impairment of normal function, accompanied by fatigue, at least 6 months in duration, post-exertional malaise, which I'll talk about a little more, and those two are very, very important. Then unrefreshing sleep or problems with sleep, and at least one of the following: cognitive impairment or orthostatic intolerance. Those are the core symptoms that need to be all there, moderate to severe and frequent, these are the shared characteristics of people with this illness complex. We know there are other features that are a little more not as universally present. Those are chronic pain conditions, immune and inflammatory manifestations, infection manifestations, and what have been called neuroendocrine manifestations. These are common and can be really problematic in patients, but are less consistent across the whole patient population. We distinguish ME/CFS from other post-viral syndromes by the amount of impairment or debilitation and the development of post-exertional malaise. So post-exertional malaise is illness relapse or symptom worsening triggered by activity or stressors. And these stressors can be physical, cognitive, sensory, emotional, or even being in the upright posture. PEM and impaired function occurs in many patients with long COVID as well, and many of those patients meet ME/CFS criteria. And at least in the ME/CFS patient population, illness severity and functional capacity ranges from mild impairment but difficulty maintaining a normal schedule of life and low tolerance for exercise to bedridden, barely able to speak or move. And we call those patients the severely ill or the very severely ill. There are important comorbid conditions to consider in long COVID and ME/CFS beyond the objective organ damage. This is a list of those comorbid conditions, and I'm going to focus more on the ones in the box, but cognitive impairment, orthostatic intolerance, mast cell activation, small fiber neuropathy, which is damage to the tiny small nerves that are involved in sensory perception and the function of the autonomic nervous system. There are many disorders of sleep and disturbances of sleep, as well as primary sleep disorders. There may be upper and lower gastrointestinal symptoms and dysbiosis. But for sure, in my opinion, and in the opinion of most people who study post-viral syndromes and ME/CFS, if the symptoms in long COVID persisted 6 months and meet established criteria, you should make a diagnosis of ME/CFS. It can be post-COVID or post-SARS ME/CFS. So let me just give you a very practical approach from a clinician who has taken care of ME/CFS patients for a few decades now, and add some of the insights that I have gained in the last 5 years taking care of ME/CFS, but also in seeing long COVID patients. So this is my approach, and I'll give you a little visual of it in a minute. It's a pretty simple formula. And this is in the absence of targeted treatments that are going to cure the disease. So first of all clinicians should be able to do this. So first of all, identify and treat all medical conditions that you can see as part of the presentation. Second, and probably primary for the illness, is learn to pace activity. That means reduce the severity and duration of post-exertional malaise by reducing the duration and the intensity of all activities that might trigger post-exertional malaise, and teach the patient to do this so their symptom burden comes down. Next is to address the major symptoms of the illness, and on top are sleep, pain, mental wellness, and a little bit about fitness, but only if it doesn't cause post-exertional malaise or worsening of illness. And then I want to talk about targeting 2 of those common comorbid conditions, because these are the ones that are the most often missed, and yet they can respond to supportive treatment. And here's my diagram of this that I've used for many years. So up in the top left corner is you've got to pace your activity to avoid worsening of illness, pain amplification, worsening sleep, a crash, and worse energy. And so the 3 table legs are in front of those major symptom categories, and those determine the stability of the table and the functional well-being, which is on top. And in smaller print in the back, and the leg you can't see, is fitness, because fitness is only achievable to a degree depending on the severity of illness. Well, now we know that there are at least 2 other comorbid conditions that are overlooked, but are commonly present, and even more commonly in long COVID than what we've identified in long-standing ME/CFS patients. So how can you learn from your patients their level of impairment? Impairment function is quite difficult to communicate, and it's hard to measure. So I'm just going to give you 2 easy things to remember that we use in clinic that really speed up the ability to estimate people's function. And the first is to determine the patient's hours of upright activity. And this, we're defining for this purpose, that's the total number of hours with your feet on the floor in 24 hours. Now that includes sitting in a chair with your feet on the floor, that's upright, standing and walking. Probably includes driving, sitting. So it's all the hours where you're not lying in bed or having your feet elevated. And normal people have, generally 14 to 17 hours per day of hours of upright activity. Lots of people with chronic illness, including chronic pain conditions and other chronic illnesses, still have 10 to 12 hours of upright activity tolerance because they rest in sitting position. But people with ME/CFS, orthostatic intolerance, and POTS, and similar conditions often will report 0 to 8 hours of upright activity tolerance. And even people that are really quite functional with ME/CFS might report 8 hours of upright activity tolerance, and that is not quite enough to maintain a full-time employment. So they often, if they're able to work, they do it by building in rest periods or work from home and other things to be able to do it. Of course, you have to rule out severe depression as a cause why people just want to stay in bed and pull the covers over their head. So remember this, how we define this. And the other we use is a simple, what we call the good day, bad day questionnaire. And I actually have people just fill this out on a computer, or we used to do it on paper. And that is, I have the patient, this is spontaneous answer from the patient, to give us the average number of good days and bad days per month. Just divide them up. Like, I have 10 good days and 20 bad days per month on average. And then I asked them to estimate their average hours of upright activity on a good day and on a bad day, using that same definition we just talked about. And then I have them give examples of tasks or activities they can do on a good day and can do still on a bad day, and give examples of activities or tasks that you cannot do even on a good day, and you for sure cannot do on a bad day. And you know, I don't coach people very much about how to fill this out. They write it, and then I look at it, and it gives me an immediate picture of how impaired they are. And also if they're having push crash cycles, you know, if they have, but it also helps me understand kind of their window of function of what they can do and can't do. And it's usually very, very helpful and educational for understanding right away a person's function. So let's talk about some of these comorbid conditions, and let's start with orthostatic intolerance. And what is orthostatic intolerance? So this is the definition. Orthostatic intolerance is the development of symptoms in upright posture that are relieved or improved by reclining. It's actually a symptom, and it's an observation. There are ways, and if you need to ask people about this, they need to help them understand what you're asking. But once they understand what you're asking, and this is part of hours of upright activity, right? And ask them if their symptoms are better if they lie down and get worse the longer they're up. And you can have a lot of different symptoms from orthostatic intolerance. So there are ways to objectively measure syndromes of orthostatic intolerance. And we have names for them, orthostatic hypotension and POTS, and we'll talk about that in a minute. But we've tried to use a standardized 10-minute passive stand test that we've dubbed the Nasaline test. And the way to do this test in the office is to record heart rate and blood pressure after 10 minutes of supine rest. So get the patient really relaxed on a table near a place where they can stand in a few minutes, and take the blood pressure and heart rate a couple of times while they're lying down. Then have them move to a standing position. We use the passive stand test, which means you lean against the wall. We think it's safer for patients in case they feel more confident that they're not going to fall down. There's lots of debate about whether to use a passive or an active stand test. But once they're in that standing position, use a pulse ox and a blood pressure cuff and record the heart rate and blood pressure every 1 to 2 minutes. It's trickier to do it every minute. I like to do it every minute, but you can do it every 2 minutes for at least 10 minutes, unless the patient cannot stand any longer due to feeling lightheaded. Then you have the opportunity to interpret this test. So let me show you one example. This is a real patient who came in. He was age 45 when we first saw him. He'd been sick since COVID for 7 months. He did not have a diagnosis of when he came to see us. We did this, you can see the lean test here. So here are his 2 supine blood pressures at the top. 115/75, his heart rate was in the mid 60s. And then after he'd been there for 10 minutes and rested, we have him stand up and lean against the wall. You can see that his blood pressure stays pretty good, but his heart rate immediately jumps and keeps climbing and climbing. It was 103, 115, and around 7 minutes, it was 120, and then right when he was about to faint, it got to be 138. And you may not be able to read this over here, but he was very symptomatic. We terminated the test early and laid him down so that we didn't induce syncope in him. So this is a pretty extreme but real example of someone who developed postural orthostatic tachycardia syndrome, which is defined by a heart rate increase of at least 30 beats per minute in the standing position, or a heart rate that goes above 120. This is another patient. She was in another state, and was contacting me for advice. And I asked her to arrange to have someone and do a 10-minute NASA lean test in her home. And this is what she sent to me. So her supine blood pressure was 124/68. And as soon as she stood up, you can see her blood pressure dropped tremendously, all the way down to 80/64 at 8 minutes. And she was actually did not feel syncopal or like she was going to faint, but it did reproduce her symptoms. You can see that her heart rate went up, but not to the extent that you see in POTS. And I also wanted to point out that you can use the pulse pressure to estimate what's happening with cardiac output as a sort of a surrogate. And you can see her pulse pressure, which is the systolic pressure minus the diastolic pressure, was 56, which is pretty typical. So the difference between 124 and 68. And at that time, she was about to faint. Her pulse pressure, or that, she was getting symptomatic. Her pulse pressure was 16, which is quite low. And there's actually a formula on the bottom. If you calculate the pulse pressure over the systolic pressure, it should be more than 25%. And hers was 20, which really suggests poor perfusion in this case. But she met the criteria for systolic orthostatic hypotension because her blood pressure dropped more than 20 points in the first 3 minutes, her systolic blood pressure. So knowing this is really important because, and this was a real healthy 70-year-old woman, we were able to, in the box, teach her about pacing and about awareness of body position, increase her fluids. We gave her primary care gave her something for sleep and a little bit of sertraline for her anxiety. And she really did quite well. And it didn't take much, but it really improved her ability to function to give her these tools. So very quickly, I don't have time to do a whole lecture on orthostatic intolerance, but it's pretty straightforward. If you recognize the common exacerbating factors, heat, dehydration, being up too long, muscle atrophy, even laying in bed too long can worsen it. There are some medications that might be making it worse. And if you're in post-exertional malaise, it can get worse as well. You can increase volume in the blood vessels with water or medications like fludrocortisone, and IV fluids can be very good at rescue when people are sick or not doing well. You can externally compress or internally constrict blood vessels. So compression, socks, pants, abdominal binder, and midodrine is a drug that is a peripheral alpha-1 receptor agonist that acts like compression. Other interventions for orthostatic intolerance include controlling the rapid heart rate response, if it's indicated and helpful, and strengthening the muscular pumps in the legs, or altering autonomic nervous system function with a drug that is used not as frequently, but pyridostigmine, which can improve blood flow in the legs and has other functions as well. So there's a lot of information out there about how to treat orthostatic intolerance syndromes, especially in the POTS literature. So I would send you there. So what about mast cell activation? What is that? Well, mast cells, just a little background, are white blood cells in connective tissues all over the body: skin, blood vessels, lymph, nerves, lungs, GI tract, all the places where your tissues interface with the outside world. And when activated, mast cells release inflammatory chemicals as part of their job. And when they are activated, they send distress signals through the nervous system, the immune system, and do a lot of signaling with all kinds of cells. So many people are familiar with more genetic variety of what we call mastocytosis, and we're really not talking about that right now, genetic or tumor related. We're talking about just activation, mast cell mediator, excessive mast cell mediator release. And an extreme example of this is anaphylaxis. So the criteria for mast cell activation, and you can look these up too, are really episodic symptoms in 2 or more organ systems: skin, gastrointestinal, cardiovascular, respiratory, nasoocular. improve symptoms with things that calm mast cells, like H1 and H2, or histamine 1 and histamine 2 receptor antagonists, leukotriene antagonists, mast cell stabilizers, and other supplements, and even anti-IgE biologics if they're available. The third set of criteria are elevation, if you can find objective markers of these inflammatory molecules in the blood or in the urine. And if you find them, that's great. But sometimes, especially when symptoms are episodic, it's difficult. So if you have a clinical suspicion of mast cell, you can try mast cell interventions to see if it's going to help symptoms. So just to remind you, I'm hoping that you'll be able to recognize the presentation of long COVID and post-viral syndromes, especially ME/CFS, identify common comorbidities, especially the ones that we don't talk about often enough, and design simple treatment plans for people with long COVID and related comorbidities, especially having a new recognition of ME/CFS. So I think there are some questions.
Hi, yes, excellent presentation. We've got several really great questions from the chat. The first received from a Portuguese internal medicine physician who has begun to see several patients with ME/CFS and ME as a result of long COVID. The question: we desperately need more clinical training and information in Portugal. What opportunities are there for further health professional education exchanges on ME/CFS, long COVID, and related disorders? And the second question pairs really well. It's received from a medical student about to graduate, asking for resources and how to incorporate this teaching into the medical school curriculum.
Those are really great questions, and I think we're all over the world trying to understand how to get more information in professional education, and out in the trenches, in the field, and for medical students. I left my slide up a little bit longer because at the Bateman Horne Center, we've been working hard to figure out how to get medical education out there. And we have a lot of resources on our website if you can reach it from Portugal. And there's information there for patients and a lot of information for medical providers as well. I also wanted to point out that there's something called Project ECHO in the United States. And this is an online case-based lecture series. And I put up 3 of these ECHOs that are available specifically for long COVID. And the last one is one that we've been involved with, the utah.edu ECHO long COVID. And if you can figure out how to go to these links, there are lots of recorded lectures about various aspects of long COVID. And this one on the top, the one that ends in SILC, is an international one, and some of the recordings are in Portuguese. The last thing I wanted to mention before I close is, throughout the pandemic, there have been pretty good consensus guidance statements issued by PM&R, which is the Physical Medicine and Rehab organization. And the name of the journal is PM&R, and it's posted on the American Academy of Physical Medicine and Rehab. I couldn't figure out how to get a short link, but if you go to this link, you come to the section in their journal that is specific consensus guidance that covers probably, I think they may have 6 or 7 guidance documents that are very useful for understanding the presenting aspects of long COVID. So thank you very much for an opportunity to join in this great effort, and thank you for planning such a great conference. And if we can be of any help with education, please let us know at Bateman Horne Center. But I just think the more we try to teach each other, the better we'll be, and the knowledge is growing rapidly. So good luck, and thank you so much.
Thank you, Lucinda, for your effort to be with us in this so important meeting. And now I asked Luís Nacu to deliver his speech on treatment of ME, CFS beyond the NICE guidelines on diagnosis and recommendations from Europe and North America. Luís Nakul is a medical doctor, PhD, at the University of British Columbia, London School of Hygiene and Tropical Medicine, and BC Women's Hospital. Luís, please. I think you need this.
Eu acho que não vai dar para conectar, eu vou passar os slides. Obrigado. Good morning, boa tarde. Me ouvem bem? Ok. É um prazer, um privilégio estar aqui presente. Eu queria iniciar agradecendo os organizadores, em especial Dr. Jaime e Joanne. Essas são nos logos são as instituições que ajudam a pagar o meu salário e dão apoio à pesquisa. Nessa apresentação, eu vou iniciar com uma breve introdução dos critérios clínicos ou definição de ME/CFS, assim como alguns aspectos da epidemiologia. Eu vou, então, apresentar alguns critérios clínicos ou diretrizes de tratamento que foram recentemente desenvolvidas, para, então, apresentar alguns aspectos práticos que surgem como consequência dessas diretrizes antes de eu concluir. ME/CFS, ou encefalomielite miálgica, é definida clinicamente. O diagnóstico é clínico. Não existem, infelizmente ainda, biomarcadores para o diagnóstico. Então, é essencial que exista uma boa avaliação clínica para se estabelecer o diagnóstico. Isso inclui, em termos de sintomas, fatigabilidade, assim como intolerância aos esforços, mal-estar pós-esforço e distúrbios cognitivos e de sono. Essas são as principais manifestações clínicas em termos de sintomas da doença. Esses sintomas devem estar presentes por pelo menos 3 meses ou 6 meses, dependendo da definição ou do critério diagnóstico que é utilizado, de forma persistente ou recorrente. Eles devem levar a uma significativa ou uma significante redução dos níveis de atividade, sejam essas atividades pessoais, sociais, de trabalho ou de estudo. E os sintomas não são ou não podem ser atribuídos a outras doenças. As recomendações, os critérios variam, existem mais do que 20 critérios diagnósticos, mas hoje nós estamos convergindo para um set de poucos, de selecionados diagnósticos, critérios diagnósticos que podem ser utilizados. Uma coisa que eu queria enfatizar, isso vem do IOM, o Instituto de Medicina 2015, critério que a doutora Lucinda Bateman acabou de falar. Uma das recomendações, e essa é generalizável para qualquer definição, é que o diagnóstico deve ser realizado após uma história clínica apropriada, exame físico e investigações complementares. É um diagnóstico clínico, não é apenas uma combinação de sintomas que faz o diagnóstico. É importante que um clínico com experiência, um clínico competente, faça uma investigação, porque existem vários sintomas que são inespecíficos e podem ocorrer e ocorrem em um número de outras doenças. Esse slide eu quase apaguei antes de vir para cá, porque existem muitas muitas dúvidas ainda, existem muitas incertezas. Então, esses valores são algumas tentativas de aproximar para dar uma ideia qual é o grau de ocorrência na população. A prevalência antes do COVID era algo em torno de 0,2% a 1,3%, depende do estudo e da definição. Vamos pegar 0,7%, por exemplo. Isso para Portugal significaria 70 mil pessoas no país com encefalomielite miálgica. Mas então veio o COVID. E eu quero só ressaltar, estou repetindo o que já foi falado muito, já foi falado aqui, ficou claro que a principal fator de risco, a principal causa ou desencadeador de EMI e CFS é infecção, geralmente infecções virais, mas podem ser infecções de outra natureza, bacterianas, virais ou por parasitas ou fúngicas até. E Covid é uma infecção, e como uma infecção, um número significante de casos, claro, desenvolveu quadros que são não distintos de EMI e CFS. Se nós considerarmos, por suposto, porque existem várias estimativas que variam tremendamente, mas que 50% dos casos de Covid longo resultam em EMI e CFS, dependendo da prevalência ou da incidência de Covid no país, nós podemos ter aí um aumento da prevalência de EMI e CFS em cerca de 3 vezes pós-pandemia. Isso significaria cerca de 200 mil pessoas em Portugal afetados por EMI e CFS relacionado ou não relacionado ao pós-Covid. Eu só quero enfatizar novamente, esses são dados que têm um intervalo de confiança enorme, então não são dados para serem levados como definitivos, mas são ideias da distribuição da frequência da doença. E são muito incapacitantes. Por definição, são doenças que geram incapacidade. O gráfico que vocês estão vendo mostra em homens e mulheres, respectivamente, a linha verde embaixo representa os 8 domínios do SF36, que é um indicador de qualidade de vida ou de funcionalidade, e ele mostra que pessoas com EMI, CFS têm parâmetros para todos esses indicadores que são inferiores ou mais severos comparados com indivíduos na população com doenças graves, como câncer, artrite reumatoide ou depressão. E acima, o azul representa indivíduos normais na população. Normais entre aspas. Muito bem, eu não vou falar muito de fisiopatologia. Esse é um modelo simples e tem suas imperfeições, mas existem vários outros, vários outros apresentadores aqui vão estar falando com muito mais detalhe na fisiopatologia. Mas eu queria só, de uma maneira geral, colocar que um entendimento atual de EMI e CFS, para muitos de nós, significa que indivíduos que têm predisposições genéticas e ambientais, eles desenvolvem, seguindo-se a uma infecção, um insulto ou um estressor, normalmente uma infecção, manifesta uma resposta imunitária, que é normal inicialmente, que inicialmente pró-inflamatória, mas que se torna aberrante ou anormal. Essa resposta imunitária acontece na periferia e no sistema nervoso central, e existem interações entre o sistema nervoso e imunológico, levando a partir de então uma cascata, uma série de manifestações, incluindo manifestações neuroendócrinas, do eixo neuroendócrino, autonômicas, circulatórias, assim como eventos a nível mais localizado, como a hipóxia, a disóxia, a hipóxia celular, que foi falado pelo Dr. Seastrom, o que seria o shunt que pode ocorrer, assim como disfunção endotelial e disfunção mitocondrial. Então, existe uma série de eventos que, na medida que a doença progride, ela está associada a uma redução da homeostase nos indivíduos. Então, isso é um modelo geral e simplificado do que pode estar ocorrendo no EMI e CFS. Vamos passar para tratamento e existem alguns guias relativamente recentes, todos eles de 2021. O primeiro que vocês veem é um guia de médicos americanos, um grupo provavelmente muitos dos melhores médicos americanos estão lá, e esse paper tem a doutora Bateman como primeiro autor, nós temos também a doutora Levina aqui presente, um dos autores. Esse é um dos... e esse guideline foi publicado mais ou menos, aproximadamente no mesmo tempo que o nosso guideline europeu, do Network Europeu, que tem também alguns presentes aqui, doutora Helena Lacerda, Jonas Berkist e Carmen Schaubergen, que vão estar presentes, que vai fazer apresentações ainda nesse evento. Mas eles têm várias similaridades, embora eles foram desenvolvidos completamente independentemente. E o NICE Guideline, que eu também tive a oportunidade de fazer parte, assim como uma das minhas colegas, Caroline Kingdom, que está aqui presente na audiência. Eu vou só falar um pouco inicialmente sobre o NICE. O NICE Guideline, publicado em 2021, todos esses foram publicados no mesmo ano, ele reporta o ME/CFS como uma doença médica complexa que afeta vários sistemas do organismo e é importante estabelecer um diagnóstico precoce, e isso é importante por quê? Porque o prognóstico vai melhorar se a pessoa é diagnosticada e manuseada precocemente, e é importante e possível fazer um diagnóstico acurado. Foi introduzido o conceito de diagnóstico suspeito, que pode ser feito com 6 semanas de sintomas em adultos e 4 semanas em crianças. E a confirmação diagnóstica ocorre com 3 meses de sintoma. Isso é diferente da maior parte dos guidelines ou dos diagnósticos, dos critérios diagnósticos anteriores, que recomendavam a espera de 6 meses. Isso eu acho que, na minha opinião, é um avanço, porque ele permite um reconhecimento mais precoce da doença e a intervenção. De novo, importante, história clínica, exame físico, acesso psicológico e de bem-estar e investigações para um diagnóstico, outros diagnósticos. E, de novo, os critérios diagnósticos são bem semelhantes a do IOM, é uma redução das atividades, fatigabilidade debilitante, exacerbação dos sintomas pós-esforço, existe uma intolerância aos esforços, sono não restaurador e dificuldades cognitivas. Eles têm um processo bastante rigoroso de revisão da evidência, e o comitê ele se reuniu durante 3 anos. Houve um período de intervalo sem reuniões devido ao Covid, mas ele foi um processo bastante intenso e bastante rigoroso. E eles não acharam evidência forte para nenhuma intervenção. E o NICE, ele reporta, como é um evidence-based, ele reporta baseado nos achados da evidência. E eles chegaram à conclusão que a evidência existente é de baixa qualidade, na maior parte dos casos. Mas eles sugerem o manuseio da energia, que é o pacing, o espaçamento, como a maior estratégia, a estratégia mais importante para o manuseio de sintomas. E eles são específicos em recomendar que não se oferte CBT, ou a terapia cognitiva comportamental, para a cura de ME. Isso estava no guideline anterior do NICE, de 2007, bastante antigo, estava bem defasado, e também ele sugere que não se recomendem tratamentos baseados em atividade física ou exercício. E também não existe a recomendação de nenhuma medicação específica para a cura da doença. Mas eles aceitam o tratamento sintomático, eles recomendam esse tratamento sintomático. E quando nós vamos para o Guidelines europeu, do Network Europeu, do Euromini, ele também reconhece a falta de evidência forte, mas ele se baseia bastante no expertise, na experiência dos médicos e pesquisadores, e eles recomendam mais proativamente o tratamento sintomático, assim como o empoderamento dos pacientes para estarem em controle dos seus sintomas e também o espaçamento ou pacing. Existe uma série de medidas de suporte que são recomendadas, como terapias de suporte, terapias de apoio, e um approach que é multidisciplinar, assim como multissetorial. Então, nós temos diferentes especialidades, como terapia ocupacional, trabalhadores sociais, assim como a importância do sistema educacional e ocupacional e educacional de estar envolvidos, dando suporte aos trabalhadores, assim como aos estudantes. E eles recomendam tratamentos específicos, o NICE não vai até esse ponto, mas é recomendado tratamentos específicos para sintomas específicos. Eu não vou parar aqui, não vou entrar em detalhe, mas só queria mencionar que existem tratamentos que melhoram os sintomas. A hipótese, a Mast Cell Activation Syndrome, que seria a síndrome da ativação dos mastócitos, estão contempladas. Então, nós passamos do NICE, que rigorosamente revisa a evidência e nos diz que não existe uma boa evidência. Nós temos outros guidelines, como o americano e o do network europeu, que nos digam vamos tratar sintomaticamente. Mas eu acho que nós estamos no momento que nós podemos começar a tratar baseado na fisiopatologia, ou baseado em anormalidades que são reconhecidas e podem ser diagnosticadas. Então, eu só vou dar 2 exemplos, um relacionado à desautonomia e outro relacionado à neuroinflamação. Inicialmente, não é a primeira vez nessa conferência que nós estamos falando em POTS, mas esse slide ele se refere a POTS de uma maneira geral, ele não é específico para ME/CFS ou encefalomielite miálgica. Mas ele mostra aqui alguns fatores que estão associados, alguns mecanismos associados ao POTS. Um seria a diminuição do retorno venoso ou a redução da pré-carga, que vocês já ouviram falar hoje e vão continuar ouvindo durante essa conferência. Então, nós temos situações que podem acontecer durante o POTS e outras desautonomias, como a redução da volemia, como autoantibodies ou autoanticorpos, a neuropatia de fibras pequenas, assim como efeitos diretos no nodo sinusial, proporcionados ou desencadeados por mediadores inflamatórios. Aqui tem um exemplo da síndrome da ativação de mastócitos, excessivo ativação simpatética central ou, novamente, autoanticorpos. E aqui tem exemplos de tratamentos, eu não vou ser exaustivos, mas eles incluem drogas como inibidores da beta-bloqueadores e outros inibidores da frequência cardíaca, assim como vasoconstritores, drogas simpaticolíticas, expansores do volume sanguíneo. O outro exemplo que eu queria dar aqui seria em relação a naltrexone em doses baixas. Naltrexone é uma medicação que é utilizada em doses reconhecidas e aceitas para o tratamento de abuso de opioides, álcool e outras condições. Isso são doses altas. A experiência em muitos centros, inclusive do nosso serviço, é de que quando você usa a naltrexone em doses baixas, o efeito, na verdade, inclui um efeito protetor neurológico, seria um efeito anti-inflamatório, porque pela ação na micróglia, no sistema nervoso central, assim como uma upregulation dos opioides. Então, eles estimulam a produção de opioides do indivíduo mesmo, endógenos. O gráfico azul, que seria, ele mostra, o gráfico mostra a nossa experiência na clínica em Vancouver, que após o uso de low-dose naltrexone, existe uma diminuição dos índices de pain, de dor, assim como o PHQ-9, que são indicadores de depressão e fadiga, mas não tem uma alteração significativa dos indicadores de sono. O outro gráfico é de um estudo não cego na Finlândia, que mostra uma boa resposta em 74% dos indivíduos com ME/CFS naquele país. Como é que eu estou de tempo? Está ok? Ótimo. Eu vou dar agora falar 2 palavras sobre o nosso serviço em Vancouver, no Canadá, que é o Serviço de Doenças Complexas Crônicas. E só para dizer qual é o nosso modelo de serviço, inicialmente nós temos um grupo interprofissional, que inclui desde terapeutas ocupacionais, fisioterapeuta, enfermeiras, naturopata, acupunturista, etc., que promovem especialmente sessões de grupo com a nossa população de pacientes, incluindo, como indica o slide, educação e empoderamento dos pacientes em relação ao pacing, mindfulness, tratamento de dor, melhora de função cognitiva e outras atividades que são desenvolvidas em grupo. A nível individual, existe o tratamento médico, que inclui um diagnóstico e o segmento dos pacientes, de acordo com a necessidade, e, quando necessário, existe a consulta com a farmacêutica, com o farmacêutico, ou então com membros específicos no nosso time de profissionais aliados à medicina. Esses são só alguns dos parâmetros que nós usamos para monitorar a resposta dos indivíduos durante o tratamento no serviço. Isso se refere a aproximadamente 700 pacientes tratados no serviço, e nós observamos aqui, são gráficos selecionados, uma melhora dos níveis de fadiga e uma melhora também da função física e mental, de acordo com o SF36, durante o programa, inicialmente na entrada do programa, com 6 meses, e no momento da alta do programa. Esses resultados não têm uma significância clínica excessiva, a gente deve olhar com cuidado, mas ele demonstra uma resposta positiva, em geral, do programa. Eu tenho 2 slides ou 3 para apresentar como conclusões. Eu falei até agora um pouco dos guias para terapêuticos, o NICE, o Euromini, etc. Um pouco da nossa prática clínica, do nosso serviço, no caso, no Canadá. E agora eu vou passar como é que nós movemos, como é que nós vamos daqui para frente. Eu estou pegando é importante que existam bons serviços de saúde que funcionem para que se possam profissionais de saúde competentes trabalhar e e melhorar a saúde dos indivíduos com ME/CFS. E, para isso, eu só estou copiando as recomendações do Euromini, que recomenda de 2 a 4 especialistas em ME/CFS por 1 milhão de população. Então, aqui em Portugal, nós temos que ter pelo menos 20 até 40 especialistas em ME/CFS. Eu acho que nós temos, eu acho que vocês, os locais, têm um bom trabalho ainda a fazer para treinar mais profissionais de saúde. E pelo menos um centro em ME/CFS para 10 milhões de população. Parece que isso foi feito para Portugal, né, esse slide, mas foi assim. Então, eu acho que seria importante ter pelo menos um centro aqui com um time interprofissional e dando suporte aos cuidados primários de saúde, porque tudo começa, a importância do diagnóstico em cuidados primários de saúde eu não posso deixar de enfatizar isso, e isso requer educação dos profissionais dentro da rede. Então, temos que ter serviços funcionantes, e só um pequeno resumo do como vocês, os profissionais de saúde aqui nessa audiência, vão saber bem, né, estabelecer uma parceria com o paciente, trabalhar dentro de um time multiprofissional, avaliar, diagnosticar, legitimizar o paciente, sua doença e responder às necessidades do paciente. Não são só médicas. O paciente com uma doença debilitante como a ME/CFS vai ter várias consequências, né, financeiras, inclusive, e muitas outras que vocês vão saber muito bem. Tente considerar as alterações fisiopatológicas, eduque e aprenda com os pacientes, com os profissionais de saúde e trabalhe com serviços que estão preparados e respondam às necessidades da população. E aprenda com história. Eu acho que nós, como humanidade, nós não fazemos muito bem isso, aprender com a história. Então, são dois exemplos muito simples, né? Quando eu estava na escola médica, úlcera, o principal fator de risco para a úlcera, a principal causa era personalidade tipo A, eu acho. As pessoas acima de uma certa idade sorriram. Até que descobriram H. pylori. Então, assim, a medicina muda com o tempo, a gente descobre novas coisas. E o AIDS, eu queria enfatizar que, no início da AIDS, tinha um preconceito, um estigma, ainda tem, infelizmente. Então, eu só queria assim, uma breve lembrança de todos nós, o que não se passou pelo AIDS, até que se descobriram, é o vírus do HIV, então... E depois, tratamento, e AIDS hoje é uma doença curável, totalmente curável. Então, são só dois exemplos, mas a mensagem aqui é vamos prestar atenção na história, e a história de EMSFCCovidLonga está em evolução, e nós estamos aprendendo a cada dia mais. Obrigado pela atenção.
Obrigado, Luís. Thank you, Luís, for so practical lecture. And now I call Eliana Lacerda. She's going also to make the presentation in Portuguese and with the slides in English. The speech is about a prospective cohort of the UK ME/CFS Biobank, participants with mild and moderate or severe ME/CFS. Eliana Lacerda is medical doctor, PhD in London School of Hygiene and Tropical Medicine, and a member of the CourMe research group. Eliana, please.
Bom, inicialmente eu queria só agradecer o convite, é uma grande honra estar aqui e falar na minha língua nativa, embora eu não seja portuguesa, eu sou brasileira, e vocês podem... Tá bem? Ok. Desculpe, mas eu estou com um probleminha de garganta também, então está meio difícil, eu já falo baixo. Como eu falei, eu sou brasileira, né, então o meu português é um pouco diferente do que vocês têm ouvido, e a minha apresentação vai ser em cima de uma coorte prospectiva que a gente tem acompanhado essa coorte de pacientes até 6 time points. Então, a gente trabalha com esses pacientes há bastante tempo, e eu posso dizer que são pacientes que eles acabam tendo uma ligação com o grupo CureMe, né? E nessa apresentação, o que eu vou mostrar para vocês é como a gente estabeleceu a coorte inicial, como foi o processo de consulta com a população de ME/CFS, a gente trabalhou com grupos e com as associações de ME/CFS na Inglaterra. A gente trabalha com... a gente fez uma consulta com esses profissionais e pessoas. Depois, a gente estabeleceu a infraestrutura, tanto do database como o Biobank, que a gente aninhou dentro de um Biobank específico. E esse Biobank, no momento, a gente tem trabalhado com amostras de sangue mas a gente está pegando algumas amostras de saliva para uma outra proposta que a gente está fazendo. E o recrutamento dos participantes e todos os follow-ups dentro de uma análise clínica. Depois eu vou mostrar alguns resultados dessa coorte prospectiva que a gente estabeleceu. Como eu falei inicialmente, a gente fez, para estabelecer o UK ME/CFS Biobank, a gente fez uma discussão com as principais ME/CFS Charity da Inglaterra, e a gente fez grupos focais com participantes, inclusive com aqueles que eram severos, né? E a gente queria saber exatamente quais eram as prioridades deles, né? Então, uma das coisas do Biobank que a gente estabeleceu é que os pacientes, a gente discutiu potenciais amostras, como saliva, biópsias, etc., e eles escolheram sangue, que seria mais fácil e menos danoso do ponto de vista da resposta em termos dos pacientes com síndrome de fadiga crônica. E a gente desenhou os procedimentos de recrutamento com questionários e acessando sintomas. E depois a gente, junto com depois dos questionários iniciais, a gente faz um assessment, avaliação clínica, obrigada, e coleta de amostras. Então, como todos aqui já ouviram bastante, a encefalomielite miálgica é uma doença crônica que apresenta um grau significante de desabilidade e anormalidades nos sistemas nervoso e imunológico, principalmente, mas que afetam vários outros sistemas corporais, como os colegas já apresentaram aqui. A apresentação clínica usual é uma fadiga severa, que é bastante debilitante e que tem um componente mental e físico que dificulta as atividades rotineiras. Problemas de sono, dor, disfunções nos sistemas de neurocognição e no sistema autonômico, e a gente também vê relatos de sintomas relacionados à imunidade e ao sintoma neuroendócrino. Então, como é que a gente começou essa avaliação dos pacientes? A gente desenvolveu um questionário, que esse questionário tem uma série de sintomas. Então, esse é o QRME, que é o nosso grupo, o Symptoms Assessment, e os pacientes, eles preenchem o questionário no acesso inicial, e depois a gente faz um exame clínico. E eu gosto desse... Ai, desculpa, eu queria voltar aqui. Eu pus essa foto porque essa foto ela é bem emblemática para a gente. Na época do Covid, a gente continuou fazendo essa coleta de dado e avaliação clínica, e a Caroline, que é a minha colega que está ali, a enfermeira, ela foi e ela coletava o sangue dos pacientes no jardim da casa, com todo vocês veem que ela está paramentada, né? Mas durante o Covid a gente não parou, e a gente continuou com esse recrutamento. Bom, o nosso questionário ele permite um acesso aos 3 mais usados critérios diagnósticos, como Fukuda, o CDC e o Instituto de Medicina. E aí, a gente conseguiu também, nós temos uma coorte bastante grande, eu acho, em termos de número de pacientes, E a gente inicialmente a gente trabalhava com os questionários em papel, e hoje em dia eu fico muito feliz porque a gente tem um grupo na London School que finalmente conseguiu estabelecer o nosso database, que é o QRM Database, onde os pacientes recebem um link e eles entram os próprios dados dentro do database. Então, assim, foi uma conquista grande que a gente conseguiu. E aí, inicialmente, a gente tinha a gente recrutou um número de 396 participantes, e desses participantes, a gente tinha pacientes com mild moderate. Eu acredito que em termos de percentagem é bem similar a todos os outros estudos que têm sido feitos, em torno de 1/4% masculino, 3/4 feminino. Então, isso é o que a gente vê na nossa coorte geral. E para esse estudo prospectivo, a gente tem um número de 96 pacientes. A coorte com os pacientes severos, a gente tem uma faixa um pouquinho maior de número de pacientes homens, adultos. A gente não trabalha com crianças, a gente trabalha com adulto a partir de 18 anos de idade. E aqui a gente começou a ver os scores de... Eu poderia ter um pouquinho de água, por favor. A gente tem a gente criou alguns domínios de sintomas que são relacionados ao Canadian Criteria, e vocês podem ver, eu achei que era um pointer aqui, vocês podem ver que no domínio do autonômico, a gente tem ali, deixa eu só ver aqui um pouco. A gente tem positional malaise, não, no anterior. A gente tem o positional malaise em 5 pontos, a cada 6 meses que a gente avaliava esses pacientes, né? E isso era... Esses 5 pontos são relacionados com os domínios que a gente trabalhou, com, por exemplo, positional malaise. A gente mostra que os pacientes que estão no primeiro slide, eles são do lado esquerdo, eles são os mild moderates, e aqui são os severos, do lado esquerdo. Então, vocês veem que existe como se fosse uma extensão maior dos pacientes, em termos da gravidade e da flutuação dos sintomas em relação aos pacientes moderados, quando a gente considera com os severos. E isso vai acontecer, por exemplo, pós-exertional malaise, vocês veem que o gráfico da esquerda, os severos têm os dados bem mais acima, embora tenha, a cada time point vai ter cada linha é um paciente, né, e a gente vai ver como que isso tem se distribuído. Em relação à dor, que é um outro domínio que a gente tem também, os severos, a dor pode estar bem baixa e bem alta, né? Então, é uma distribuição completamente errática em relação a esses domínios. Na segunda parte do slide, a gente tem o domínio de disfunção de sono e disfunção neurocognitiva. E aqui a gente vai ter, deixa eu ver, disfunções autonômicas, disfunções imunológicas, e todos eles relacionados ao mild moderate, aos pacientes com apresentações moderadas e apresentações mais severas. E então a gente tem os autonômicos, imunes e neuroendócrinos, desculpem. Aqui é uma apresentação, que esse eu achei o mais interessante. A gente só tem aqui os pacientes com mild moderate, com apresentação moderada e apresentação severa, e no Physical Component Summary do SF36, que é a parte física, a gente vê que os pacientes mais severos, eles têm um score bem mais baixo do que os pacientes em todos os time points, todos os 5 time points. Agora, quando a gente olha o sumário mental do SF36, a gente vê que está all over the place. Então, assim, é bem o impacto da doença. Eu acho que esse slide é emblemático também, porque mostra o impacto da doença na saúde mental dos pacientes com síndrome de fadiga crônica. E eu não estou falando aqui que os pacientes com síndrome de fadiga crônica têm um processo de adoecimento mental, como muitas pessoas falavam. A cura é o Cognitive Behavioral Therapy, que não é, né? Mas qualquer doença crônica e limitante, como vocês sabem, tem um impacto na saúde mental dos pacientes. Isso não significa dizer que os pacientes não têm um sofrimento físico importante, como mostra o componente físico do SF36. Um outro marcador que a gente achou quase meio que ocasionalmente, nós fazemos uma série de exames laboratoriais para descartar outras doenças, né? E aí, quando a gente começou a ver a coorte dos nossos pacientes, os exames, tanto nos severos como nos mild moderate, eles tinham a creatinofosfoquinase estava mais baixa. E a gente esperava que tivesse um pouco alta, mas foi um achado que a gente fez. A gente, inclusive, fez algumas publicações em relação a isso, né? E esse gráfico, ele meio que é bem emblemático para mostrar que todos os pacientes com síndrome de fadiga crônica, eles têm uma creatina fosfoquinase bem mais baixa, mas os severos têm mais baixo ainda. E isso é uma coisa interessante. Foi um achado clínico que a gente fez e que mostra que poderia ser, inclusive, indicado como um teste de monitoramento para esses pacientes. Um outro achado que a gente tem, que outros colegas têm achado a mesma coisa, é a diferença de hand grip com o dinamômetro. A gente percebe que os pacientes mild moderate, eles têm o hand grip é um pouquinho mais baixo, nessa coorte particularmente. Em outros estudos, quando a gente pega a coorte completa, a gente tem que os severos são bem mais baixos do que o mild moderate, mas essa coorte é um pouco menor, então esse resultado não é tão significante, mas ainda mostra uma redução, e principalmente quando a gente compara com uma outra coorte que nós trabalhamos, que é uma coorte de pessoas com esclerose múltipla, que foi uma coorte de doentes, mas com uma desabilidade significante, e mesmo assim eles tinham os scores bem mais altos em relação ao grupo de MCFS. E aqui a gente, foi uma das nossas últimas avaliações dessa coorte, a gente mostra valores preditivos de o que a gente chama de Global Clinical Score, que são todos esses scores que a gente trabalhou, e uma estatística trabalhou conosco, então a gente mostra que, por exemplo, o Global Clinical Score, que a gente usa nos questionários, utilizando todas aquelas questões, vocês veem a diferença dos healthy, dos indivíduos saudáveis, os mild moderates, os severos e os controles com múltipla esclerose. Então, esse Global Clinical Score, ele mostra, quanto maior o score, maior a disabilidade. Aqui é o score do hand grip, né, do dinamômetro. A gente está mostrando a diferença no primeiro slide do hand grip em relação ao mild, moderate e severo. E a gente vê que, mesmo com o dinamômetro, a gente tem uma... a gente mostra que o mild moderate ele tem uma escala maior em relação a isso, mas a média, ou a mediana, é em torno de 3 nesse slide. O severo é um pouco menor, né? A gente tem, quanto menor, mais em pé. Mas é interessante que isso é o valor preditivo. Quando a gente vai olhar as diferenças do hand grip, o máximo e o mínimo, você vê que o severo está numa faixa de muito menor em relação ao que a gente está querendo mostrar nessa análise, é que existe uma diferença muito grande com a variabilidade do hand grip nos vários grupos de controle em relação aos severos. Aqui a gente está mostrando novamente a creatina fosfoquinase, que novamente mostra um grau significativo de redução da creatina fosfoquinase em relação aos MS, pacientes com esclerose múltipla e paciente com mild e moderate, uma apresentação mais moderada de MCFS, enquanto os controles normais estão lá em cima. É interessante falar que esses controles normais não são aqueles super fit, eles são pessoas que têm uma vida relativamente normal, mas é interessante também mostrar que o MCFS com a apresentação moderada em relação à creatina fosfoquinase, ele mostra uma semelhança com pacientes com esclerose múltipla. Aqui, eu acho que é bem autoevidente que os valores preditivos do physical component summary, do componente físico do SF36, é muito distinto em relação aos pacientes com o quadro severo e o quadro moderado. E aqui é uma análise de correlação que a gente faz com todos os domínios do SF36 que a gente utilizou. Então, esse GCS7 é Global Clinical Score, que a estatística juntou todos os scores que a gente fez e criou esse Global Clinical Score. E aí a gente está vendo o que correlaciona com o quê. Então, é interessante que existem com alta correlação o Global Clinical Score, mas principalmente a gente percebe neurocognition com o sistema autonômico, e é interessante mostrar essas correlações, né, e como que alguns são bem significativos em relação aos sistemas. Nos casos severos, a gente tem, de novo, o sistema autonômico, neurocognitivo e dor, que é bem significativo também. Então, em conclusão, a gente percebe que a flutuação dos sintomas ela é evidenciada durante todos os follow-ups que a gente fez, em todos os time points. A gente perdeu um pouco de paciente durante o COVID, obviamente, alguns pacientes não conseguiram, ficaram com medo de serem avaliados clinicamente, de doar a amostra, mas existe essa amplitude menor em relação aos pacientes que têm uma apresentação mais severa, né? A amplitude dos sintomas em todos os pontos, ela é bem menor, então é como se o corpo tivesse meio dormente mesmo, assim, shutting down. Uma outra coisa que a gente evidenciou foi a análise de correlação, correlações significantes entre domínios, né, que a gente esperava isso, e esses domínios, eles, eu acho que são interessantes para a gente trabalhar um pouco o manuseamento dos sintomas. Né? A gente, olhando para domínios específicos, a gente pode considerar approach Sem problema. A gente pode considerar um pouco essas possibilidades de manuseamento de sintomas pelos domínios dos sintomas que estão controlados e até chegar a descobrir um pouco mais, ou conhecer um pouco mais da fisiopatologia da doença, que eu acho que, por mais que a gente tenha aprendido bastante, ainda tem algumas questões significantes que a gente, enquanto pesquisador, enquanto médico, não consegue estabelecer as conexões completas, ou seja, como que se dá essa fisiopatologia? Eu acho que essas perguntas ainda têm algumas respostas pendentes. Obrigada. E desculpem a fala.
Now I invite you, please, and Luis also, to come here to the floor for a short session of questions and answers and the discussion of your two talks. Eliana, can I put you a question? Please sit. Yeah. About CK. About the levels of CK are lower in the population with long COVID and in comparison with normal controls. I think it's due to the people with fatigue exercise less in time and in intensity than normal people. So they have muscle atrophy. In 3 months, people, if they don't leave home, if they stay seated or in bed, they lost almost 1/3 of the muscular mass. Those are studies that are made in the first flies to the moon by NASA. And as you know, the first trips to the space were not accompanied by depression we have here. And so the astronauts lost it 1/3 to half muscle mass and also bone mass in the flies of 3 weeks fly, a 3-week fly only. So I think the CK it could be a signature of the disease, but maybe it's only due to the less exercise they do. They don't move due to the fatigue, and so CK. What is your opinion about it?
I think that it must, yeah, I agree with you that the lower activity that these patients have, they lost mass muscle. And I think that this could be, but when we started looking at the results from the clinical, because we have a battery of
it depends also on the moment of the disease. You made the measurements of CK.
Yes, I mean, all the participants that we have, most of them have at least 10 years of disease when we started our cohort. So it makes sense.
Yeah.
I completely agree with you. But I think that it was the idea of looking at all these blood tests that we run, and we didn't find anything. And then suddenly CPK is very low, and I said, well, if there is a component of inflammation, why the CPK is so low? But I think that you might have the trigger now.
We can work that figure in other ways. We are going to talk about it, okay?
Yeah.
Because it's very, very interesting.
And this is very good, because now I'm just doing this, because we have also a biobank. So we have sent samples around the world.
Okay.
America, Europe. So if you want, we can send some samples and you can have a look.
Ok. Sim? Vai já aí o microfone. Já vai.
English or Portuguese? English or
Or
Portuguese?
if you want to in Portuguese, okay.
My name is...
She understands Portuguese very well.
Know. My name is Patrícia Pinto. I'm a rheumatologist, and I work in Vila Nova de Gaia, and we have a group of patients with this disease. We are developing a project like Dr. Nakul was telling that Portugal needs that. And maybe I can say something about CK also, because I think it would be very nice to make a correlation with the sarcopenic patients. They can be old patients, but they also have less activity, that they do less movement. And when I did some research, I think that patients with Epidemiologic have even less CK than the patients that have sarcopenia, for the studies that I read. And for our sample, we have at least 30 patients, young patients, people like in the middle age, and old patients. Most of them, they always have CK, and is very low. But this is only a commentary to what you said. And I have 2 questions for you and 2 questions for Dr. Nakul, if I can say that. For you, in your cohort, did you include patients with long COVID? Also, or only patients that have EM, fatigue?
No, in this cohort we don't have, but we have another NIH grant that we are about to start our recruitment of a small cohort of people with long COVID.
But when you have those timetables with the 5 points that you made evaluation during 5 evaluations, we didn't see any change in those those numbers. It seems that treatment or the treatment that patients are doing is not making any difference in the different evaluations. How you can comment on that?
For this cohort, the majority of these patients, they are seen by doctors in the UK, and usually they don't have specific treatments. They use some medicines, and we have a list of medicines that they have been using in our database. But it's more about symptomatic, as
Yes.
we know, don't have a specific treatment. But yes, I think that it's more what they are doing in terms of their own thing, because there are, I think that 4 doctors that I know that have private clinics that look after patients. But usually the national health system in the UK, the treatment used to be cognitive behavior therapy and exercise.
Thank you. Dr. Nakula, it was a great talk. I think in Europe we are using a lot of, or we can see that patients that have these diseases are using a lot of supplements, like alimentary supplements and special diets. I don't know if it's the reality of Canada or your center, and if it is, how do you manage those supplements? Because they are doing a lot of them at the same time, and we cannot even know if they are getting some response, even if it is small with one or with the other. Because we cannot speak a lot about other treatments that are not validated. So that's my question. Thank you.
Yeah, thank you for your question. Yes, in Canada they use lots of supplements. In North America, I think North America in general, there is a tendency for patients to use very freely supplements that you can get over the counter. I think our approach is we have a naturopath in our service, so when necessary, our naturopath discusses cases with them. We only refer to naturopath in specific cases. One of the reasons we refer, interestingly, is when people are taking more than a large number of supplements, we start to get worried because we don't know if they're having any effect, and we don't want patients to spend excessive amount of money. But I mean, I'm quite liberal in terms of supplements. I don't tend to there is a small number of supplements that we recommend as per our protocol, but we usually don't interfere in the supplements that patients are taking. We just give general advice.
Thank you. Nuno.
Hello. I know it's been a while, but my name is Mspoovda, and I used to work with Louise and Iliana in the London School of Hygiene and Tropical Medicine. And if I can add about this UK Biobank data, is that talking about this sarcopenia and muscle mass loss over time, I actually analyzed that data, and it was interesting that actually they lose a muscle mass as healthy controls. The only thing that changed, at least in this cohort, is actually the body fat. And it was, for me, was really surprising, and we discussed this. So we can discuss this later.
Thank you. João Carlos.
Thank you so much. The question is to Professor Nakul. I want you to address the topic of non-pharmacological management, because we've seen in the last years a couple of, small randomized controlled trials that showed some benefit, and I wonder why in the guidelines they are not mentioned, and what's your opinion? And I would address only 2 of them. First, hyperbaric oxygen. And second, the transauricular vagal stimulation. So what's your opinion, and why these non-pharmacological therapies are not at least mentioned as future therapies in these guidelines?
And I would have two questions about acupuncture and also the cryotherapy, okay? Cryotherapy.
Okay.
Well, because they are similar questions about
okay, right.
no pharmacological interventions,
Yeah.
okay?
So NICE guidelines, if you have one or two studies, and usually the evidence will be low quality. So we're talking about either a relatively large number of people in a number of trials, unless the effect is massive, and then you can probably have a bit less numbers in total. So they didn't find, they look at everything under the sun in terms of studies, and unfortunately there are no studies there, not robust enough studies, or no studies that are replicated. But it's very important that if you don't find that evidence, it doesn't mean that the evidence is not there. So not finding evidence is not the same as lack of evidence. So I think the answer, I would say, just do more studies. I have reports from colleagues that they have good experience with hyperbaric oxygen. I have some supplements, that patients tend to report some results when they take. One of them is the PEA supplement that you use in micronized form. So that's something that there is a good number of, and there is a small studies showing that. But this is not enough for to say in terms of protocol, or for NICE to say at least that those should be recommended. When it comes to Euromine, I didn't mention, but if you look at the paper, there are a number of supplements that are used by the physicians and health professionals within Europe and within the network, and they are put there as options to be considered. So it's not a no-no, but on the other hand, I'm not in a position to say supplement A or B actually is something that should be widely recommended from the data that is there. And I know very little about cryotherapy, but Nuno comes from Poland, so there is a colleague there that has been working on that. Do you have any comments on that? I mean, I don't know how much you know about.
My microphone to Nuno Sepúlveda, please.
Yeah. As far as I know, it was a small study, but the results were impressive. That's why I asked if NICE guidelines actually they thought about this in these meetings. They discuss non-pharmacological kind of therapies that, like you said, evidence. It's not very strong at the moment because of lack of studies. It's lack of studies mostly.
Yeah, exactly. Yeah.
Okay. Thank you. Some more question?
No. So I think that I'm not trying to do this in Portuguese and in English. It's, uma questão. Pronto, uma questão importante que eu acho em relação a essas outras potenciais intervenções é a questão da evidência. Quando a gente fala em evidência científica, você tem que fazer um duplo cego. Como é que você faz um duplo cego numa câmara bariátrica? Entendeu? Assim, você põe uma câmara com uma pessoa e depois fica difícil. Alguns procedimentos ficam difíceis de fazer duplo cego. Você faz e o controle é o quê? Entende? Eu acho que tem algumas questões. Provavelmente.
Não, eu concordo com isso, e é o mesmo para as terapias psicológicas, que tem várias, né? Elas não são duplo cegas, e quando elas não são duplo cegas, a evidência vai ser bem mais fraca. Rituximab pode ser um exemplo de quando fizeram um estudo aberto, inicialmente sem controle, o efeito parecia bem significante. Quando fizeram duplo cego, não teve efeito. é só um dos exemplos para ilustrar o fato de que estudos não controlados que não são duplos cegos, realmente a evidência sempre vai ser baixa.
It's the difficulty also with physiotherapy or spa treatments and so on. It's very, very difficult. And last question, Fernando.
Muito boa tarde. Parabéns, antes de mais, pelas vossas apresentações. Estou em representação da APED, a Associação Portuguesa para o Estudador, e também da Nova Medical School. Eu queria clarificar dois aspectos com a Eliana. Um deles relacionado com os valores CK, se de facto esses doentes tinham ou não tinham critérios para sarcopenia. E o segundo aspecto, o que é que considerou dentro do item alterações imunológicas e neuroendócrinas?
Eu poderia te colocar assim, em relação aos domínios, a gente tem um questionário bem ampliado e aí a gente pega algumas questões específicas que são relacionadas a esse domínio, né? Então, foi isso que a gente trabalhou. A outra questão que você perguntou foi em relação ao CQ.
Critérios de sarcopenia.
A gente não olhou isso. Poderia até, assim, como o nosso questionário é bem amplo, você me deu uma ideia para a gente dar uma olhada. Eu acho que poderia ser, mas eu acredito que não, porque, normalmente, esses pacientes eles teriam quando a gente faz uma avaliação clínica nos pacientes, eu acho que teriam algumas indicações, talvez, de mais... Sim. A gente...
Não fez a avaliação.
Não fez, não.
They were not evaluated only by the grip strength. They have the grip strength.
A gente tem o baseline, tem todos os follow-ups, todos com o hand grip também. Então, a gente pode... Mas é uma coorte mais restrita.
Okay.
Mas todos eles com critério específico de ME/CFS. E como eu mostrei aqui nessa coorte da gente, os 3 critérios, todos eles tinham compliance com os critérios diagnósticos de ME/CFS.
Well, we can also talk with Eliana and Luís during the lunch or after the lunch. Now is lunchtime, and for you who want to lunch here, we have a gentle offer from FLAD, and you have a meal box in the cloakroom nearby. Okay? We see each other here at 2:30. Have a good meal.
através do controle destas duas hormonas, que é feito através do exercício híbrido, ou seja, o exercício de força cardiovascular, não só um no outro, e essas hormonas são resultadas durante o exercício. E isso consegue baixar os fibromialgia. E o que eu queria perguntar é se há estudos relacionados com isso. Se não há.
Eu não conheço os estudos, mas isso é agora, se tem uma fibromialgia, é uma boa razão.
Há um estudo similar feito na Universidade de São Paulo que eu li. Não avaliam especificamente o tipo de hormonas, mas a parte que ele está aqui é definida através da serotonina, da dopamina, e eles veem que avaliam no geral a rotação de hormonas que baixa a inflamação. Nós sabemos, com os estudos não só de vida, mas outras coisas, que há certas determinadas hormonas que era mais benéfico buscar, porque essas sim baixam relativamente baixa a inflamação. Só a sensação de bem-estar. Pronto, eu andava à procura um bocado de informação. Trabalho na fitação. Primeira vez que eu nos cursos em estresse foi através de familiares, não foi basicamente às cegas, comecei a testar vários métodos de trânsito durante períodos de 4 ou 6 semanas. Qual era o estímulo que ela tinha melhor. Depois comecei a aplicar isso nos meus anos, ao longo da minha carreira. Tenho tido resultados muito bons. A amostra é curta, são para aí 20 pessoas, mas efetivamente.
Pensou em publicar?
É uma hipótese.
Olá, meu nome é Priscila Falcão, tenho 46 anos, sou brasileira e há quase 7 anos sou portadora de encefalomielite miálgica, ou síndrome de fadiga crônica. Durante 5 anos eu vivi a saga em busca de descobrir o que estava acontecendo de errado com o meu corpo. Foram 5 anos de dúvidas, de ansiedade e busca por uma resposta. Hoje, após quase 2 anos de diagnóstico fechado e mesmo aliviada de saber o que está acontecendo com o meu corpo, a angústia pela falta de respostas e as dúvidas ainda prevalecem. O portador de encefalomielite miálgica precisa de qualidade de vida, de apoio e principalmente precisam ser vistos. Hoje eu uso um pouco de energia que eu tenho para informar e dar visibilidade a essa doença que afeta milhões e milhões de pessoas no mundo e ainda assim é considerada invisível. Não, nós existimos. Obrigada a todos que farão dessa conferência um passo muito importante para as nossas vidas. Muito obrigada.
Hi everyone, my name is Sian Leary and I'm Head of Advocacy and Communications at the World ME Alliance. We are thrilled to be standing in solidarity with Portugal for its first ever international ME conference. ME is a global health crisis, and so global collaboration is vital, especially as we are seeing millions more develop the condition post-COVID. This conference is a crucial step, and we hope it will spark substantial and sustained change for people with ME in Portugal and beyond. So thank you for your commitment to a world where ME is better understood, is researched and is conquered together.
Sono Giada Da Rossa, presidente della CFS and Associazione Italiana. L'encefalomielite mialgica è una malattia devastante che distrugge vite. È una tortura quotidiana, costante per chi ne soffre in modo severo ed è comunque invalidante anche per chi ce l'ha in modo meno grave. Incontri come questo sono molto importanti perché ci permettono di immaginare e di cominciare a costruire un futuro migliore per tante persone che soffrono nell'invisibilità. Grazie a tutti voi che siete impegnati nella ricerca, fa davvero la differenza.
Hi, this is Duran Corlett from ME Support IOM, based in the Isle of Man, and we were delighted to hear that a conference is being held in Portugal about ME, and well done to all involved with the organisation. It's so important that more is done to help people with ME, and their families and their carers and all of those that were affected by this disease, which can in some cases be extremely debilitating. Our hope is that more research is done and that more medical professionals understand the condition so that they can give out good quality advice. We remain disheartened when people with ME attend appointments or are admitted to hospital and their symptoms are exacerbated through poor advice. We hope the pandemic has been and will remain to be a catalyst for improvements in post-viral illness, healthcare, and that the conference in Portugal is in itself a catalyst too. Best wishes.
A MSFC é uma doença pouco conhecida no nosso país. É necessário aumentar a sensibilização dos profissionais de saúde para esta patologia, permitindo que os doentes consigam ser diagnosticados mais precocemente e obtenham também melhor acompanhamento e tratamento.
Na MIOS temos sentido nos últimos anos um aumento no número de contactos, quer de pessoas com sintomas compatíveis com o diagnóstico de EMSFC e que procuram recomendação de médicos para avaliação, bem como de doentes recém-diagnosticados, alguns após infecção por Covid. Esperamos...
Olá, meu nome é Priscila Falcão, tenho 46 anos, sou brasileira e há quase 7 anos sou portadora de encefalomielite miálgica, ou síndrome de fadiga crônica. Durante 5 anos eu vivi a saga em busca de descobrir o que estava acontecendo de errado com o meu corpo. Foram 5 anos de dúvidas, de ansiedade e busca por uma resposta. Hoje, após quase 2 anos de diagnóstico fechado e mesmo aliviada de saber o que está acontecendo com o meu corpo, a angústia pela falta de respostas e as dúvidas ainda prevalecem. O portador de encefalomielite miálgica precisa de qualidade de vida, de apoio e principalmente precisamos ser vistos. Hoje eu uso um pouco de energia que eu tenho para informar e dar visibilidade a essa doença que afeta milhões e milhões de pessoas no mundo e ainda assim é considerada invisível. Não, nós existimos. Obrigada a todos que farão dessa conferência um passo muito importante para as nossas vidas. Muito obrigada.
Hi everyone, my name is Sian Leary and I'm Head of Advocacy and Communications at the World ME Alliance. We are thrilled to be standing in solidarity with Portugal for its first ever international ME conference. ME is a global health crisis, and so global collaboration is vital, especially as we are seeing millions more develop the condition post-COVID. This conference is a crucial step, and we hope it will spark substantial and sustained change for people with ME in Portugal and beyond. So thank you for your commitment to a world where ME is better understood, is researched and is conquered together.
Sono Giada Da Rossa, presidente della CFS and Associazione Italiana. L'encefalomielite mialgica è una malattia devastante che distrugge vite. È una tortura quotidiana, costante per chi ne soffre in modo severo ed è comunque invalidante anche per chi ce l'ha in modo meno grave. Incontri come questo sono molto importanti perché ci permettono di immaginare e di cominciare a costruire un futuro migliore per tante persone che soffrono nell'invisibilità. Grazie a tutti voi che siete impegnati nella ricerca, fa davvero la differenza.
Hi, this is Duran Corlett from ME Support IOM, based in the Isle of Man, and we were delighted to hear that a conference is being held in Portugal about ME, and well done to all involved with the organisation. It's so important that more is done to help people with ME and their families and their carers and all of those that were affected by this disease, which can in some cases be extremely debilitating. Our hope is that more research is done and that more medical professionals understand the condition so that they can give out good quality advice. We remain disheartened when people with ME attend appointments or are admitted to hospital and their symptoms are exacerbated through poor advice. We hope the pandemic has been and will remain to be a catalyst for improvements in post-viral illness, healthcare, and that the conference in Portugal is in itself a catalyst too. Best wishes.
A MSFC é uma doença pouco conhecida no nosso país. É necessário aumentar a sensibilização dos profissionais de saúde para esta patologia, permitindo que os doentes consigam ser diagnosticados mais precocemente e obtenham também melhor acompanhamento e tratamento.
Na MIOS temos sentido nos últimos anos um aumento no número de contactos, quer de pessoas com sintomas compatíveis com o diagnóstico de EMSFC e que procuram recomendação de médicos para avaliação, bem como de doentes recém-diagnosticados, alguns após infecção por Covid. Esperamos...
Olá, meu nome é Priscila Falcão, tenho 46 anos, sou brasileira e há quase 7 anos sou portadora de encefalomielite miálgica, ou síndrome de fadiga crônica. Durante 5 anos eu vivi a saga em busca de descobrir o que estava acontecendo de errado com o meu corpo. Foram 5 anos de dúvidas, de ansiedade e busca por uma resposta. Hoje, após quase 2 anos de diagnóstico fechado e mesmo aliviada de saber o que está acontecendo com o meu corpo, a angústia pela falta de respostas e as dúvidas ainda prevalecem. O portador de encefalomielite miálgica precisa de qualidade de vida, de apoio e principalmente precisamos ser vistos. Hoje eu uso um pouco de energia que eu tenho para informar e dar visibilidade a essa doença que afeta milhões e milhões de pessoas no mundo e ainda assim é considerada invisível. Não, nós existimos. Obrigada a todos que farão dessa conferência um passo muito importante para as nossas vidas. Muito obrigada.
Hi everyone, my name is Sian Leary and I'm Head of Advocacy and Communications at the World ME Alliance. We are thrilled to be standing in solidarity with Portugal for its first ever international ME conference. ME is a global health crisis, and so global collaboration is vital, especially as we are seeing millions more develop the condition post-COVID. This conference is a crucial step, and we hope it will spark substantial and sustained change for people with ME in Portugal and beyond. So thank you for your commitment to a world where ME is better understood, is researched and is conquered together.
Sono Giada Da Ross, presidente della CFS and Associazione Italiana. L'encefalomielite mialgica è una malattia devastante che distrugge vite. È una tortura quotidiana, costante per chi ne soffre in modo severo ed è comunque invalidante anche per chi ce l'ha in modo meno grave. Incontri come questo sono molto importanti perché ci permettono di immaginare e di cominciare a costruire un futuro migliore per tante persone che soffrono nell'invisibilità. Grazie a tutti voi che siete impegnati nella ricerca, fa davvero la differenza.
Hi, this is Duran Corlett from ME Support IOM, based in the Isle of Man, and we were delighted to hear that a conference is being held in Portugal about ME, and well done to all involved with the organisation. It's so important that more is done to help people with ME and their families and their carers and all of those that were affected by this disease, which can in some cases be extremely debilitating. Our hope is that more research is done and that more medical professionals understand the condition so that they can give out good quality advice. We remain disheartened when people with ME attend appointments or are admitted to hospital and their symptoms are exacerbated through poor advice. We hope the pandemic has been and will remain to be a catalyst for improvements in post-viral illness, healthcare, and that the conference in Portugal is in itself a catalyst too. Best wishes.
A MSFC é uma doença pouco conhecida no nosso país. É necessário aumentar a sensibilização dos profissionais de saúde para esta patologia, permitindo que os doentes consigam ser diagnosticados mais precocemente e obtenham também melhor acompanhamento e tratamento.
Na MIOS temos sentido nos últimos anos um aumento no número de contactos, quer de pessoas com sintomas compatíveis com o diagnóstico de EMSFC e que procuram recomendação de médicos para avaliação, bem como de doentes recém-diagnosticados, alguns após infecção por Covid. Esperamos...
Olá, meu nome é Priscila Falcão, tenho 46 anos, sou brasileira e há quase 7 anos sou portadora de encefalomielite miálgica, ou síndrome de fadiga crônica. Durante 5 anos eu vivi a saga em busca de descobrir o que estava acontecendo de errado com o meu corpo. Foram 5 anos de dúvidas, de ansiedade e busca por uma resposta. Hoje, após quase 2 anos de diagnóstico fechado e mesmo aliviada de saber o que está acontecendo com o meu corpo, a angústia pela falta de respostas e as dúvidas ainda prevalecem. O portador de encefalomielite miálgica precisa de qualidade de vida, de apoio e principalmente precisamos ser vistos. Hoje eu uso pouco de energia que eu tenho para informar e dar visibilidade a essa doença que afeta milhões e milhões de pessoas no mundo e ainda assim é considerada invisível. Não, nós existimos. Obrigada a todos que farão dessa conferência.
Especially as we are seeing millions more develop the condition post-COVID. This conference is a crucial step, and we hope it will spark substantial and sustained change for people with ME in Portugal and beyond. So thank you for your commitment to a world where ME is better understood, is researched and is conquered together.
Sono Giada Da Rossa, presidente della CFS and Associazione Italiana. L'encefalomielite mialgica è una malattia devastante che distrugge vite. È una tortura quotidiana, costante per chi ne soffre in modo severo ed è comunque invalidante anche per chi ce l'ha in modo meno grave. Incontri come questo sono molto importanti perché ci permettono di immaginare e di cominciare a costruire un futuro migliore per tante persone che soffrono nell'invisibilità. Grazie a tutti voi che siete impegnati nella ricerca, fa davvero la differenza.
Hi, this is Duran Corlett from ME Support IOM, based in the Isle of Man, and we were delighted to hear that a conference is being held in Portugal about ME, and well done to all involved with the organisation. It's so important that more is done to help people with ME and their families and their carers and all of those that were affected by this disease, which can in some cases be extremely debilitating. Our hope is that more research is done and that more medical professionals understand the condition so that they can give out good quality advice. We remain disheartened when people with ME attend appointments or are admitted to hospital and their symptoms are exacerbated through poor advice. We hope the pandemic has been and will remain to be a catalyst for improvements in post-viral illness, healthcare, and that the conference in Portugal is in itself a catalyst too. Best wishes.
A MSFC é uma doença pouco conhecida no nosso país. É necessário aumentar a sensibilização dos profissionais de saúde para esta patologia, permitindo que os doentes consigam ser diagnosticados mais precocemente e obtenham também melhor acompanhamento e tratamento.
Na MIOS temos sentido nos últimos anos um aumento no número de contactos, quer de pessoas com sintomas compatíveis com o diagnóstico de EMSFC e que procuram recomendação de médicos para avaliação, bem como de doentes recém-diagnosticados, alguns após infecção por Covid. Esperamos que, na sequência desta primeira Conferência Internacional sobre Encefalomielite Miálgica, Síndrome de Fadiga Crónica e COVID-Longa e as parcerias que se estão a estabelecer entre diversas entidades, o conhecimento sobre estas patologias seja ampliado para o benefício dos doentes. O futuro está nas mãos de cada um de nós. Contamos convosco, contem connosco.
Hi, I'm Sonia Chaudhry, Chief Executive of Action for ME in the UK and co-chair of the World ME Alliance. I'm so proud to be part of an incredible global community creating change for people with ME and know that we can accelerate this by working together. Clinical education can make a real meaningful difference today, while we hope that research will lead to effective treatments and one day a cure. Thank you to everyone in this community for doing your bit.
Hi, I'm Saskia de Wit from the Netherlands. On behalf of ME/CVS Nederland, I'm wishing you a fruitful conference where researchers, health professionals and patients can meet and join forces to find ways ahead to improve the life of so many. Thank you everyone and have fun.
Hola, soy María Richardson, parte de Millions Missing México, y me emociona mucho esta primera conferencia internacional en Portugal, que además de avanzar la investigación y educación biomédica en torno a la encefalomielitis miálgica y Long COVID, amplía el acceso a muchas personas en Latinoamérica y nos recuerda que estas enfermedades destruyen vidas en todos los idiomas alrededor del mundo.
Bonjour, ici Louise de Millions Missing France. Nous souhaitons l'arrêt des prescriptions de rééducation à l'effort en cas de malaise post-effort et la formation des professionnels de santé à ce symptôme si handicapant. Nous souhaitons une recherche scientifique coordonnée et fondée sur des critères de sélection stricts avec des groupes contrôle, avec ou sans malaise post-effort. Un immense merci à tous les participants et à nos collègues lusophones pour l'organisation de cette formidable conférence.
I learnt that ME can be debilitating.
I have learned that every ounce of energy is precious.
E che non posso fare tante cose alla volta.
Aprendí que tengo una enfermedad que está entre las de peor calidad de vida.
I've learned that I'm extremely resilient.
I learned that my old life had gone.
I have learned from ME that available energy is not the same every day.
I learned that there's such a thing as being so exhausted that you can't even go to sleep.
I learned that it's okay to have a bad day.
I learned that you can be very sick and it may not show from appearance or ordinary tests.
I learned that many healthcare professionals have serious misconceptions about my disease.
Unless they see it on a daily basis or it happens to them, they don't know what people have to give up.
Estamos abandonados por la sanidad pública. No hay especialistas.
I have learned that people with ME are often housebound or bedbound.
My life is very different from what I thought it would be.
You need a lot more strength, endurance and control than I could have ever imagined during my dancing career.
It's not easy to live with ME.
You must trust what patients tell you.
Will you learn from me?
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 dia a todos e a todas. O meu nome é Bárbara Gonzalez, sou professora universitária e investigadora na área da psicologia. Fui diagnosticada com encefalomielite miálgica em 2015, portanto há perto de 10 anos, com sintomas como quase todos nós há muito mais tempo, portanto há cerca de 30 anos que já os tinha então por diagnosticar. Tenho um filho, portanto, como quase todas nós, luto para conjugar família, trabalho. Tenho a sorte de ter uma condição moderada ou abaixo disso até, não é? O que me permite, com muito esforço, com muita luta, cumprir minimamente as tarefas que tenho que fazer. E acho que a nossa grande preocupação tem que ir para as pessoas que, infelizmente, são tantas que têm versões severas desta doença e estão invisíveis na sociedade, das quais não se ouve falar e não são vistas. Portanto, que esta primeira conferência, que aguardo com tanta expectativa, possa trazer grandes contributos para a medicina e para que depois a sociedade, nomeadamente os locais de trabalho, etc., possam ganhar também conhecimento sobre esta síndrome e ajudar, sobretudo, as pessoas que dela padecem e a saírem da invisibilidade. Os maiores votos de maior sucesso para esta conferência, à qual também estarei a assistir online. E até lá.
O meu nome é Ana Luísa, tenho 34 anos e sofro de encefalomielite miálgica há 10 anos. Durante os 2 primeiros anos da doença, tive um diagnóstico de depressão. Fui medicada e acompanhada em concordância com esse diagnóstico, mas continuei a piorar. Eventualmente dei por mim incapaz de prosseguir uma vida normal e procurei outras respostas. A encefalomielite miálgica foi a resposta que obtive. Rapidamente apercebi-me que este diagnóstico era um vazio. Apesar de me ter descarrilado a vida, não tinha significado para familiares, profissionais de saúde ou para a sociedade em geral. Mais do que uma resposta, a encefalomielite miálgica revelou-se uma pergunta. Espero que esta conferência seja o início da resposta para pessoas como eu e para muitos outros que nem conseguiram ter chegado ao diagnóstico perante o vazio de conhecimento e reconhecimento em Portugal. Agradeço profundamente a todos os intervenientes. Obrigada.
Olá! Venho aqui contar a minha história e lembrá-los do quanto é fácil colocá-los uns contra os outros. Ainda mais vocês que não sabem lidar com as próprias limitações. Ainda me lembro daquela primeira febre epidêmica no hospital de Londres e como foi fácil para vocês darem o caso por concluído. As palavras ainda ressoam aos meus ouvidos. Surto não resolvido. Se era eu... Vocês nunca saberão, e não sou eu que vou dizer, já que confundir a mente de vocês e vê-los perdendo o jogo de cintura tornou-se a minha piada diária. Gosto de rir da forma como vocês perderam a escuta, ou nunca tiveram-na. Às vezes me pergunto se é tão difícil assim lidar com tanta impotência, a ponto de ficarem surdos. Eu não saberia dizer, depois de tantos anos saindo por cima... Vocês se lembram daquela nova infecção na Islândia? Foram cerca de 70 surtos de doenças semelhantes. As manchetes não cessavam. Epidemia inexplicável em convento. Vírus da fadiga? Novo tipo de pólio? Gripe misteriosa? Ponto para mim. Isso é, vocês jamais saberão. Já que os casos foram arquivados de forma inconclusiva, confesso que adoro isso em vocês. A cada dia que se passa, o jogo se torna mais fácil. Ai, se não fosse tão engraçado assistir de camarote os conflitos entre vocês. Me pergunto quando foi que vocês perderam a lógica do funcionamento do corpo humano, porque dessa lógica eu entendo bem. E posso dizer, está tudo claramente interligado. Vocês realmente acreditam que é possível separar o psicológico do físico? Quanta bobagem! É no mínimo curioso como o indivíduo perde energia, que já não tem, se questionando sobre sintomas exacerbados e tão evidentes. por terem ouvido. É psicológico, é coisa da sua cabeça, de alguém que não estava disposto a lidar com a própria falta de saber. Deve ser mais fácil dizer isso do que se perder em investigações. E te digo mais, não faz muita diferença saber o que vem primeiro, se é o ovo ou a galinha. É apenas óbvio que eles dependem um do outro e afetam um ao outro, em maiores e menores proporções. Quando foi que vocês se esqueceram que conhecimento nunca é demais? Ainda me lembro daquela possível epidemia de mononucleose, ou talvez uma possível síndrome viral que era caracterizada por fadiga extrema e debilitante, além dos problemas cognitivos. Os resultados laboratoriais não identificaram causa viral e nem anormalidades no sistema imune. Em vez dos pesquisadores cogitarem que se tratava de algo que poderia envolver critérios ainda não conhecidos, resumiram tudo aquilo em histeria pura e foram esquiar. O mais engraçado disso tudo, mais de 30 anos depois, eu ainda não faço parte dos conteúdos abordados nas aulas das faculdades que são voltadas para a área da saúde, mesmo com o estrago que eu faço. São sintomas persistentes por mais de 6 meses de fadiga extrema, disfunção gastrointestinal, dores, alterações cardíacas, problemas cognitivos, tontura ou náusea, distúrbio do sono e mal-estar após esforço. Ainda assim, não há nada melhor do que me deliciar com a confusão que vocês fazem entre vocês mesmos. Afinal, é impagável me deparar com os pacientes desamparados em meio a tantos sintomas físicos e psíquicos. Ainda me lembro daquele paciente, aquele que estava com sintomas desautonômicos exacerbados, que nunca viu os seus médicos conversarem entre si, e menos ainda com psicólogos, enfermeiros, fisioterapeutas, nutricionistas. O que são mesmo? Ainda dou risada do cardiologista que trocou uma das medicações que interferiu no funcionamento das medicações neurológicas, que atrapalhou os quadros depressivos, e ainda tinha aquele médico, aquele que se achava mais médico do que os outros, e por isso achava que não precisava trabalhar em equipe, que tirou o remédio da pressão e desencadeou outros sintomas gastrointestinais, e ainda assim se recusava a falar com o gastro, que também não tinha interesse nenhum em se comunicar com os outros, muito menos ouvir o psicólogo, que acompanhava o paciente semanalmente. Afinal, o psicólogo nunca sabe de nada mesmo, né? No fim de tudo, o paciente seguiu desamparado, tomando decisões que nunca esteve apto a tomar, depois de se revoltar com toda a equipe, aquela mesma equipe que só não se destruiu porque nunca soube que era uma equipe. Continuo aqui, firme e forte, cada dia mais presente. Ultimamente sinto que subi de cargo quando me correlaciono ao pós-Covid. Às vezes, ainda me pego imaginando quantos ou quais dos seus precisarão ser atingidos para que eu seja levada a sério e então comecem a perceber o indivíduo como um todo. Assinado encefalomielite miálgica, a vulgo síndrome da fadiga crônica.
Hi, my name is Christina Baltais and I'm from Toronto, Ontario. I'm a visual artist who's lived with ME/CFS for the past 18 years, which is a really long time. I got sick when I was 20, and for the first decade I was still able to do schooling, but unfortunately my ME/CFS progressed. And in the past 8 years, I've been using visual arts, so sculpture, collage art, just any form of art I can to raise awareness and to just really educate others about how marginalized and misunderstood this disease is, how there's no treatment, there's no cure, and most doctors don't even know what it is.
Invisible exertions. This photo series depicts how the weight of everyday objects changes in ME/CFS. This makes activities of daily living incredibly challenging. Any exertion, mental, physical, emotional, can also set off post-exertional malaise, the hallmark of this disease. Struggling to find the words. A hard-to-describe symptom of ME/CFS is brain fog. It has significant impacts on a person's ability to read, carry on a conversation, comprehend information, remember anything, and find the words to be able to communicate. Slow and steady. Pacing is critical in ME/CFS to avoid progressing the disease. This collage is about adopting a new relationship with life that centers the mantra, "My pace, not a race." How small a world can become. This nesting doll set shows using size and color how contracted one's world can become when you live with ME/CFS. This set starts at life before ME and moves through the spectrum of the disease until it reaches very severe ME. When a wooden shell is removed, it represents a further shedding of abilities, the functional capacity to work, exercise, socialize, study, travel, and have hobbies. The very smallest shell contains a tiny blue rose within it, representing a human being that must persist amidst extreme confinement and isolation, tending and mending. This collage is about the constant care and checking in with one's own body when living with ME. It also speaks to the language of pain, whether it's radiating, stabbing, shooting, pulsating, burning, dull, or migrating. Life is like a box of chocolates. This collage symbolizes how unpredictable my health is day to day, let alone hour to hour. Like this box of chocolates, I never really know what I'm going to get.
Olá, meu nome é Ivana, eu sou portadora da encefalomielite miálgica, a vulgo síndrome da fadiga crônica. Trata-se de uma doença multissistêmica extremamente estigmatizada. Vamos combinar que esse nome não favorece também, né? Ele não ajuda. É muito comum a gente falar esse nome e a pessoa virar e falar, fadiga eu também tenho, enfim, eu também estou cansado. Fadiga, por si só, é apenas um dos sintomas que se apresenta no quadro de um paciente com síndrome da fadiga crônica. É muito comum que ele tenha sintomas gripais, dores, dor de cabeça, intolerância ortostática, alterações cardíacas. Uma característica muito marcante na síndrome da fadiga crônica é o PEN, que é o mal-estar pós-esforço. Então, muitos pacientes desencadeiam crises após esforços físicos, psíquicos ou mentais. Brain fog, disfunção gastrointestinal, urgência urinária, diversos outros sintomas. Existem pacientes com um quadro muito grave mesmo, que são pacientes que não conseguem levantar da cama, que não conseguem conversar por muito tempo e nem conseguem procurar ajuda, né? Normalmente os exames desses pacientes tendem a não apresentar alterações, o que torna ainda mais difícil esse processo de diagnóstico, porque ainda não existe um biomarcador específico. Encefalomielite miálgica, síndrome da fadiga crônica, doença multissistêmica que desencadeia a disfunção dos sistemas imune, neurológico, endócrino e metabolismo energético. Sintomas persistentes por mais de 6 meses de fadiga extrema, dores, problemas cognitivos, intolerância ortostática, mal-estar pós-esforço, alterações cardíacas, sintomas gastrointestinais, distúrbios do sono, tontura ou náusea.
Pacientes com CFS muito graves experimentam níveis profundos de sofrimento e sintomas extremos que podem ser fatais. Eles são semelhantes a um paciente gravemente enfermo 24 horas antes de morrer, exceto que vivem assim por anos e anos. Pessoas com CFS muito grave ficam na cama o dia todo e dependem de cuidados. Eles precisam de ajuda na higiene pessoal e na alimentação e são muito sensíveis aos estímulos sensoriais. Algumas pessoas podem não conseguir ingerir alimentos e precisam ser alimentadas por sonda. Pacientes muito graves têm deficiência de energia e fraqueza extrema que podem torná-los incapazes de se mover e falar. Eles também têm uma resposta anormal ao esforço, o que significa que a atividade física, cognitiva ou emocional pode fazer com que se deteriore a ME por semanas ou até meses. Muitos pacientes também não toleram ficar de pé devido a tonturas, palpitações e sensação de desmaio. Eles são frequentemente hipersensíveis à luz, som, toque, movimento, temperatura e cheiros. Eles também podem precisar da ajuda de um cuidador para se comunicar. O NICE recomenda um ambiente de baixo estímulo, por exemplo, uma sala escura e silenciosa com interação em um nível de sua escolha, podendo haver pouca ou nenhuma interação social. Recaídas são comuns e pacientes muito graves são extremamente vulneráveis com margem mínima ou nenhuma margem de erro. Mesmo pequenos erros podem resultar em deterioração prolongada e severa. O NICE recomenda que cada interação seja avaliada quanto ao risco para garantir que os benefícios superem qualquer dano potencial. A maioria dos médicos não teve treinamento formal. Muitos acham que é psicológico e alguns nem acreditam na condição. Erros de diagnóstico e tratamento inadequados são comuns. Alguns pacientes têm problemas para ingerir alimentos e requerem alimentação por sonda ou suporte nutricional, mas isso geralmente é adiado ou, em alguns casos, negado. Recentemente, houve 2 casos de alto perfil de pacientes que receberam apoio negado, e um inquérito sobre a morte de uma pessoa devido à negligência médica está em andamento.
Need to light myself up a little bit.
Should I hold that for you?
I'm getting really exhausted.
Okay, you can stop. Should I try to do it for you?
I didn't think this was going to tire me out this much. I don't even know if it's working. You see me?
Yeah.
We had to stop after like 5 minutes.
It was actually 1 minute.
And feels like my arms weigh like 100 pounds. I feel paralyzed. I'm not paralyzed, but I feel paralyzed. And I know if I do anything extra, it's going to get worse. And this hasn't happened in a long time. And it feels difficult to pick up my food to eat. I'm doing it anyways. I don't know if I'm going to ask Mom to do it or not, but right now I'm doing it. But I'm probably going to be like this for at least 2 hours. Hopefully 1. I don't know. In the past, when I got like this, it happened for, days at a time. Hopefully with the Abilify, it's better. But I haven't crashed in a long time. It's scary. I don't really remember the protocol other than not moving. But Yeah, it just feels like every cell in my body's dying. Just cement block on my chest, my arms weigh 50 to 100 pounds. Maybe not literally. Maybe they weigh 20 to 30 pounds heavier. I don't know. Talking probably isn't any good for me right now.
Okay. Thank you, sweetie.
I can't lift my arms to feed myself, so we're doing the soup through a straw. And I feel like I'm dying. And I don't want to talk anymore. Bye.
I got a virus.
I didn't die.
But I never recovered.
1 year later.
8 years later.
16 years later.
20 years later.
I still can't live my life.
I'm still housebound.
And bedbound.
I can't work.
I cannot do a normal job.
I can't look after myself.
I have missed my daughter's childhood.
I can't play with my kid.
I'm now diagnosed with the chronic illness.
Myalgic encephalomyelitis.
ME.
ME is a complex multisystem disease. The key feature is post-exertional malaise, which is a worsening of symptoms after cognitive, emotional, physical, or other exertion.
My GP recommended that I increase my activity levels.
My specialist told me that the national recommendation is graded exercise therapy.
Graded exercise therapy?
Graded exercise therapy.
This made me worse.
Much worse.
Graded exercise therapy is harmful for patients with ME. because of this key cardinal feature of post-exertional malaise. What is happening is that patients, when they exercise, get worse.
I went from being able to walk down the street to being reliant on a wheelchair.
To being bedbound for a year.
I had to buy a walking stick.
The story is a variation on the same theme, but it's very much the same. Someone is well and fit, and then suddenly they're functioning at a fraction of their pre-illness capacity.
I wish I'd allowed my body the time to rest,
instead of pushing through.
I wish the recommended therapy hadn't made me and thousands of others worse.
The guidelines are now being rewritten.
But until they're finalised, this harmful recommendation of graded exercise therapy remains in place.
We need change now.
Before I had ME myself, I had very little exposure and understanding to and of patients with ME. I had a vague notion it may have been related to deconditioning or burnout, but as soon as I became unwell with this illness, I realised that that was completely wrong. This is a severe, complex neuroimmune condition.
It is possible that COVID-19 unfortunately will lead to an increase in the number of people with ME. We think this because there has been a variety of studies, one of which in Australia found that about 10% of people who had had one of 3 or so viral infections after 6 months had fatigue syndromes. Therefore, I think probably a 10% level is what we might and should expect. So the research that we need to pursue as scientists in COVID-19 and post-viral fatigue are 2 types. There's one which is epidemiology. So this is all about how many people experience prolonged fatigue after COVID-19 symptoms. And then the second is different. It's biomedical. It's working out why many people recover well and a substantial minority do not. And that's understanding the biology, the underlying causes, the biomolecular causes of risk of getting fatigue.
Coronavirus is a very novel problem, and we are seeing a lot of exciting work coming from research centres, clinicians, international collaboration, and patients and the general public and the government all supporting the drive to get some scientific answers for this new and horrible disease. And what we need to do is see the same sort of movement in finding a cure for ME.
What I'd like to say is that I hope that I'm not right. I hope that there isn't an upsurge in the number of cases with initially post-viral fatigue and then diagnoses of ME. I hope that that's not the case. But if it is, then I think a far larger number of our population in this country and abroad will have a better understanding of those who have lived with ME for many, many years.
I wish I could go and watch live football again.
I want to climb mountains again.
I want to be able to run again.
I want to sing and dance again.
I want a proper social life.
I want to be the best parent I can be.
I want my life back.
I want to be able to live my life again.
I want to be independent again.
I want to be free from pain.
I want to get up for more than 4 hours a day.
I want to join the real world.
I want to be able to go out of the house.
I want to be able to do something for longer than 40 minutes before having to lie down.
I want to hold my head upright, at least most of the day.
I want to listen to loud music and dance wildly.
I want to go.
I just want to be able to go downstairs and sit in my garden. I want to leave my bed.
If any of these are going to happen,
We need treatment that helps, not harms.
We need
biomedical research to better understand this disease.
We don't want anyone to go through what we're going through.
We got viruses from which we didn't recover.
We don't want that to happen to you.
Olá, meu nome é Priscila Falcão, tenho 46 anos, sou brasileira e há quase 7 anos sou portadora de encefalomielite miálgica, ou síndrome de fadiga crônica. Durante 5 anos eu vivi a saga em busca de descobrir o que estava acontecendo de errado com o meu corpo. Foram 5 anos de dúvidas, de ansiedade e busca por uma resposta. Hoje, após quase 2 anos de diagnóstico fechado e mesmo aliviada de saber o que está acontecendo com o meu corpo, a angústia pela falta de respostas e as dúvidas ainda prevalecem. O portador de encefalomielite miálgica precisa de qualidade de vida, de apoio e principalmente precisamos ser vistos. Hoje eu uso um pouco de energia que eu tenho para informar e dar visibilidade a essa doença que afeta milhões e milhões de pessoas no mundo e ainda assim é considerada invisível. Não, nós existimos. Obrigada a todos que farão dessa conferência um passo muito importante para as nossas vidas. Muito obrigada.
Hi everyone, my name is Sian Leary and I am Head of Advocacy and Communications at the World ME Alliance. We are thrilled to be standing in solidarity with Portugal for its first ever international ME conference. ME is a global health crisis, and so global collaboration is vital, especially as we are seeing millions more develop the condition post-COVID. This conference is a crucial step, and we hope it will spark substantial and sustained change for people with ME in Portugal and beyond. So thank you for your commitment to a world where ME is better understood, is researched and is conquered together.
Sono Giada Da Ros, presidente della CFS and Associazione Italiana. L'encefalomielite mialgica è una malattia devastante che distrugge vite. È una tortura quotidiana, costante per chi ne soffre in modo severo ed è comunque invalidante anche per chi ce l'ha in modo meno grave. Incontri come questo sono molto importanti perché ci permettono di immaginare e di cominciare a costruire un futuro migliore per tante persone che soffrono nell'invisibilità. Grazie a tutti voi che siete impegnati nella ricerca, fa davvero la differenza.
Hi, this is Duran Corlett from ME Support IOM, based in the Isle of Man, and we were delighted to hear that a conference is being held in Portugal about ME, and well done to all involved with the organisation. It's so important that more is done to help people with ME and their families and their carers and all of those that were affected by this disease, which can in some cases be extremely debilitating. Our hope is that more research is done and that more medical professionals understand the condition so that they can give out good quality advice. We remain disheartened when people with ME attend appointments or are admitted to hospital and their symptoms are exacerbated through poor advice. We hope the pandemic has been and will remain to be a catalyst for improvements in post-viral illness, healthcare, and the conference in Portugal is in itself a catalyst too. Best wishes.
A MSFC é uma doença pouco conhecida no nosso país. É necessário aumentar a sensibilização dos profissionais de saúde para esta patologia, permitindo que os doentes consigam ser diagnosticados mais precocemente e obtenham também melhor acompanhamento e tratamento.
Na MIAS temos sentido nos últimos anos um aumento no número de contactos, quer de pessoas com sintomas compatíveis com o diagnóstico de EMSFC e que procuram recomendação de médicos para avaliação, bem como de doentes recém-diagnosticados, alguns após infecção por Covid. Esperamos que, na sequência desta primeira Conferência Internacional sobre Encefalomielite Epidemiologic, Síndrome de Fadiga Crónica e COVID-Longa e as parcerias que se estão a estabelecer entre diversas entidades, o conhecimento sobre estas patologias seja ampliado para benefício dos doentes. O futuro está nas mãos de cada um de nós. Contamos convosco. Contem connosco.
Hi, I'm Sonia Chaudhry, Chief Executive of Action for ME in the UK and co-chair of the World ME Alliance. I'm so proud to be part of an incredible global community creating change for people with ME and know that we can accelerate this by working together. Clinical education can make a real meaningful difference today, while we hope that research will lead to effective treatments and one day a cure. Thank you to everyone in this community for doing your bit.
Hi, I'm Saskia de Wit from the Netherlands. On behalf of ME/CVS Nederland, I'm wishing you a fruitful conference where researchers, health professionals and patients can meet and join forces to find ways ahead to improve the life of so many. Thank you everyone and have fun.
Hola, soy María Richardson, parte de Millions Missing México, y me emociona mucho esta primera conferencia internacional en Portugal, que además de avanzar la investigación y educación biomédica en torno a la encefalomielitis miálgica y Long COVID, amplía el acceso a muchas personas en Latinoamérica y nos recuerda que estas enfermedades destruyen vidas en todos los idiomas alrededor del mundo.
Bonjour, ici Louise de Millions Missing France. Nous souhaitons l'arrêt des prescriptions de rééducation à l'effort en cas de malaise post-effort et la formation des professionnels de santé à ce symptôme si handicapant. Nous souhaitons une recherche scientifique coordonnée et fondée sur des critères de sélection stricts avec des groupes contrôle, avec ou sans malaise post-effort. Un immense merci à tous les participants et à nos collègues lusophones pour l'organisation de cette formidable conférence.
I learnt that ME can be debilitating.
I have learned that every ounce of energy is precious.
E che non posso fare tante cose alla volta.
Aprendí que tengo una enfermedad que está entre las de peor calidad de vida.
I've learned that I'm extremely resilient.
I learned that my old life had gone.
I have learned from ME that available energy is not the same every day.
I learned that there's such a thing as being so exhausted that you can't even go to sleep.
I learned that it's okay to have a bad day.
I learned that you can be very sick and it may not show from appearance or ordinary tests.
I learned that many healthcare professionals have serious misconceptions about my disease.
Unless they see it on a daily basis or it happens to them, they don't know what people have to give up.
Estamos abandonados por la sanidad pública. No hay especialistas.
I have learned that people with ME are often housebound or bedbound.
My life is very different from what I thought it would be.
You need a lot more strength, endurance and control than I could have ever imagined during my dancing career.
It's not easy to live with ME.
You must trust what patients tell you.
Will you learn from me?
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 Bom dia a todos e a todas. O meu nome é Bárbara Gonzalez, sou professora universitária e investigadora na área da psicologia. Fui diagnosticada com encefalomielite miálgica em 2015, portanto há perto de 10 anos, com sintomas como quase todos nós há muito mais tempo, portanto há cerca de 30 anos que já os tinha então por diagnosticar. Tenho um filho, portanto, como quase todas nós, luto para conjugar família, trabalho. Tenho a sorte de ter uma condição moderada ou abaixo disso até, não é? O que me permite, com muito esforço, com muita luta, cumprir minimamente as tarefas que tenho que fazer. E acho que a nossa grande preocupação tem que ir para as pessoas que, infelizmente, são tantas que têm versões severas desta doença e estão invisíveis na sociedade, das quais não se ouve falar e não são vistas. Portanto, que esta primeira conferência, que aguardo com tanta expectativa, possa trazer grandes contributos para a medicina e para que depois a sociedade, nomeadamente os locais de trabalho, etc., possam ganhar também conhecimento sobre esta síndrome e ajudar, sobretudo, as pessoas que dela padecem e a saírem da invisibilidade. Os maiores votos de maior sucesso para esta conferência, à qual também estarei a assistir online. E até lá.
O meu nome é Ana Luísa, tenho 34 anos e sofro de encefalomielite miálgica há 10 anos. Durante os 2 primeiros anos da doença, tive um diagnóstico de depressão. Fui medicada e acompanhada em concordância com esse diagnóstico, mas continuei a piorar. Eventualmente dei por mim incapaz de prosseguir uma vida normal e procurei outras respostas. A encefalomielite miálgica foi a resposta que obtive. Rapidamente apercebi-me que este diagnóstico era um vazio. Apesar de me ter descarrilado a vida, não tinha significado para familiares, profissionais de saúde ou para a sociedade em geral. Mais do que uma resposta, a encefalomielite miálgica revelou-se uma pergunta. Espero que esta conferência seja o início da resposta para pessoas como eu e para muitos outros que nem conseguirão ter chegado ao diagnóstico perante o vazio de conhecimento e reconhecimento em Portugal. Agradeço profundamente a todos os intervenientes. Obrigada.
Olá! Venho aqui contar a minha história e lembrá-los do quanto é fácil colocá-los uns contra os outros. Ainda mais vocês que não sabem lidar com as próprias limitações. Ainda me lembro daquela primeira febre epidêmica no hospital de Londres e como foi fácil para vocês darem o caso por concluído. As palavras ainda ressoam aos meus ouvidos. Surto não resolvido. Se era eu... Vocês nunca saberão, e não sou eu que vou dizer, já que confundir a mente de vocês e vê-los perdendo o jogo de cintura tornou-se a minha piada diária. Gosto de rir da forma como vocês perderam a escuta, ou nunca tiveram-na. Às vezes me pergunto se é tão difícil assim lidar com tanta impotência, a ponto de ficarem surdos. Eu não saberia dizer, depois de tantos anos saindo por cima... Vocês se lembram daquela nova infecção na Islândia? Foram cerca de 70 surtos de doenças semelhantes. As manchetes não cessavam. Epidemia inexplicável em convento. Vírus da fadiga? Novo tipo de pólio? Gripe misteriosa? Ponto para mim. Isso é, vocês jamais saberão. Já que os casos foram arquivados de forma inconclusiva, confesso que adoro isso em vocês. A cada dia que se passa, o jogo se torna mais fácil. Ai, se não fosse tão engraçado assistir de camarote os conflitos entre vocês. Me pergunto quando foi que vocês perderam a lógica do funcionamento do corpo humano, porque dessa lógica eu entendo bem. E posso dizer, está tudo claramente interligado. Vocês realmente acreditam que é possível separar o psicológico do físico? Quanta bobagem! É no mínimo curioso como o indivíduo perde energia, que já não tem, se questionando sobre sintomas exacerbados e tão evidentes. por terem ouvido. É psicológico, é coisa da sua cabeça, de alguém que não estava disposto a lidar com a própria falta de saber. Deve ser mais fácil dizer isso do que se perder em investigações. E te digo mais, não faz muita diferença saber o que vem primeiro, se é o ovo ou a galinha. É apenas óbvio que eles dependem um do outro e afetam um ao outro, em maiores e menores proporções. Quando foi que vocês se esqueceram que conhecimento nunca é demais? Ainda me lembro daquela possível epidemia de mononucleose, ou talvez uma possível síndrome viral que era caracterizada por fadiga extrema e debilitante, além dos problemas cognitivos. Os resultados laboratoriais não identificaram causa viral e nem anormalidades no sistema imune. Em vez dos pesquisadores cogitarem que se tratava de algo que poderia envolver critérios ainda não conhecidos, resumiram tudo aquilo em histeria pura e foram esquiar. O mais engraçado disso tudo, mais de 30 anos depois, eu ainda não faço parte dos conteúdos abordados nas aulas das faculdades que são voltadas para a área da saúde, mesmo com o estrago que eu faço. São sintomas persistentes por mais de 6 meses de fadiga extrema, disfunção gastrointestinal, dores, alterações cardíacas, problemas cognitivos, tontura ou náusea, distúrbio do sono e mal-estar pós-esforço. Ainda assim, não há nada melhor do que me deliciar com a confusão que vocês fazem entre vocês mesmos. Afinal, é impagável me deparar com os pacientes desamparados em meio a tantos sintomas físicos e psíquicos. Ainda me lembro daquele paciente, aquele que estava com sintomas desautonômicos exacerbados, que nunca viu os seus médicos conversarem entre si, e menos ainda com um psicólogo. Enfermeiros, fisioterapeutas, nutricionistas. O que são mesmo? Ainda dou risada do cardiologista que trocou uma das medicações que interferiu no funcionamento das medicações neurológicas, que atrapalhou os quadros depressivos, e ainda tinha aquele médico, aquele que se achava mais médico do que os outros, e por isso achava que não precisava trabalhar em equipe, que tirou o remédio da pressão e desencadeou outros sintomas gastrointestinais, e ainda assim se recusava a falar com o gastro, que também não tinha interesse nenhum em se comunicar com os outros.
Susan. Susan. Já aí vem quando Quando a Susan chegar, eu começo isto. Ah, são estas duas? E mais a Susan. Vocês precisam pôr o microfone. A Susan, quando chegar, diz.
Com licença. Posso pôr na sua orelha? Pode ser? Com licença. Já pomos a fita cola. A senhora tem algum bolso das calças?
Não tenho bolso. Como é que quer pôr? Eu posso segurar se quiser.
Pode ser?
Posso.
Ele já está ligado, não precisa de se preocupar. Quando chegar ao palco, ele fica.
Posso pô-lo na cadeira que acho que não vai ficar sentado, não é?
Sim, pode
ser. Põe na cadeira ao meu lado, ok.
É.
Sim, senhor. Agora é só preciso pôr a fita cola, não é?
Só aqui a fita cola, peço desculpa.
Não faz mal.
Com licença, posso?
Pode. Sim, outra vez. À vontade.
Para ele ficar seguro. Depois eu ia lhe pedir.
Well, welcome. Please sit. Welcome to the afternoon session. Please sit. Obrigado. Isto não é para esta, é só para a outra, mas de qualquer das maneiras.
É para o Advocacy Panel.
É a seguir.
Ai, não é agora?
Não. Nós entramos às 3h30. Well, I invite onde é que o António? Well, to the first session of the afternoon, I invite Dr. Susan Levine. Susan, please, Susan, you come to the floor. António Vaz Carneiro, and to substitute Joanne. She's a little bit tired and she's not able to assess this session. I invite Dr. Dora Sargento. She is a medical doctor and patient also. And this session is going to be a conversation about the role of physician as advocate, lessons learned from 30 years of clinical practice. Antonio?
Thank you, Jaime. We'll speak English, okay? Is that okay?
I hope so. I hope so.
Let me start my French. No, just kidding. No. Chinese, no, you didn't know. Well, good afternoon, everybody. It's a pleasure for me to be here, moderate, replacing Joan, that sometimes she's not that well, and so we allow her to go home, rest a little bit, because we have a dinner tonight, so I want her in good shape. So thank you for inviting me, Jaime, and thank you to our guests here, once again, for staying here with us. This conversation runs around a very singular concept. Can you hear me? Can you hear me?
Where's the microphone?
Hello, 1, 2, 3. Okay, all right. It's better. Okay, all right. So, which is normally we know the diseases. When you talk about acute myocardial infarction, you know what that is. When you're talking about a pneumonia, you know exactly what that is. When you talk about colon cancer, you know exactly what you're talking about. Post-viral syndromes are a unique area that has a higher degree of uncertainty that the normal practice of medicine, normal knowledge of medicine has, which raises very interesting problems, and very singular problems as well, which is, how am I going to show all the stakeholders, society, health professionals, patients, families, media, that this disease really exists. Normally when we talk about this, we are trying to defend a certain disease. Diabetes is very important, but we know exactly what it is. Everybody knows what that is. Here is different. And therefore, there is this huge amount of effort of trying to bring to upfront this, I would say, not new, because we've been talking about post-viral syndrome for the last 40 or 50 years. So it's new. It's not new at all. New is long COVID, but then again, SARS-CoV-2 is also new. But it's not new. It has been here forever. So we are now getting more aware of the existence of this disease. And since it's even the long COVID is a recent disease, but ME, CFS is a long disease, it's very interesting that when you look at pathophysiology, like we discussed so well this morning, it's really, really, really almost the same thing. For me, it was a surprise. I wasn't expecting this.
Right.
But it's an opportunity, a huge opportunity for the patients that are technically abandoned. Nobody believes them. They send to psychiatry and say, well, good doctor. Suddenly, the landscape changed, and we have to take opportunity of this. This is a unique opportunity for several reasons. One of which is long COVID is really important disease. It's going to be more and more. You just have a couple of years. We have a lot of work to do for the next 5, 10, 15, 20, prognosis, short-term prognosis, long-term prognosis. Everything's going to be needed to do a huge amount of research on this, but also because we can drag together this type of diseases and lump them together and discuss them together. Now, there are several stakeholders that can actually assume that responsibility, and certainly the patients are one of them. That's why we organized this meeting, because this was organized basically by the patients. And so certainly, they are very powerful, and if they are well organized, they are unbeatable. Nobody, I used to say, you guys, I invite, this meeting took about a year to organize. When the first time John talked to me, it was about a year ago. And so we decided to select these very, very high top quality people in the world. And I said to her, they're not going to come. Mm-hmm. There are very busy people. And she said, there are two groups of people in which these experts come. If the meetings are organized by patients or by medical students. And she was right. Mm-hmm. Because every single time that I invited you, you always said yes. So I'm really, really grateful. Uh-huh. And this part of our meeting today is just basically reflecting on, we know about the importance of patients. Let's now talk about the importance of doctors and healthcare professionals. I will even, go beyond doctors. What should we do? What is your experience in terms of trying to change things? With whom do you speak? Mm-hmm. What is good? What is a good idea that we should do on the short term, or on the long term? So I'll start with Susan. Dora, as a major advantage, she is a patient, but she's also a doctor, so she understands this much better than most of the concept of this. So, Susan, if I was going to be a champion of this disease, of this pathology, what advices would you give us?
Well, yeah, obviously I've thought about this for a long time, and I always say that I've been doing this for 30 years plus, but things really haven't changed very much. And I think I've certainly learned so much in the last 3 decades of practice from my patients, and I've tried to hone down, and so I thought I was going to interview Joan, actually. So I was going to demonstrate just my in-office interaction with my patient. So my first thing is, how did you get this? What were the circumstances under which you became sick? By that I mean, was it an acute event? Was there a trigger? Can we find something tangible that you can link to the onset of your illness? So that's one of my first questions. Sometimes it's obvious to the patient and sometimes not, but that's my sort of lead-in question. Dori, I'm going to answer your larger question in a minute, and then based on what I've learned about, and we know now a lot about comorbid disorders, frequently there's a clue elsewhere in the patient's history. Oh, I was perfectly healthy before this, but then you ask, did you have migraine headaches? Did you ever faint as a child on the baseball field, for instance? Did you ever have irritable bowel syndrome, or have you had allergies or eczema as a child? So these are risk factors, we think, that I've learned about through the last decade or so of studying this as part of a multi-center group that we've got going on in the US that's looking at potential risk factors for this. So I've sort of introduced that element into the practice based on what I've learned there. And so we sort of continue the conversation. But to answer your larger question about what my wish list for this illness is to really have it be something that's mandatory in the curriculum for medical students to learn about. And also, as part of postgraduate training, for instance, I trained in infectious disease, did my fellowship, as a mandatory rotation, because frequently we learn only about those immediate diseases like AIDS or something like that that's going to kill you right away, or meningitis, the more dramatic diseases. But these diseases, the chronic fatigue syndrome, ME/CFS among them, are stealthy. They just come upon you slowly, mysteriously, and then they take away your life. They take away your breath. But yet they're also invisible illnesses, because everybody looks okay when they walk in the office. Their lab tests are mainly okay. So the main take-home thing is to really believe your patient about the symptoms, even in the absence of a positive blood test, to really take this journey with your patient and be willing to, surrender your sort of scientific need to have a positive test or, evidence-based medicine, but to query it and to take this journey with your patient, basically.
Thank you, Susan. Now, Dora, you have a special role here, in the sense that we just talked. If you want to make this disease more visible, with whom should we talk? Whatever you feel like, I need to do something about the overall picture of this, with whom should we talk?
It's very difficult, and I'm with a double paper here, yes. And Susan, if you want, you can ask me.
Oh, okay.
You can interview me as you will do with John.
Yes.
It's very difficult for us as a patient, and I feel that, because the psychiatric adjustment for us, it's huge. And I think everyone here in this class, in this room, has got that mark on their shoulders and their heads. And this disease has not a biomarker, has not a classification that we do, as you said, Professor, before, diabetes, age, we have got a lot of markers, as we do in Sjogren's syndrome, as we do in rheumatoid arthritis. we've got markers that we can do, that we can classify a patient. Here, we don't have any kind of markers. And if you correct me, Susan, if I'm wrong. And we need that to say to our patient, you've got this disease, and this is how we are going to treat you. In long COVID, we don't have that. And I, as a patient, feel that always. I try to ask help with internal medicine, my specialty. Nothing happens. I try to help with my cardiologists, and I am a lucky girl, okay? Because I had a marker. I had a myocarditis and I had a pleural effusion, okay? I'm a lucky one because I'm not crazy, okay? I think that's the difference, because I've got everything that you've got, but I also have got a causal for my chest pain, my cardiac arrhythmics, okay, it's different. I'm the lucky one. But I don't have biomarkers also.
Let me ask you a question, if I might.
Yes.
When you were practicing and you encountered a patient with non-COVID ME/CFS, did you, not exactly write them off, but did you take them less seriously than you would now, having had it yourself? Do you know what I mean? Like once you experience...
I understand you. Yes. My experience make me see different things now. Because COVID, I think COVID has turned all medicine around, everything. Because we saw now things different. 5 years ago, even though we know that other viruses like Epstein virus, like CSM viruses, do also a post-infectious fatigue syndrome, but not too long.
Right.
We now see this in our medicine, in our practice, and it turns out that even, and I don't think so, I think that probably less frequently we don't look at them with these eyes, but our elderly people have also COVID infections, and they are more fatigued, more difficult in walking, more difficult in doing their home things usually.
Right, sure.
And we don't look them as a post-COVID syndrome. We say, oh, they are getting older, but they have also this syndrome.
Right.
Yes, I experienced that because this is a disease that we have got to be alert of.
Now, when you see let's say you go to your cardiologist and they don't know what to do with the myocarditis, and you're just sort of dissatisfied with their care, do you kind of do your own research and tell them, like, this is what I found?
Yes. The first time I went to my cardiologist, I do an Holter. It's in a 24 hours ECG. Right. And my cardiologist tell me, Dora, you are freaking off. You've got to do a spa. You've got to do yoga because you've got a frequency of 115, 2,000 to 200, sorry. And it's a Saturday morning. Why are you like that? You are freaking off. You've got to do yoga. You've got to do gym. You've got to work out. Okay. I said, okay. And she'd give me a beta blocker. Okay. 1 month after, she called me back, Dora, sorry, I went to a conference of cardiologists and they spoke the first time of the tachycardic paroxystic orthostatic, and you don't have nothing on your mind. You've got a post-COVID complication of myocarditis.
That's a good outcome.
Yes, it's a good outcome.
But at least you know what you have.
Yes.
Really important.
So they are afraid of the complications of the myocardic. Right. They don't know what to do. Yes. But I think it's not only here. I think it's worldwide, right? Yeah. And I think that's why I'm here, and that's why I think it's very useful and it's very important for us to try to understand what is the problem, what organs COVID affects, because it's not only the brain. It's also a neurological complication, cardiology complication, pulmonary complication, ophthalmologic complication. And I think we are way far away from the diagnosis and from the major complications and the treatment also.
So do you feel some satisfaction? Well, at least with that doctor came around a little bit, but some of the other, like if you went to see a rheumatologist or if you saw a neurologist, would they do an MRI of the brain? Would they know what to do you think?
No. I find the best rheumatology I could have, Professor Jaime Branco here present, that was very, very careful. And he told me, I don't know what you have, and I will not give you any medication, and probably I will not give you the answer you are trying to have, because it's true. Okay, I've got an inflammatory process, huge inflammatory process, and at the beginning I don't have any markers for a syndrome, an autoimmune syndrome, but perhaps at the end it will come to that end or not. I don't know. He will probably tell me some years later or sometimes.
Do you experience post-exertional malaise?
Yes.
Yeah.
Yes.
So like coming here today, you'll be in bed for a couple of days.
I had difficult to do any kinds of effort. Yes, I do, but with a lot of consumption of energy and with very difficult, even in spoken. At the telephone, it's awful for me to spoke. It's very difficult.
And too much stimulation, like listening to TV or even the lights.
Yes, lights is horrible. And I had before headaches when I was young. Afterwards, I stopped having headaches. And with the infections of COVID, headaches turn on again and worsen even more. And coming back again to what you are asking me, Susan, now about the neurologist. Meantime, one time after the COVID, I had similar like an ischemic transitory accident. 2 hours without even can spoken everything. I didn't know what it is. I didn't know what a glass was. I didn't name water. And I went to the hospital. I do MRI, and they didn't know what it was. The MRI was
okay.
Normal. And they proposed me to start on statins and on aspirin. I didn't start both because I had myalgias. And statins can agree more, and I stayed like that. And I, as a physician, not as a patient, because it's difficult to adequate both. I thought it was more a complication of long COVID. And it's past 2 years, and I'm equal, never get again.
You haven't improved at all? Have you had any days where you almost feel your old self?
Some days I feel it's all better. I'm as new. I don't feel any pain. I can do all things, and next day I wake up and it's awful again. It's awful, and even worse the day afterwards.
Do you feel, despite your daytime fatigue, that you have trouble sleeping?
Yes. The sleeping, it's not recomfortable. No, not recomfortable. The day afterwards, it's.
And do you get temperature dysregulation? Do you feel excessively cold or hot? None.
Oh, I've been all over my life. I've very cold. Yes. This not.
And now you had told me you got it a total of 5 times.
5 times, yes.
Were there any differences in the impact of the different infections? Like, was your first infection the worst one, or when you got it
The first infection was the worst of all. It was very intense, fever, myalgia, headache, a horrible headache. I had a flu-like syndrome. Saturation was 89, 19 at home. I didn't went to the hospital because I know where were the hospitals. And bilateral conjunctivitis. Yes, an
you mentioned that.
Yes.
Yeah. Uh-huh.
And afterwards, I never recover the ophthalmological visual.
Do you have this as a side thing? Do you have home tests for COVID here?
Yes, we
and
have.
Then you go get it. You get a PCR at the hospital.
No, yes, the PCR always confirm the PCR in the hospital, and the three other times were also symptomatic, and I feel all the prodrome syndromes, headaches, myalgias, and fever. Then I tested, and it was positive, and I stayed home. And the last one was similar to the first one, and that's when I got myocarditis.
Wow.
It was last one in May. It's going to be one here in May. Afterwards, I stopped to test. Never more tests.
Did you get the vaccinations or the boosters?
Yes, I get vaccination. That was obligated here in Portugal 3 times. Vaccine.
Did you feel any effects of the vaccinations?
A little fever after vaccination, a little fever, and 1 to 2 days of myalgias. Only that, yes.
Okay. And we were talking a little bit in terms of past medical history. Do you have anything that you think would be a predisposing factor?
I think my medical history is a little bit difficult because I've got some other issues, but not correlated with this disease. But I have had before 3 or 4. I think it was 3 times pleural effusion, pericardial effusion in contests. 1 time idiopathic and 2 times after an respiratory infection. That's why I suppose probably a connective tissue, an autoimmune disease in the past. In the past, no, that is not diagnosed.
You don't have any thyroid disease, Hashimoto's?
No. Thyroid's completely normal.
Hypermobility?
No.
No, we didn't talk. I don't think we mentioned that yet at the conference. Yeah. Okay. And any family members with autoimmune disease, your parents or siblings?
No, a cousin with psoriasis and I don't remember more. I don't think so.
Now, having had the experience from both ends, being a doctor and a patient, do you feel hopeful that you can convince the medical profession of the reality of the disease?
Yes, that's why I'm here. I hope that we can all make the difference because...
You're hired.
Sorry?
You are hired.
Yeah, okay, thank you.
I'm not going to pay, but nevertheless you're hired.
Yes, but I was not paid before for being tested.
Just kidding.
Yes. I hope we can do the difference because as a patient, I feel that we are not well supported. I feel that it's a disease that it's not well classified, well supported, well oriented, well treated. And as a physician, I think we don't know a lot of that. So we know a little bit, a very little bit, not only to diagnose, but to treat. And I think it's very urgent that we know how to diagnose. If there is no biological biomarkers, at least some keywords, some 4 to 5 clinical indications that, as you said before, 4 or 5 indications that we can do for at least 6 months, pain, disturbance in sleep, 4 or 5 criteria that makes diagnosis, for we can help the patients to have a diagnosis and orientation and to give them a better life.
So we come to the end of this roundtable. Thank you very much.
Okay, you're welcome.
The idea here was that an expert to interview a patient so we can get a more personal feeling of what this means. Sometimes we're looking at groups of people with these studies and we lack the individual, the individual suffering, which was really why we designed this. Yes, please, a quick question. I'll be happy to answer. Yeah.
My name is Manuela, I'm a nurse, and I'm a mother of a 17-year-old boy that has
A nurse with his mother, a 17-year-old boy. Okay.
Yes.
Because they are
My
here.
son is 17 years old. He has ME about 3 years ago. And I was listening to you. Yes, I've been through there. Your child has a psychiatric problem. He's not okay from his mind. I went to 20 doctors, and no one could told me what Miguel had. And the most difficult part was the lack of sensitivity of the doctors to my kid. This is the day that he does not want to go to a doctor. He tells me, Mommy, doctors, they are dumb. They only look at the computer. They don't talk to me. They treat me like a 5-year-old kid. So, resuming. I sympathize with you and all the people here with ME, but where are our children? In Portugal, is my son the only kid with ME? Nobody talks about this.
Well, thank you very much.
That's what I wanted to say.
Thank you. Okay, Jaime, I think we would like to thank Susan and Dora. Thank you very much once again.
Microphone, please.
I want to give you this.
Well,
thank you, Susan.
I have a comment that is an advice for patients and their families. If you have a doctor for an illness, a disease, or a sum of complaints, you have a doctor. If you have 2 doctors, you have alpha doctor for the same illness. And if you have 3 doctors, you have none doctor, 0 doctors. If you don't like the doctor, you change doctor. You don't sum doctors about the same disease. That's the worst thing you can do about. Okay? And I have 45 years of experience, not 30 years of experience, okay? I'm a doctor since 79. And that's what I give as advice to my patients. If you don't like me, you go to another doctor. If I don't serve you, you go to another doctor. But because patients have several times the need to change doctor, but maintains, I don't know why, the precedent doctor. It's not good for the patient. It's not good for the doctor. It's not good for anybody. Okay. Bon. We go forward, and now we have another video. The next session, Ed Young. It's a Pulitzer winning and in science writer. And he is going to talk about 3 years of covering COVID-long, COVID and ME CFS, what you need to know, lessons learned by Pulitzer Prize winner in an exploratory journalism. This is a previously taped video from Ed Young. Please.
Hello, my name is Ed Young, and it is my honor to conference on clinical scientific advances in ME/CFS and long COVID. Now, I am not an expert on these conditions. I'm not a clinician. I am not someone who has either of these conditions, but I am a journalist who has reported on both long COVID and ME/CFS for the last few years. And I'm here to share what I've learned in learning more about these kinds of illnesses and my approach to telling stories about them. So in the early months of the COVID-19 pandemic, when many people who are now still sick were first infected, the common wisdom was that the coronavirus either sent you to an intensive care unit or, more commonly, caused mild symptoms that resolved after just 2 weeks. But in the late spring, I started seeing trends that did not fit with this narrative. My sister-in-law got infected in March 2020, and she was still burning with fever after 3 weeks, and then 6, and then more. Young and formerly healthy people like Fiona Lowenstein and Mara Gay wrote op-eds about surviving but not recovering. Felicity Callard wrote an amazing piece in the blog called Somatosphere about what mild cases can really be like. But when I interviewed scientists and clinicians about these lingering symptoms in May, most were surprised. One said, "That's unusual." But it wasn't. By May, affected patients had already formed support groups thousands strong. They had coined terms like long COVID and long hauler. The Patient-Led Research Collaborative, or PLRC, had even conducted research on their own communities. And even in March, people with similar illnesses like ME/CFS were warning that this new pathogen would trigger a wave of disability such as what they had long experienced. They knew then what is now abundantly clear. People infected by COVID can be pummeled by months or years of debilitating symptoms, and the same is true for a variety of viral illnesses. I wrote my first piece about long COVID in June 2020. It was one of the first pieces about the condition to appear in a national publication, and in the following days, that story was read by more than 1 million people. I got more than 150 emails from people who thought that they were going mad or had been told that they were going mad, and they felt validated to see their reality, which was so different to the accepted reality of the illness reflected in a big story. And that story was the first of 8, and those responses were the first of thousands more. That work, published in a major national magazine, The Atlantic, helped to catapult long COVID into the limelight. It helped to turn long hauler into a common phrase. And it helped to draw the connection between long COVID and ME/CFS, a connection that I'm proud to say that I made from the very first time I wrote about long COVID. Now, I stress that I would not have covered this topic in the way that I did, had it not been for people like Fiona Lowenstein and Mara Gay and Felicity Callard and the PLRC, patients talking about their experiences and advocating for themselves. And the same especially goes for a woman named Sarah Rainey. So Sarah and I first got to know each other in 2018 when she sent me an email out of the blue. We had communicated exactly once before on Twitter. She liked my book, I loved her music. Her email said, "I have a serious health condition. I'm moving to DC, where I lived at the time. All the people I know recently moved away, and this is absolutely mortifying, but will you go on a friend date with me?" I said yes, and we almost immediately became good friends. I'm recording this having just visited Sarah in Arizona, where she lives. In 2019, Sarah sent me a copy of the book that she had been working on for a decade. It's called The Lady's Handbook for Her Mysterious Illness, which describes her experience with ME/CFS and complex regional pain syndrome, the shocking mistreatment that she experienced as a result, and the similar problems that millions of other people go through. The book is a monumental feat of storytelling. Again, it's The Lady's Handbook for Her Mysterious Illness. If you've not read it, I highly recommend it. And I know that the book has made its way out through this community, but maybe a lot of people haven't heard about it because it had the massive misfortune to come out in the middle of March 2020, which meant that it got zero publicity, which is really the most bitter irony for a book about neglected diseases. But I read it, and it helped me understand my friend better. It opened my eyes to this entire category of medical problems. I read about how crushingly hard it was for Sarah to get medical care. I read about how her symptoms were relentlessly downplayed or ignored by medical professionals and by her loved ones. I read about how the people who she sought for help caused her emotional and physical harm, how impossible it was for her to rely on evidence-based medicine when medicine doesn't bother to create an evidence base for your condition. Her book changed the way I think about the relationship between patients and the healthcare system, and what it means to think about health critically and skeptically. perhaps most importantly, I got to see what it is like for someone to live with this condition, a condition that debilitates Sarah regularly, but that allows her these brief windows of opportunity where she can hang out with her able-bodied friends like myself, and in those windows she seems fine, but I know that she's not fine because I've talked to her and I listened. That book primed me for what was to come. It meant that once I started hearing about similar things in long COVID, I knew what I was looking at and I knew to draw a link with ME/CFS. Covering these conditions has solidified my view that science is not the objective neutral force that it is often caricatured to be. It is instead a human endeavour, relentlessly buffeted by our culture, values and politics. As energy-depleting illnesses that disproportionately affect women, long COVID and ME/CFS are easily belittled by a sexist society that trivialises women's pain, and a capitalist one that values people according to their productivity. Societal dismissal then leads to scientific neglect, and the lack of research then becomes fodder for further scepticism. I only understood this vicious cycle after interviewing social scientists, disability scholars, and patients themselves, whose voices are often absent or minimised in the media in favour of the same academics and clinicians who, when I started reporting on these conditions, knew the least about them. It is important to realise that, like the pandemic as a whole, long COVID and ME/CFS are not just health problems. They are social ones, and they can only be fully understood as social problems. So the dismissal and the gaslighting that patients with these conditions that my friend have experienced, people saying you're just depressed, you're anxious, it is in your head, these are among the worst aspects of long COVID and ME/CFS, and they can be as crushing as the physical suffering. They are really hard to fight because the disease's symptoms can be so beyond the realm of everyday experience as to seem unbelievable, and because those same symptoms sap people's energy and fog their mental abilities. So journalism can be a conduit for empathy, helps to put words to the indescribable and clarify the unfathomable for people too sick to do it themselves. Long haulers have told me that through these pieces they better understood what was happening to them. They found community and medical care, and they felt the relief of recognition at a time when friends, family members and healthcare professionals were brushing off their ordeal as imaginary. As a science writer, I have written about many topics throughout my career, but none have affected me more than long COVID, and none have so profoundly changed my view about what journalism can achieve and how it can do that. Many long haulers, and I use that term expansively to include people with ME/CFS, long COVID, and other sister illnesses like fibromyalgia and Ehlers-Danlos syndrome and many more. These groups of people have told me that they have used my work to finally get through to skeptical loved ones, to employers, to doctors. And I hadn't ever thought that that would be how the pieces would be used. I used to imagine that my writing would go out to a reader who might learn something new, maybe even change what and how they think, and then that's it. But this one-step model is woefully incomplete because we are a social species. Journalism doesn't stop with first-generation readers, it cascades through their networks, and done well, it can make those networks stronger. After my most recent piece, which explained how severe the fatigue of long COVID and ME/CFS really is, one long hauler told me that her sister said, "I did not understand how sick you really felt." Even healthy people started writing in. A reader who spent her 25-year life watching her mother wrestling with ME/CFS said that until reading that piece, quote, "I truly didn't get it, or maybe I just didn't believe her." People who had been sick for years or even decades said it was the first time they had seen their lives accurately, fully, and compassionately reflected in the press. This is a damning indictment of our profession, and I'm including my pre-pandemic self in that. I am far from the only journalist covering this topic, but there are clearly not enough of us. How could so many people feel so thoroughly unrepresented by an industry that is supposed to give voice to the voiceless? In covering diseases like long COVID and ME/CFS, many of our journalistic norms and biases work against us. We love iconoclasts, but that privileges the voices of skeptics who can claim that they are being cancelled by patient groups over the voices of the patients who are actually suffering. We love new, novel things, but that leaves us prone to ignoring chronic conditions that are by definition not new. We work to things like tight deadlines. We prefer phone interviews to print, but these things can be harmful to the people we most need to hear from. We cannot afford these weaknesses. Around the world, tens of millions of people are suffering from long COVID. Some might recover, others will join them, especially since our leaders have rushed us back to an era of unrestrained airborne pathogens and lax public health, an era that had already cost millions of ME/CFS sufferers dearly long before COVID arrived. In this status quo, people are expected to ignore the threat of infection, and then they'll pay through the nose if they get sick, or at least here in the US, and they'll face stigma and ridicule if they become disabled. That is a horrendous bargain. Journalism can and should repudiate it. We are not neutral actors reporting on the world at a distance. We create that world through our choices, and we must learn to choose better with purpose, care, and compassion. So I choose my stories very carefully. I prefer to be proactive over reactive. There are a lot of skeptics of ME/CFS and long COVID, and I think if we spend all our time countering what they are saying without talking about the realities of these conditions for ourselves, we lose something. We lose a lot by letting extremists dictate the terms of condition, terms of engagement. So rather than rebut a dozen rubbish op-eds, I prefer to spend my time actually creating work that will help people, that will illuminate rather than counter-illuminate. I try to pick angles that will be interesting to both people with the conditions and people without them. So the pieces that I've written about the reality of symptoms like fatigue and brain fog were like this. They were like biographies of symptoms. I wanted those pieces to make people who experience these symptoms feel seen, but also to convey to everyone else just how strange and extreme those symptoms can be. After choosing my stories, I then have to interview people. But I recognise that for this topic, interviews have costs. Interviewing long haulers isn't benign. At minimum, I might be asking them to relive the worst experiences of their lives to a stranger. But worse, most long haulers experience post-exertional malaise, PEM, in which minor physical or mental exertion can trigger a loss of energy so profound that I have called it the annihilation of possibility. An hour-long call could wreck someone for days. And knowing this, I've started telling people up front that they could end and reschedule the interview at the slightest inkling that their health might suffer. And some did pull on that ripcord. I set long deadlines, knowing that I was working on what disability scholars have called trip time, a flexible way of scheduling your time that's responsive to the needs of your illness. While I would normally insist that phone interviews get better results, I've also happily sent written questions to long haulers who struggle with real-time spoken conversations. I know that my normal deadlines will go out the window. I make my schedule work around my interviewees' energy levels and not the other way round. Good journalists are meant to maintain a healthy distance from our sources. But this professional standard can easily transform into callousness. Staying independent turns into, I act how I want to act and you deal with it. But with long COVID, I bend to accommodate my source's need and not the other way around. I also bring as much curiosity and empathy as I can to interviews. I am not fishing for quotes or for dramatic details of horrible symptoms. I want to know how long haulers feel. I want to know the nuances and the minutiae of their lives. I want to check my own thoughts on the fly. I run my interpretations past my sources in real time to check if my understanding and assumptions are correct. You told me this, it makes me think blah, blah, blah. Am I correct in that? And I do this iteratively, asking each source about the experiences of the previous ones. The last person I spoke to told me this. Does that match your experience? Do you agree with that? That allows me to identify points of commonality or contention. I know that everyone is wrong about something, and being empathetic doesn't mean abandoning our journalistic rigor. It just means going about establishing that rigor in a different way. I listen. I listen very, very carefully. I am trying to look for places where my own understanding shifts in the middle of a conversation. For example, long haulers often suffer fatigue, but that fatigue is very different from everyday tiredness. It is more severe, it is multifaceted, it is harder to push through, and it is not cured by sleep. Post-exertional malaise, PEM, is different again. Every symptom burns more fiercely. The fatigue is accompanied by a flu-like poisoned feeling. And it's not that your batteries are drained, but they're completely missing. These states are very easy to conflate. It is easy to think that PEM is just extreme fatigue or that a long hauler's fatigue is like my fatigue. They are not. And their differences only became clear to me after many interviews and a lot of careful listening. It is very easy to talk to people and simply think, well, they're all exhausted, that's bad. But there are subtleties and nuances in their metaphors and their language and their descriptions that reveal important truths about the disease to anyone who cares to listen. I have tried to center patients. I don't use them in anecdotal leads, only to quote academics thereafter. They might be suffering, but they are still protagonists of their own story, with power and agency. They are not just passive beneficiaries of medical aid. I want people to empathize with long haulers, not gawk at them. There are good moral reasons to do that, but there are good practical reasons too. Biologists have a saying that nothing about biology makes sense except in the light of evolution. That phrase is about the central position of evolutionary theory in understanding the natural world. Well, by analogy, nothing in chronic illness makes sense except in the light of the patient experience. That experience is the ground truth against which all other data must be understood. If you read a scientific paper that contradicts what the patients are telling you, it's not that the patients are wrong. It's likely that the study has flaws in it. This patient-centric approach is sometimes dismissed as advocacy. And there's a feeling that advocacy is antithetical to journalism, that the two are opposed to each other. But in fact, it's just good journalistic practice to give weight to the most knowledgeable sources. I have treated long haulers as the experts on their own conditions because they are. They saw and predicted the rise of long COVID before credentialed academics did. Many are patient experts who have read the scientific literature on long COVID and ME/CFS more deeply than many doctors because they are highly motivated to do so. Others are meta-experts. They thoroughly understand the community, their desires, their needs, their history and conflicts. They can help you distinguish who are the reliable voices and who are the grifters, who are in it for their own personal gain. All of these people should be front and center of every story. And instead, a lot of journalists just use them as anecdotal fodder. You lead your story with someone who's suffering and then you leave them behind. No, they should be the core of what we write. Now, I didn't come to this easily. Before the pandemic, I mostly interviewed academics who had degrees and institutional affiliations. But long COVID taught me to seek expertise where it actually lies instead of where it seems to lie. And this is now especially easy to do because there are large databases of sources of good long haulers to talk to, which have been compiled by other researchers and journalists. When I write about long COVID, I write in part to make people feel seen, to create this combined mirror that reflects countless individual experiences. These illnesses are usually extremely varied, but if I can do my job right, I can make everyone feel at least partly reflected. But I also write for people who don't have the conditions themselves, in the hope that they will learn something. Writing is a constant battle for attention, one waged through careful consideration of structure, tone, and understanding where readers are at. And so with things like ME/CFS, I always have at the back of my mind the most common misconceptions. When I wrote a piece about fatigue, I started with a description of what someone who has ME/CFS experiences, and then immediately I compare that to her previous life to note that the fatigue she now feels is nothing like what she once felt. That's meant to address the, oh, I'm just tired too, rejoinder, without having to explicitly do that. My point here, you can hear my dog walking along the floor. My point here is that if you want a healthy person to care about or to empathize with people with ME/CFS, it is not enough to simply say that this condition is terrible or debilitating. You have to show, not tell. And particularly, you have to show how it is different to normal experience. You have to understand and acknowledge that it is very hard to appreciate what this condition is like when you are healthy. You have to get through to people who might be skeptically thinking, well, that doesn't sound that doesn't sound real, or that sounds too similar to what I have, and actually nip those thoughts in the bud in the course of a piece in a very seamless way. Similarly, I think it's not enough to say that there are just differences, that these diseases are not common to our normal experience. You have to try to explain at least some of the scientific underpinnings for those differences, and I have tried to do that. It is a very easy frame to say that these are mystery illnesses about which nothing is known. But that frame only serves people who are skeptical about them. It certainly doesn't serve long haulers themselves, and it simply isn't true. There might be not enough research on these conditions, but there is some, and it is valuable. It has given us important insights that readers need to know about. These are the skills that I have worked hard to build over the years in many topics, and I've brought to bear in the reporting for this one. After the pieces are finished, the work still continues. So in several of my recent pieces, I recorded audio versions because people commonly tell me that their brain fog makes it hard to read long pieces. After these pieces are published, I get a lot of emails, several hundred after some of the more popular ones, and I try and read and respond to as many of them as I can, because I know that writing these emails exerts the cost, and I try to honor that by at least reading them. Now, I have not been trained in any of this, right? I don't have a background in trauma-informed reporting. I didn't even know what the term meant until quite recently. I still make mistakes, and I'm still learning how to do this. But for those of you who are in the room and who want to write more about these conditions, and I really hope that you do, I want to emphasize that the tent poles are curiosity, kindness, and empathy, and everything else unfolds from that. Writing about the pandemic has been very difficult. Many of the grim outcomes I warned about came to pass. Most of the changes that I hoped for did not. I watched 2 administrations in the US make avoidable mistakes and then make them again and again with every new surge and variant. I watched almost every publication that I once cared about become complicit in normalizing a level of death and disability that was once described as incalculable. That work was really crushing. It wrecked my faith in journalism and its institutions. But a lot of my work on long COVID restored that faith a bit. The solace that many long haulers drew from my pieces gave me solace in return. It convinced me that there is still a point to this horrible work and a purpose to bearing witness to suffering and a reason to continue shouting into the abyss. Sometimes, even if just a little, the abyss does actually brighten. I don't want to sound self-congratulatory. The long COVID crisis is far from resolved. Millions of people are still suffering with ME/CFS. Long haulers need more than just confirmation of their pain. They need well-funded and well-conducted research, social support, workplace accommodations, and cures. But there's a lot that we can do in journalism while we wait on and push towards those outcomes. There's a poet named Sean Thomas Doherty who wrote a poem called Why Bother? It goes like this. Because right now there is someone out there with a wound in the exact shape of your words. Those words are those words are ours to provide. Those wounds ours to plaster. Contrary to the widespread notion that speaking truth to power means being antagonistic and cold, journalists can instead act as a caretaking profession, one that soothes and nurtures. And we are among the only professions who can do that at a scale commensurate with the scope of the crises before us. We can make people who feel invisible feel seen, and we can make everyone else look. The last thing I'll say is that for me, all of this started because I said yes to a random friend date and then listened. Do not underestimate the power of small acts of kindness or little moments of connection and of stories. None of my pieces would have been possible had the long haul community not spoken up for itself. I don't think I would have understood what was happening or drawn connections to Emmy if I hadn't read Sarah's book, or hadn't seen conversations between her and other people in the ME/CFS community, or hadn't followed a lot of disability scholars on Twitter. Their work allowed me to do my work in many, many ways. You know, when I first started covering long COVID, Eliza Perego had already coined the term. Amy Watson had coined long haulers. I can't tell you how useful this was to a journalist. There were names for the thing that I was writing about and the people who have it, and they were simple, evocative names. The Patient-Led Research Collaborative had already done research that asked a ton of interesting questions while they were all sick. People from the ME community were explicitly drawing connections between long COVID and ME. ME advocates have been loud enough for long enough that even though I didn't know much about the condition, I did know about the work of people like Julie Romeyer and David Tuller. When I started diving into the topic, I found it incredible that MEpedia existed, a font of useful information in a space that can be utterly bewildering to newcomers. I found so many knowledgeable people who patiently explained the ins and outs of ME/CFS to me, people like Jen Breyer and Jamie Seltzer and Alison Sobrano. They told me about the controversies, the history, the sticking points. This was all invaluable. I also wrote this piece about people who were grieving loved ones lost to COVID, and for that piece I spoke to an anthropologist named Sarah Wagner, who told me that after atrocities, wars and conflicts, it is often bereaved family members who have to fight for recognition and reconciliation despite the heavy burden that they already bear. When it isn't politically expedient for those in positions of power to commemorate the deaths and extend forms of reparation, Wagner told me, it falls on the families. And that's what I see here. All of my work draws from the efforts of people who had no energy to spare and were heroically using that little energy to advocate for themselves, to tell their own stories. I hope that you continue to do so. I hope the journalists in the room continue to believe you. Thank you very much. Take good care.
Microphone.
Okay, now, as you already know, Joan is not feeling well, and I'm going to try to substitute her now as moderator of the next session. And to do so, I ask Sian Leary to come here and sit, please. She is head of Advocacy and Communications to World ME Alliance. Thank you. There. Muna Sidarius. Okay. She is a medical student at the University of Algarve and MIO's managing board member. And Monica Anderson Moraes. She's a BA, volunteer organizer. Okay, can see one. Down there. Volunteer organizer, Millions Missing Alliance. And online, we have Sonia Chanduri, Chief Executive Officer of Action for ME, Non-Executive Director of Kuro, Share World ME Alliance, Decoded Me Study. She doesn't see us, I think, isn't it? We see her, and she listens from us, and we listen her also. Okay. Now, thank you for coming. Thank you for being with us and to accept to be in this panel. This is a panel, well, in continuation of the last one about patient advocacy. And for all of you, well, I ask what personal experience and motivations led each panelist to advocate for this disease. And this is a very tough roundtable with only 30 minutes. So I ask you to be precise, and I give you for each question 2 minutes, okay? And maybe Monica.
Goodness me, thank you for having me. 32 years of experience in 2 minutes. Okay, let's go. Pardon my notes, I blame my brain fog. What is my motivation? I was diagnosed 32 years ago. I was very lucky. I was halfway through a master's degree, and the university I was at had an excellent medical school, so I was immediately diagnosed. Unfortunately, I wasn't well advised, not through gaslighting, but because 32 years ago, we didn't know. I had access straight away to the database of the medical school. I'm not a medical student. And so for 32 years, I've been studying this disease and living it in person. And I'm very passionate about this. We are 55 million plus patients worldwide. 85% are still not diagnosed. And basically, if you imagine one day someone comes up to you and says, your life as you know it is over. Your job, your mortgage, your savings, your marriage maybe, who knows. And prize, bonus, everybody's going to treat you like you're a nutcase. And I went from calling this chronic fatigue syndrome to calling it be positive and have you tried syndrome, because everybody had a suggestion. And on top of it, you will not get very much medical support, and the state will most certainly not help you. It doesn't have to be like this. My lessons over 32 years, I would like to share them. It really doesn't have to be like this. Had I been advised differently, my life could be different today. I have a very good friend who was diagnosed exactly the same year as me. Today, she is the director of an international school in Bogota. Why? She was well advised. She had an excellent doctor, a pediatrician, she was very young at the time, who said, stop, pacing. You have got to stop. There is a theory that there is a metabolic issue The mitochondria does not metabolize oxygen properly. I'm not a doctor, forgive me, this is my interpretation, but if you stop straight away, you have a much greater chance of recovering. I was halfway through a very expensive master's degree. I had a thesis to hand in. I couldn't stop. But I was told, don't stop, keep going. We're not sure it's not psychological. So I went. And it doesn't have to be like this. You know, there are ways of dealing with this illness, in dealing with doctors. I have, today, 32 years later, fantastic doctors. Dealing with your family, dealing with your friends. A typical phrase that I've had is, you know, people say, oh, you're sick, okay, well, are you gonna get better? Well, I'm not sure. And people say, well, you either get better or you die, but you're kind of in between, you know? We're not quite sure what to do with you because, and it doesn't have to be like this. And I'm very passionate about sharing my positive experiences. And I would really like to use this experience to help other people in whichever way I can. So forgive me if I've gone over 2 minutes probably.
Okay, a little bit more, but okay. Sonia, what are your personal experience and motivations?
Thank you very much, and sorry I can't be there with you in person. So all my career I've worked with people who have faced inequity and disadvantage, working with children and families, and I took this job because I wanted to be a chief exec. But then I found I had friends who had ME and I just didn't know. I went to my first interview and I met the team and I heard the stories of the people that they're working with, and I went away thinking, I really want this job. How could I have not known about this whole community of people as a social worker, a third sector leader, where people have been left invisible without support? And so I was delighted when I had my second interview, and then I got offered the job. And my first year, I worked very passionately, incredible hours to try and affect change for a community that had just been ignored. And then I'm quite ashamed to say, it never occurred to me that any could happen to me or one of my family members. My son had just had his 11th birthday. He got a chest infection. He had 3 lots of antibiotics. He didn't get better and was subsequently diagnosed with ME. And 10 years later, he's still suffering with it. So my motivation is because people deserve services, they deserve treatments, deserve the research. I deserve that for my son. My son deserves it. And I'm still here because I believe that we can be stronger together, and there's still much more for us to do.
Thank you. And Sian, what is your
Okay. So my motivation, I think, is twofold. I have ME myself. I was diagnosed about 11 years ago. Spent about 5 of those years severely ill. You know, I lived through the kind of years of being housebound, at times bedbound, through the extreme isolation that comes with that, and through the loss of many kind of friends, of parts of my family, of others, through the lack of understanding and awareness. But for me, I think a lot of my drive comes from the themes that Monica and Sonia have already mentioned, from the injustice that is part and parcel of what people with ME experience and what people with long COVID are now experiencing too. And the fact that this isn't a medical mystery alone. It is a disease that has been stigmatized and that continues to be mistreated across the world. And so for me, the drive there is about creating change for a group of people that have for too long been badly treated. And I think I really agree with Monica that there are better ways to do this. We have those ways now to some extent. Yeah, we don't have as much as we need, but we do have better ways to do this. We can affect change now. And so for me, that's why it's really important to work in this kind of policy advocacy space, as well as the incredible research that we've heard today, that those two things need to be woven together to create change as fast as we can for you know, what is ultimately also a very warm and loving community that I have had a huge deal of support from.
Thank you. And for you, Mona?
Yeah, for me, it has been a path that hasn't been so clear, maybe as some of you, because it has started with chronic fatigue that kind of developed into more chronic tiredness or fatigue, chronic pain into chronic fatigue. And but that also then with my sister having similar symptoms and my own experience with disability as our family have allowed me to develop a more accepting perspective with the time, but also kind of not giving up totally on wanting to understand this better and find better ways to handle it personally. But then also, I think together with having a mom that has always been very active socially as a social worker, but as well in her life, always fighting for other people individually, has brought me some ideas of fairness and justice, and also awareness of the difficulties that society imposes to those who feel some limitations. So my own engagement, I think, has come quite recently, more in this pandemic situation where maybe some of us have had time to slow down a little bit and rethink our lives. And I have decided to go into the healthcare, a healthcare profession. So that's why I'm studying now medicine. And Emmy has been with me for a while, but I've only had a diagnosis more recently. And now I've decided also to get my hands on this.
Thank you. The second question is also for four of you. I don't know what is this. What form has your ME advocacy taken? And I initiate for Cian, okay?
Okay. So for me, at the moment, I'm working with the World ME Alliance as their head of advocacy and communications. And we're an organization that now has 27 national member charities or organizations across the world in in 20 countries. And we are working together to try and affect policy change through supporting each other as kind of grassroots organizations. All of our member organizations have people with ME or lived experience somewhere at the heart of what they do. And we've got this kind of two-pronged approach, which is, building up the grassroots, sharing the knowledge that we can, sharing the resources that we can, so that we're not reinventing the wheel in different countries across the world. And I think it's really important to say that the stories that we are hearing here today, they are true in every country in this world. This is not a disease that only affects Western countries or white people, as it's sometimes seen in kind of media representations. It affects absolutely everyone. So we've got this, first approach of really trying to build up the grassroots and charitable work that we can across the world. And then we're also trying to focus our work on the World Health Organization to try and create top-down change too. That is going to be a long game. It's going to take us a hell of a long time to get somewhere there. But I think what we're seeing is that the long COVID has really changed some of the attitudes and approaches for executives at the World Health Organization. And we're hopeful that we can work with the World Health Organization directly, but also member states of the World Health Organization, which is all the countries that we are living in, to try and show that we can provide resources from the top down as well that will meet in the middle to create that accelerated change that is really necessary for this population.
Thank you. And for you, Sonia, what is the shape of your form of advocacy?
So I helped co-found and set up the World ME Alliance, and I co-chair that still today. So I work very closely with Sian and our members in the way that Sian has described. At a national level, Action for ME engages in lots of different ways. We have a programme of work with MPs, parliamentarians, to engage them, help them understand the illness better, to ask questions in Parliament. We have signed up some parliamentarians to be champions for us, and a good example was last week before, one of them identified himself as a parliamentary champion for Action for ME, and then talked about the impact of ME and the needs of people with ME when talking about welfare benefits. We've worked heavily with the government on the National Delivery Plan. A draft came out a while ago. We're waiting for the plan itself to be launched. And a lot of this work is being done in the background. And as one of your guests said earlier on, it's very important we do that in a very collaborative way. In terms of research, we helped set up the Research Collaborative in the UK. And through that work, we've engaged with funders and with others. We've secured funding for Decode ME, the world's largest ME study, and we're looking at genetics, and we co-lead that. And we're also involved in another study, genetic study, looking at ME and long COVID with some other partners. And then lastly, we fund research as well and have also set up a genetic centre of excellence working with the University of Edinburgh.
Thank you, Sonia. And for you, Mona?
So I've joined MIOSH recently, and I am hoping that together we can leverage some of the group's knowledge that has been for 20 years working mainly on fibromyalgia, although ME CFS has been also a strong point from the beginning. But now using this traction from long COVID and the opportunity to have been involved with organizing this conference, I'm really hoping that we can also balance a little bit our representation of both diseases, our way of helping to educate the public in general, but also the medical community or healthcare providers, as well as the patients themselves.
Thank you. And at last, Monica.
My involvement as a patient advocate has been more, it hasn't taken on an official form like Sean and Muna and Sonia. Unfortunately, it was not possible for several reasons. I'm now affiliated with Aliança Millions Missing, but I guess my advocacy has been on an ad hoc basis, talking to doctors, talking to nurses, even pharmacists. One pharmacist I talk to on a regular basis to get medication. She wants to learn more about it. Social workers, crisis support lines. There are people calling them every day, not knowing what's wrong with them. I interviewed someone recently at a crisis support line, and she said a lot of people are showing similar symptoms. They need training. And so I hope in about a year's time to dedicate my time to this patient advocacy, which so far I haven't been able to do full-time, but I very much hope to do.
Thank you. And now I have individual questions for each of you. For Sonia, how do you best support people with ME now and build real change simultaneously?
So I think there are a range of things. I think it's really important as far as we can to ensure services are available for people with ME, that they're inclusive, they meet the needs. And as a charity, we try and plug some of those gaps by providing information support and healthcare. And it's important that where there are services, and I know not all countries do have services, but it's important that we expand them as much as possible. But there are simple things that doctors and others can do to help reduce stigma. It's important to raise awareness to ensure increased public understanding of ME through our press and our media, and as a charity we do a lot of work in that area. Professional education is important. It's just mentioned about social workers and doctors, but also those in education and other industries. It's important that we have research funding. Research funding will be transformational for people with ME. We need to accelerate research. It's very disproportionate, the amount of money that goes into ME compared with other illnesses, let alone the quality of life or poor quality of life that people with ME have to live with. I've mentioned the policy and advocacy work with decision makers, and also support with people to help self-advocacy, although we've got to recognise that there are still severe limitations for some individuals who don't have the energy to be able to follow that through. I think the other thing is working collaboratively, and that's the whole ethos of the work we do at Action for ME and also the World ME Alliance. That maximises the effort, it creates a more powerful, consistent voice, and we can, together, we're a harder voice to ignore. So I think by combining those approaches, we provide immediate support to people with ME to meet needs now, while also working to secure change for the future.
Thank you. Mona, tell us about the stigma you see from your dual perspectives as a future healthcare professional and person with lived experience of the disease. In 2 minutes.
Yeah, I've had some bad experience personally with doctors also gaslighting or doing things that shouldn't. It doesn't need to be like that. Even people who were supposed to be specialists in diseases like this, for example, fibromyalgia, and should be a little bit aware of allowing some time to explain symptoms and to express my worries. But I've also had, strangely, a situation where I had recently joined MIOJ as a member, and I had been a few months in my new degree when they had a new campaign with a poster that said fibromyalgia is invisible, but the pain is real. And I thought this was an amazing opportunity to be able to expand this to the whole of the Algarve, where I am studying, because we were all doing internships at the primary healthcare centers there. So the faculty was very welcoming. My colleagues also agreed to take the posters, but some of them told me that the doctors didn't want to put up the posters. And even one of the doctors said, if I put up that poster, all the women will say they have this disease. And I was like, how is this possible nowadays? And actually, from my experience during my internships, fibromyalgia is a lot more recognized than MEFS. So I have never seen anyone during my internships with a diagnosis. I don't really know anyone other than the people that I've met through MIOJ. But I do know of some people with fibromyalgia diagnosis. So we are here still. Things aren't clear, and there's probably a skew in the diagnosis. Also, doctors who are actually caring people, and those specific examples, have told me, oh, now we are going to have a patient, they're a little bit difficult, they have fibromyalgia. But then they're actually nice to the person. They allow them to talk, they are caring, but they still have this reaction. So we do still need to do a lot of work here in Portugal. And if this is the case for fibromyalgia, it's much worse for ME, CFS. Also, a teacher recently from neurology, which is supposed to be the area of expertise, has told me, oh, but those are diseases that are not very well known when I spoke about this conference. And I told him, well, ME/CFS has been long recognized by the World Health Organization, and then he completely changed his attitude. So.
Okay, thank you. Monica, what communication strategies have been most effective in changing public perceptions and dispelling myths about the disease?
Short.
Short. Like I said earlier, my work has been done very much in an unofficial basis. It's basically been done organically and using common sense, really, and emotional intelligence. Sometimes you get gaslighted. I was once seen by a doctor, and after I listed my symptoms, he said, "Wow, are you married?" And I looked at him, "None of your business," because he said, "You must be a real pain in the neck." And I just thought, you know what? This is not right. You know, this cannot happen. And basically, on the other hand, I have the most incredible GP who said, "Monica, I don't know what your illness is, but you know what we'll do? We're going to treat you." At first she said palliatively, and I thought, God, well, I'm not quite there yet. But, and then she said symptomatically. I thought, okay, that's better. So she's wonderful. She's open. She knows that I take my research very seriously. She's open to my suggestions. So my suggestion is when you go and see a doctor, gauge their receptivity, or a nurse, for instance. Gauge how receptive they are. Don't waste energy on people who are not prepared to listen to you. I had a nurse once at one of the worst relapses that I had say, "Oh, you know, you should really take a stroll down to the garden down the road." And "Have you done that?" I said, "No, I am actually in the middle of a relapse, 15 months. She said, "Oh, you know what? With that attitude, it's going to be really difficult." And I thought, you know what? I'm not going to let you get away with it. So I said, "What do you know about my illness? Do you even know the name?" And she was accompanied by a doctor on a home visit. And she stopped. And she changed, her demeanor changed completely. So, you know, don't let people get away with gaslighting, with mistreating you. We deserve respect. Doctors deserve respect. Doctors, you know, this is not a well-known disease. And some of them I've been extremely lucky. It's very kind, very open. Take articles, take statistics, come armed with concise facts that can help them understand. And don't give up.
Okay, thank you. Cian, what advice would you have for someone wanting to start advocating in this area?
Wanting to start advocating in this area, I would say that there are many organizations across the world now who are predominantly run by people living with lived experience of this disease, either with the disease themselves or as carers, but also by, you know, willing allies and friends who see the injustice here and want to make a difference. So I'd say get in touch with your national organization and see what's possible there. But we've also heard that there are very varied ways of getting involved in this advocacy space. And, you know, what Monica has done through that kind of individual outreach to doctors has been really powerful here in Portugal. And I see the same in other places, in Czech Republic, in South Africa, in Mexico, and, you know, there's some brilliant advocates here from Brazil who are making real change there through kind of direct work with government policy advisors and more. So there is real opportunity here, and beyond that, you know, get in touch with us at the World ME Alliance. But I think it's all about taking that first step, posting something on social media, creating connections, working together, collaborating, knowing that you are not alone in this story and that together we can and will make a difference.
Okay, thank you. And last question for all of you. Can you give one word that describes a value you want to see in advocacy going forward, in the advocacy of this illness? And, well, not one word, but 1 minute, okay? Muna.
Maybe I need this. I think we mainly need to bring awareness, especially here in our country, as we have, I think, all said, to the generic public, to patients, also that we can gather as patients, that we start shifting a bit also was one thing that I wanted to say earlier and maybe make sense now. towards a more social model understanding of this also as a disability and not just in the medical perspective. And so I think that's my word, awareness.
Okay, thank you. Monica?
So I've gone over my 2 minutes, and now I'll go over my 1 word, 3 words: targets, strategy, and communication. I think we need to define targets for guidelines, for diagnostic guidelines, for treatment, have a strategy in place, and communicate. There is so much information out there, and 32 years is just so much information that I would like to share with people, and there are so many things that people are not aware of. Forgive me to bring my own example back onto the table, but 15 months ago, I was bedridden. I could just about get up and cook. I had spasms. I thought I was coming down with some kind of neurodegenerative disease other than what I already had. And I was lucky enough to be part of an incredible support group, and I asked the question, does anyone have these symptoms? And the answer I got was, are you taking this medication? Which supposedly was harmless, but guess what? Not for me. I stopped, the spasms stopped, the fatigue stopped. Of course, I didn't go back to being Superwoman, but I went back to my normal baseline. Communication, and I cannot stress that enough.
Well, like Ed Young said about a friend of him, you can write a book. It's a service.
Would you do the preface?
Okay, I will do it. Yeah? I will do it. Okay. Sian.
I've been thinking about this question, and I'm not sure this is the right choice, but the word that comes to mind for me is acceleration. That I want us to see change faster, and I think that comes through collaboration. And maybe that's difficult when we work in a world full of people with ME who have an energy-limiting disease, but acceleration is what we need to see. So that's my hope for the future.
Thank you very much. And Sonia, please.
So Sean got there before me, so my word was accelerate, and I think it's really important that we accelerate research, we accelerate understanding, we accelerate just in all areas and service provision so that we can achieve equity. As I said right at the beginning, too many people are invisible, too many people are suffering, too many people are struggling in so many different ways, and I just think it's tragic and it's unacceptable. And certainly in countries like the UK, where we're not dealing with some of the issues, say, in parts of Africa, that we should see improved services. And I think that can only happen by us all working together to work systemically, collaboratively, and I think that's when we'll eventually achieve equity.
Thank you. Well, I thank very much the 4 of you. Namely, to accomplish so short time we had for this roundtable. And now we have another pause for coffee, and we return at 4:30. Thank you.
Well done. Well done.
supposed to wear a tie tomorrow.
Right, I know, I brought it.
Did you bring a tie?
Yeah, I brought a tie.
I mean, you can look.
We're going to send it to Jean.
Oh,
and
no,
her
wait, it's
team?
backwards.
Oh, I got it.
Yep. Mm-hmm.
She's lovely.
Yeah.
You have a lovely team.
Okay.
Do you love the house? The space? And now, Dr. Unger, you know that this foundation is established to help connections between the U.S. and Portugal.
Oh.
So for us, it's very important because now we can come back. Oh, it came out beautiful.
Yeah.
That's great.
Yeah.
We can come back to them and ask them to fund exchanges.
Oh, that would
like
be excellent.
having, I don't know, people from the CDC if they want to come or have an internship in Portugal. So that for us, this was a very strategic foundation. Did you get an answer to your poster session?
For
posters.
Yeah, they put them up. Yeah.
Sorry, I had a bit of a POTS episode. So, ladies, the truth. What do you think? Oh, I know what's going on. There's 3 medical congresses. One is the general family practitioners. So that's like a primary audience for us. And there's 2 other events that have to be I don't know why we scheduled the conference to coincide. Online's good. And we're getting comments from folks watching from the US, from France. They're not understanding that it doesn't matter. This Portuguese friend of mine, she goes, I couldn't even understand the Portuguese. She's hard of hearing. She's a patient. But she said, now that but with English, my phone recognizes the caption, so I'm reading it while listening to it in English. But the repercussions of that.
Já. Well.
Now what we need is a dozen people that
tudo a correr bem.
Well, we're going to begin in the 10th session of this program, and I'm going to present you the moderator of this roundtable, João Carlos Vinck. João Carlos Vinck is a medical doctor and professor of respiratory medicine at the School of Medicine of the Universidade do Porto. He's also coordinator of the respiratory medicine unit in the Institute CUF of Porto. João Carlos.
Can you hear me now? Yeah, I think so. Thank you so much, Professor Jaime Branco, for the kind invitation, kind introduction, and also my compliments to Professor Vaz Carneiro. I don't know if he's in the room, for this great achievement. But I have to say that I'm really delighted to be here. Joan, I mean, you're an example. Your activism is really fantastic. So I'm really, really honored to be here and share, I mean, with all these keynote speakers, to learn from you, from the doctors, and from you, especially from the patients, that I think we need very much to be, all together to accelerate, like the previous panel was saying, to accelerate the knowledge and do this cooperation with all the centers. So it's for me a great honor. Thank you so much for the invitation. And of course that this panel will be an exciting panel. You can see all these rising stars that are joining me. So this is called the Young Investigator Panel. So these three fantastic researchers will share with us some of their, experiences and prospects and, concerns about studying this very, very challenging disease. And so we are really looking forward to know from their side and maybe inspire you all from the audience and from people that are also listening from the streaming. So first of all, I ask you just to do a brief introduction and timeline for your educational career, and I start from Joanna Squires, that is sitting next to me. Could you just tell a little bit about your educational career?
Yeah, so my name is Johanna Squires. I originally am from Michigan, but I currently work in Boston at Brigham and Women's Hospital with Dr. David Systrom and Sarah. My background is I got my bachelor's in biomedical science, and then I actually got my master's in exercise physiology from a school in England called Loughborough. And Loughborough was a sports school, so all the Olympians go there. So I read a paper by Dr. Systrom in that experience, and I reached out, got connected, and then that's how I ended up now being his senior research coordinator at Brigham and Women's.
Okay, thank you. Thank you so much. So what about you, Sarah? Can you tell us a little bit about your background?
Yeah, I'm Sarah Zaira. I grew up in Saudi Arabia, and I attended Cornell University in Ithaca, New York for my undergrad. I graduated about 2 years ago with a bachelor's degree in biology and society, and since I've joined Dr. Systrom's lab at the Brigham and Women's Hospital. So my journey to finding Dr. Systrom was a little bit different. I knew very little about ME/CFS 2 years ago, and I was kind of just wanting to get involved in research in general. And I started looking at different labs that had openings and different opportunities, and I came across Dr. Systrom's lab, and I was reading his papers and the recent papers he published. I was super interested in not only the work he did, but when I started watching videos and reading blogs about ME/CFS, I was shocked that when I asked a lot of my family members, a lot of whom are physicians practicing in the Middle East, they didn't know anything about ME/CFS. And so that sort of motivated me to learn more about it and help others understand about it too.
Okay, thank you. What about you, João Malato?
Hi. Well, I actually have a mixed background. So I did my bachelor's in Porto in marine ecology and animal behavior. So I studied the interactions between predators and prey and hormonal changes between how they adapt. And then because I collected a lot of data and I had really not a lot of statistical knowledge, I decided to go into biostatistics. So I did a master in Lisbon in biostatistics, and I got in touch with the clinical data, and I really fell in love with medical science and how biostatistics can help or collaborate with them. And through an Erasmus, I was able to do my thesis at the London School of Hygiene and Tropical Medicine under the supervision of Nuno Sepúlveda, over there with the camera. And it was in malaria, and after the Erasmus fellowship was over, I still wanted to stay there and work a little bit. So Nuno put me in contact with Luis, Eliana, and Kate, and Jack at the QME research group. And I spent 1 month with them, and I really fell in love with the research that they do and how empathic and human they are with how they describe and work with patients. And then I decided to continue and do a PhD focused on ME/CFS research, which I submitted less than a month ago. So yeah.
Okay. And you are based here in Lisbon, right?
Yes, I have a mixed grant, so I've been just jumping around in between here, initially London, but then Nuno moved to Warsaw, so in between here, London, Warsaw. But yeah, I'm based here at the Institute of Molecular Medicine at the Faculty of Medicine.
Okay, so very interesting, very heterogeneous background of our researchers. And the next question, and I will start with Joanna again. So what motivated you to pursue a career in ME/CFS research?
So honestly, before I started working with Dr. Systrom, I wasn't all too aware of ME/CFS. It wasn't something that really got brought up in our exercise physiology courses. Instead, it was that CPET, so that invasive CPET that Dr. Systrom mentioned earlier, that sparked my interest. But I think the biggest motivator is, as when I first started my first day at Brigham, there was a multi-million-dollar clinical trial that Astellas was funding with ME/CFS patients. And that my first day hit the ground running. We had muscle biopsies, we had invasive CPETs that week, but we got to run all of the visits, so myself and my coworker, Mary Catherine, at the time. And when you're working with these patients that you see for weeks and weeks at a time, almost 10 weeks, you start listening to their stories and hearing just everything that they've been through. And so it was something far more tangible and honest than working with athletes, which I thought I originally wanted to do. So going through that, and then of course also, Dr. Systrom is a part of Open Medicine Foundation, and also my very first week was attending an Open Medicine Foundation call, so with the late Dr. Ron Tompkins, and then the entire row of my mentors back there. Just hearing everyone's stories and what they're working on was just far more interesting for me, and it's kept me here, and I've told Dr. Systrom I will stay with him until he retires, so it's up to you. Okay.
Okay, what about you, Sarah?
Yeah, I've touched on this earlier, but my initial spark was when I realized that a lot of the physicians in my family had no idea what it was, and that's a career I want to go into, is become a doctor, hopefully soon. So that was the initial seed, I guess, that was planted in me. And then, as Johanna mentioned, I was involved in similar studies. We worked together. And just speaking to the patients, seeing how much our work is truly helping gave me even more motivation and more excitement that the work I'm doing is meaningful. And of course, working with a mentor who's very passionate about the work they do excites me a lot as well. So that's helped a lot. And so, yeah, that's my motivation.
Okay, good. And what about you, João? What motivated you to?
Well, I think I already referred that I spent 1 month with Eliana and Luis, and I think that because I was just getting into the real life work and data and complications that come with real life, the real life experience, I was lucky enough that I found and was able to identify a cluster of more severe patients and separate them from mild to moderate cases, and then clearly visualize the differences between the symptoms of healthy individuals, multiple sclerosis patients that they also include in their UK ME/CFS Biobank. And I was really, really excited. And I think that by sheer luck, I got really hyped that I could continue this rhythm of findings all the way through the years that followed throughout the PhD. It was not the case, but nevertheless, it was the initial findings and the overall environment that sparked my interest in the research.
Okay, good. So next question. What type of research are you conducting right now, Joanna?
So right now, we just started our post-exertional malaise muscle biopsy study. So it is over a course of 8 days. There's 3 visits. Patients come in at visit 1 for a baseline muscle biopsy. It's not the scary open one if you look on the internet. It's single needle, you go home with a Band-Aid. Then a week later, you come back for a non-invasive maximal CPET, so a level 1. Which is supposed to precipitate the PEM, and then 24 hours later come in, muscle biopsy, same as the exact same, and then we just follow up. So with this study, I've had the privilege of, I was able to work with Dr. Systrom and Open Medicine Foundation to draft the protocol. I wrote the consent form, I got the IRB approval for it, I communicate with the patients, Sarah and I do all the enrollment, we run the visits, we sign the consent form, so we have our hands very deep into that one. And then we had the privilege last summer in Cambridge with Open Medicine Foundation and Dr. Systrom to discuss the LIFT trial. So it was over a dinner that we had at a pub, and it all came together. It's going to be a huge clinical trial that I've had the privilege of working my way through, understanding the different hurdles of doing a double-blinded, placebo-controlled drug trial. I can gladly say that we've gotten everything approved up until clinicaltrials.gov just wants one more thing from us, and then it's all approved. So that'll be the next big one for me, because that'll have 160 people in it, and we will be the single location. So that'll be my big one. And then on the side, it's writing papers with Wenzong and Dr. Systrom, and we're actually going to be going to American Thoracic Society's International Conference next month to present, and other little conferences. So very busy.
Okay, good, very busy. What about you, Sarah? Can you tell us a little bit more about your
Everything
research?
that Johanna said,
Yeah.
basically. I assist with all of the tasks she's mentioned. We do retrospective studies too, so just database work and keeping everything organized in the background for our database of patients that come in and see Dr. Systrom with. We have IRB approval to look at some of the test results and follow them retrospectively and how well they're doing on some of the medications that they take.
And you, João?
Well, I just submitted the thesis, so I'm a little bit not taking a rest, but the workload has decreased a little bit. But my recent work has been mostly, initially we tried, or our objective was to try and further stratify individuals based on their immune profiles. And due to complications, due to Brexit and data transfer agreements, and then COVID, the data was a little bit, the data access was a little bit delayed. So we ended up going a little bit, well, Nuno allowed me to go a little bit more into exploring, and we ended up asking more hypothetical questions on how the misdiagnosis of patients might be affecting the replicability and reproducibility of results and research itself. And so we did some work on that. That's all three of us have posters, and one of my poster is referring to that. Then as the data transfer agreements were good, and we finally had access to work with them, we worked with the patient symptoms and tried to further categorize them based on different domains, and see if there's any combination between having a more exacerbation on the immune symptoms versus, and if there's any discernible patterns between, sort of like a combinatorial analysis of sorts. That's still ongoing, and it's the work that I'm going to do in the future. In the meantime, we also had access to immune data and data relation to infection triggers and patients reporting prior infection or infection prior to the development of the disease. And we did studies on the exacerbation or the increase in IgG antibodies to herpes virus and or against herpes virus, and symptomatology, or specific symptomatology, and then related them between ME/CFS stratified by infection trigger and multiple sclerosis patients.
Okay, good. So, next question. Why is it important to you, according to you, to encourage young investigators to research ME/CFS?
So I think we had a really good discussion about it when we were planning this session, is as we kind of learned even from Dr. Levine's opening of just the history of the different epidemics that we've seen, even just what we've seen in LA and Iceland and Lake Tahoe, is that the work is being done. If unfortunately people aren't acknowledging it, but the work has been being done for decades. And these investigators that are the giants in the field, and I say this with so much love and respect, are getting older. And so there needs to be their mentees that need to be ready to take up what their mentors paved the way for. So if there's no one there to carry the torch, then all those decades of work is going to fall short. So we were saying with this is that getting the passion that we have with it, we want to carry on what our mentors do, and it's up to us, the youths, to continue on with the same passion and integrity and forward thinking.
Okay, and you, Tara?
I agree with Johanna. I think there's a lot of opportunities and a lot of things to get involved with in terms of research with ME/CFS. We know a lot now, but there's still a lot more that we need to learn and research. A lot of treatment trials that need to be done. So still a long way to go. So I think it'd be good to encourage younger and early career researchers to get involved in all these opportunities.
And usual?
Well, as a biostatistician, I don't directly work with, or I don't work directly with patients and participants. But from my point of view, there's so many questions and hypotheses that we can still try and test. And as we explore the data sets, we more and more keep arising. So we just need to keep on contributing or try to expand into and collaborate further to get more consistent and reproducible results in us for us to be able to consistently reach reach our questions or provide answers to our questions.
Okay. So, what are some of the challenges you're facing, or you think you'll face as an early career investigator researching ME/CFS, Joanna?
One of the ones, so the way that this panel's kind of gone is masters, bachelors, about to go to medical school, about to be PhD. So in the master's stage, funding-wise, I don't have the ability to apply independently for, say, any of the NIH funding. So that's kind of interesting because they're trying to put more money out there, especially for long COVID and whatnot. So aligning yourself with a mentor and a program that is willing to listen to your ideas so that they can be represented is very helpful in this, in that someone that's willing to listen to your voice and willing to work with you, not just to get the money, but in order to prosper your own ideas and career moving forward. I think it's a challenge that it can be worked with if you seek the right help.
Yeah. And you, Sarah?
One thing that struck me in the previous panel discussion that Muna mentioned was when she was putting up flyers, some of the doctors were saying, oh, why would you put these up? We don't believe it, or now everyone's going to think they have ME/CFS. A sentiment that I've heard from some friends and other early career researchers is, do you not worry that the work you do would be perceived by some biases in admissions committees when I was applying to medical school or when I was interviewing for medical school? I never thought about that previously. All of the feedback I've had, luckily, as I'm applying to schools in the United States, have been very positive. Everyone has been very interested in the work I do and the research I do. But I know that that sentiment exists. I don't know how to respond to that or what the solution is. I think if you're passionate about something, you should do it, regardless of what your worry is about biases from elsewhere, and hopefully eventually that'll change. But I'm sure the PIs and the more experienced PIs have a better answer that can help with some of these concerns. But I know that's a sentiment that exists amongst colleagues.
And you as well?
Well, I would say that it can get frustrating at times to be able to, I mean, with ME/CFS being such a convoluted condition, it really, I did really struggle with the amount of coming to no ends or no results repeatedly and trying every single thing and not being able to find or anything. And Nuno usually says that if it was easy, someone would have found it by now, so we just keep on going. And the other thing is that until recently, and aside from Mios here in Portugal, when I was working here at IMM, most of the time I worked isolated and alone because I'm the only one doing research in this topic at this lab. And when I was away abroad with Nuno or at the London School, I was with people that had the same objectives. But here in Portugal, I felt very isolated. But I mean, it's good to be here today because it really opened my eyes to people that have been for the past year working in Vila Nova de Gaia and creating their own cohort and are starting or preparing results or have, I mean, people are so you're sampling? Oh, gathering patients. Okay, nice. But yeah, so it's really good to see that there's the word is spreading around. People are getting interest, and there's more and more, at least here in Portugal, interest in this field.
Okay, so a burning question: what are the qualities you look for in a mentor?
I'll be kind. So definitely just talking to other young investigators and just other people even from my master's program is you want a mentor that will allow you to make the mistakes, will not judge you for making the mistakes, and will explain them and give you the opportunities. So one thing I always tell people that hire for the position is Dr. Systrom will give you all the opportunities in the world, and if you don't understand something, he will draw it out, he will explain it to you, and more so than any other, I think, position I've heard from is we're allowed a voice in the conversation. It's not that we just sit in the background. We're allowed to give our input on it, even if we only have undergrad or master's level. So willing to listen, work with us, and always willing to teach, I think, is some top ones.
I 100% agree. And also, I think I got very lucky too with being in Dr. Systrom's lab. These aren't questions I had when I was looking for a lab. I kind of just went with where I thought, what field I thought would interest me more, not necessarily the mentor was great. But over the past 2 years, he's been a tremendous support. To me, it was very important that he was also very supportive of my career plans and what I'm trying to do. And not only that, but also offering advice on what to do next or how to answer interview questions and things like that. One thing that I touched upon earlier too is he's very passionate about the work he does, and so that creates an environment, a working environment where everyone feels motivated and passionate to put in the work, and you enjoy going to work and you enjoy doing the research because this is something that you want to do and that you choose to do. So, yeah.
Good.
That's everything Johanna said.
Yeah. And you as well?
Well, I'll just go along and say that everything that you said as well. But I think that so I had two supervisors during my PhD. So Nuno, who is a hands-on supervisor, and then I have a co-supervisor, Luís Graça, at IMM, and both of them have different styles, but I think that it worked out okay. So we'll see. I'm still waiting for the thesis to be approved for me to go into defense. But it's good to have someone who allows you to go and explore. So if you come up with the questions, instead of taking your hand and going along with you, just let you lose a little bit of self, but not too much. Otherwise, you'll just lose exactly your focus. So I think it was to have someone who doesn't castrate your ideas, but is able to push you and reinforce and motivate you along the way.
Yeah. an important question that maybe a lot of people here at the audience will love to hear from you guys is, what advice would you give to an individual trying to get involved or just starting in ME/CFS research?
Yeah, so we've prepared some slides with some information. It worked. Awesome. So Sarah and I just recently joined, and I think Joa's interested in joining with us. There is the Young Emerge group. So Emerge is European ME research group. They have a subset for the young investigators, so Young Emerge. And it's kind of a collaboration. We're all together on LinkedIn, which is the QR code behind me. We've recently started a journal club, so we all meet. There's about 25 to 30 of us currently, open to join at any time. And they actually just put out their first joint paper in January. So that's been really helpful in that it gives you other people to talk to that know about ME/CFS and they know about the different opportunities. We actually went to Washington, D.C. in December. That was put on of Spark Me, which is associated with Young Emerge. So Sarah and I were able to present and connect, and they'll actually be meeting, they'll be meeting in Cambridge. So this is still open to enrollment if anyone's interested in attending. The Spark Me Symposium, it's going to be a part of the Invest in ME days in June. So if you are interested in attending, you can still join. That QR code at the very bottom, if I'm not in the way, is how you can register. So those have been really helpful resources that we found in the recent years.
Do you want to add something, Sarah?
Just reach out to people. Cold emailing is fine. I'm sure most guys don't mind getting those emails and helping out when they could. There's always opportunities if you just look. Don't be afraid to connect with people. If you see people at conferences and events, this is something I continue to work on too. Sometimes I get shy and don't talk as much, so just talk to people. Everyone's friendly in the ME/CFS world.
Okay.
Yeah.
Some advice from your side, from the
Just,
locals?
Just keep on bothering people, just because I just really like to talk about my work. I'll take the opportunity to apologize to my wife and my friends that I just keep on either complaining or just really euphorically talk about what I'm doing and what the conclusions that we reached. But everyone, so if I only have 6 years of this, so I did, 4 years of PhD plus 2 years of collaboration. So if I'm willing to just bother everyone with what I'm doing, people who have 30 plus years of experience will be even more euphoric and willing to give their 2 cents about the ideas and opinions. Yeah.
Okay, so I think now we have some time to more questions from the floor. We thought we only had like 30 minutes. That's what we've accomplished. But in the program, we still have some time for some more interaction. So just don't be shy. Just ask these rising stars whatever you want. And we would be very pleased to have some interaction. Yeah, please.
Congratulations for all of you. I have a question to Joanna, and I would like to know if you have any experience in introducing strength exercise in your exercise programs.
So we do work with clinical exercise physiologists, a part of the dyspnea clinic at Brigham and Women's, and mine's the research side. So in my training, yes, I was taught how to administer CPETs, but I am not currently insured by Brigham to do it. It probably is something I could pursue, but I am responsible of explaining every procedure to the patients, making sure that they understand the differences between an invasive CPET, a non-invasive CPET, and then what Dr. Sister mentioned earlier today, a submaximal CPET that we call a shape test. So I don't administer, but I do explain and I gather the data. And like Sarah said, we maintain the database of over 3,000 patients.
Some more questions? Okay, yes, Joanna.
I don't have a question, I have a comment.
Okay.
Both Sarah and Joanna were part of the scientific planning committee for this conference, and throughout the whole process helped guide the event. So that, I think, is an example of young or early career researchers helping to plan, to do outreach in different countries and begin to build an agenda. So I really just wanted to recognize their role in this and their tremendous contribution.
So I don't know. So if there is no more questions, I wonder if Professor Jaime Branco wants to carry on, and maybe we have half an hour for some sunshine, or.
Maybe you are going to end it
Earlier, yeah. Okay. Okay.
Vais falar
I have a picture with all you guys and you can share it in LinkedIn.
Well, I was asked to collaborate in two things now. The first is a summary in Portuguese of what happens this day. And so I'm going to start this summary, and afterwards, with Nuno Sepúlveda, we are going to, make some reflections about in what terms this conference, this type of conference, will influence the policies for these type of illnesses in Portugal. O sumário em português tem que ver com muitos, talvez não nesta sala, mas muitos das pessoas que nos estão a assistir online não têm uma tradução direta e imediata da conferência. Se assistirem à conferência, se repetirem a visão da conferência ou a visualização da conferência amanhã, já têm legendas. Mas hoje, em direto, não têm qualquer legenda desta conferência no YouTube. Eu vou ser muito sucinto. Na primeira parte, que incluiu as sessões 1, 2 e 3, do que falámos foi das raízes e das relações de um problema de saúde pública enorme que hoje vivemos. As raízes da Covid-longa inserem-se nos seguimentos e nos estudos, em alguns casos mais profundos, noutros menos profundos, que se realizaram a seguir a várias epidemias, desde o fim do século XIX e durante todo o século XX, em várias localizações do planeta e em vários locais, desde a população em geral até populações hospitalares, em que se descreveram quase sempre aquilo que se pode chamar síndromes pós-infecciosas. Isto é, depois de resolvida a infecção, em geral infecções virais, aparecia outra sintomatologia, que até podia repetir parcialmente a sintomatologia da virose enquanto esteve ativa, mas que aparecia como uma outra doença. Desde sempre que faltou objetividade a estas situações. Isto é, não há nenhum sinal laboratorial ou imagiológico ou de outro exame complementar qualquer, que possa consubstanciar a alteração fisiopatológica que está por trás destas entidades. E desde logo houve os detratores desta situação, dizendo que se tratava de um reflexo psicológico e ou mesmo psiquiátrico mental da infecção ou das infecções que tinham tido previamente essas pessoas. Mas a questão é que isto acontecia apenas a um grupo de pessoas que até aí, na maior parte dos casos, nunca tinha tido nada, qualquer outro sinal, e que tinha tido uma vida conforme a idade. Isto acontece sobretudo em pessoas entre os 20 e os 50 anos, sobretudo em pessoas que, enfim, têm uma atividade, até sob o ponto de vista profissional, muito desenvolvida, e ocorre também, sobretudo em mulheres. E estas respostas estão ainda hoje por dar. Passados todos estes anos, estão hoje por dar. O que é que aconteceu então, e o que é que faz esta ligação hoje, é que estas entidades descritas há tanto tempo, a encefalomielite miálgica há mais tempo, desde 55, a síndrome de fadiga crónica, enfim, nos últimos anos do século passado, e relacionada, herdando o nome que tinha a síndrome pós-infecciosa do vírus de Epstein-Barr, sobretudo quando provocava mononucleose infecciosa. A verdade é que são sintomas quase semelhantes àquilo que ocorreu ou que ocorre ainda hoje, numa percentagem de doentes que foi infectada pelo SARS-CoV-2 e, portanto, teve uma doença, teve a Covid-19. Parte destes doentes desenvolve, então, uma síndrome pós-infecciosa que é, em tudo, semelhante àquelas que foram descritas, salvo pequenas alterações que foram descritas anteriormente nas outras epidemias ou pandemias. Bom, e daí o enorme interesse é que se até agora nós tínhamos pequenos grupos de doentes, não é, que desenvolviam estas síndromes pós-infecciosas em grupos restritos de epidemias, a verdade é que isto, uma pandemia, como mencionou logo no primeiro ano de medicina o meu professor de estatística, pequenos números de grandes números são grandes números. E, portanto, pequenas percentagens de grandes números, e a população mundial esteve potencialmente toda infectada, evidentemente que, mesmo sendo pequenas percentagens, são grandes números. E sendo grandes números, como o Luís Nacula aqui demonstrou há pouco, de uma forma teórica, mas que é verdadeira seguramente, o que aconteceu foi que, de repente, nós triplicámos ou quadriplicámos o número de pessoas que têm este tipo de sintomas e, portanto, o interesse dos profissionais, das autoridades, dos jornalistas, aumentaram também. E, portanto, isto tem uma clínica que é bem conhecida, tem uma abordagem terapêutica que é muito difícil, porque não conhecendo a fisiopatologia, evidentemente que temos uma abordagem que é sobretudo sintomática, não é? E temos uma aproximação de, nem sei se lhe é de chamar outras disciplinas, mas temos uma aproximação de outras abordagens terapêuticas que não são as tradicionais e que podem aumentar até a má visão que alguns médicos têm desta patologia. Podem ser muito úteis ao doente, e nós discutimos aqui também com o Luís Nacula há pouco, algumas delas, mas para alguns médicos isto pode afastá-los deste interesse, sabendo que as pessoas estão a utilizar polivitamínicos, ou acupuntura, ou outros tipos de abordagem que não são os tradicionais. Depois, na sessão seguinte, quando falámos na sessão 4, 5 e 6, são um conjunto de sessões, nós falámos da clínica, do tratamento e do seguimento destes doentes, sendo que a primeira apresentação foi feita por vídeo, mas as outras apresentações foram feitas aqui presencialmente, e a clínica foi apresentada de uma forma muito clara pela doutora Lucinda Batman, e depois o Luís Nacula apresentou, sobretudo, uma abordagem terapêutica atual deste tipo de situações. Falta-nos sempre o pé quando procuramos ter uma abordagem fisiopatológica dessa mesma terapêutica. Da parte da tarde nós tivemos uma abordagem completamente diferente desta situação. Deixámos a clínica e passámos a falar da representação. Como é que estes doentes se podem fazer representar nas decisões que lhes dizem respeito, como é que podem ser defendidos no dia-a-dia, quer, enfim, por médicos, e a primeira mesa teve que ver sobretudo com isso, que o António Vaz Carneiro moderou, como é que eu posso agradecer aqui à Dora Sargento, que foi, enfim, foi mobilizada repentinamente, em 10 minutos se preparou para esta entrevista, dada a incapacidade momentânea da John, e que, de facto, decorreu de uma forma, enfim, que eu acho extraordinária e que nos veio dar uma ideia do que é necessário fazer, e está tudo quase por fazer. Felizmente, parece que não é só em Portugal, e isso não me deixa satisfeito, quer dizer, mas pelo menos deixa-me reconfortado que não é só em Portugal que isto acontece um pouco por toda a parte. E depois tivemos também, à distância, uma comunicação de um jornalista, do meu ponto de vista brilhante, falou durante meia hora de uma coisa que eu provavelmente não seria capaz de falar durante 5 minutos, mas sempre pelo menos para mim, de uma forma que me prendeu desde o início, e como é que, de facto, os mídia podem abordar e podem fazer a defesa deste tipo de situações que são menos queridas, menos atendidas pelos profissionais de saúde, nomeadamente pelos médicos. Os médicos aqui têm, de facto, uma enorme responsabilidade que não estão a cumprir. Mas este não é o local para discutirmos isso. Podemos discutir isto noutra ocasião. Depois tivemos uma outra sessão sobre outros atores na defesa dos doentes. Alguns eram também doentes, mas, enfim, que outros atores podem representar e defender estes doentes. E, finalmente, esta última mesa. Porque é que jovens, enfim, que podem trabalhar qualquer patologia, entre aspas, muitíssimo mais interessante e mais mediática, não é? Se interessam por este tipo de situações que são esquecidas, são desprezadas e são, às vezes, até menos consideradas. E sob esse ponto de vista, nós percebemos que, felizmente, o que procuramos fazer hoje, quer dizer, defendendo este tipo de doentes, está, com certeza, acautelado para o futuro. E, sobretudo, se a investigação, e vamos também falar disso, e amanhã é o outro dia aqui, de muito trabalho, demonstrarmos que, cada vez mais, existe aqui uma base, e é isso que temos que procurar, uma base fisiopatológica para esta doença. O Luís Nacul, desculpa estar sempre a referir-te, mas quer dizer, mas de facto é uma coisa que eu também refiro. Eu, quando acabei o meu curso de medicina, em 1978, não estou a mentir, foi em 1978 que acabei, em julho, dia 26, quer dizer, a úlcera gástrica ou a doença péptica era uma patologia que se relacionava com o stress. Era o stress, quer dizer. E como é que nós tratávamos a úlcera gástrica? Com repouso, produtos lácteos, não é? Quer dizer, e antiácidos. Bom, isto é a história da medicina. Mas era assim que há 46 anos se tratava a úlcera gástrica e do duodenal. Bom, não era bem assim, porque a úlcera do duodenal tratava-se assim. A úlcera gástrica, se resistia 12 semanas a este tipo de tratamento, era operada. E era operada porquê? Porque degenerava muitas vezes em cancro. Muito provavelmente já era um cancro desde o princípio, porque muitos destes doentes tinham realmente, mas não é disso que estamos a falar hoje, mas já agora, quer dizer, de facto, o que evoluiu a medicina neste sentido, nestes últimos anos, descobrindo-se que afinal, há bactérias em meio ácido. Pá. E um meio ácido agressivíssimo, não é? E bactérias que, apesar de estar no meio ácido, nos fazem mal e que são as responsáveis pela maior parte da doença péptica. Não por toda, mas pela maior parte da doença péptica que hoje temos. Portanto, até aí também não sabíamos. Eu sei lá se daqui a meio ano, 6 anos, não sei quanto tempo, não vamos, obviamente, e espero que sim, encontrar a causa para esta entidade. E, de resumo, em português, eu penso que estamos conversados. Estamos, John. Acho que resumi bem o dia de hoje. Muito obrigado. Mónica.
Acho muito interessante o seu comentário sobre a úlcera, porque não há muito tempo tive uma conversa com um urologista, tenho a sorte de ser seguida por ele, que me disse: a tua doença é o que era a esclerose múltipla há 60 anos.
Ou a diabetes mellitus há 100 anos. Hoje a diabetes mellitus tem múltiplos marcadores biológicos, mas há 100 anos, talvez um pouco mais de 100 anos, alguns doentes com diabetes descompensada eram internados em manicômios, hospícios, porque não havia manicômios na altura, em hospícios, como doentes mentais. Porque não se sabia, não havia tratamento e não se sabia o que era. Se querem, eu continuo com exemplos para trás. Quer dizer, quer dizer, até descobrirmos, não sabemos. Até descobrirmos, não sabemos. Percebe?
Acha que agora, com o aparecer de pacientes com encefalomielite miálgica no seguimento de um long COVID, por exemplo, eu tenho ideia que o governo americano, por exemplo, acordou, podemos estar aqui com um problema de saúde pública grave. Tanto que, se não me engano, foram 1.000 milhões de dólares que foram investidos agora em investigação. Acha que há... O que é que prevê, Sr. Professor? O que é que prevê?
Eu, se não acreditasse nisso, não estava aqui.
Claro.
Não estava aqui, não. Quer dizer, vamos lá ver. Uma coisa é nós termos 40 anos, outra coisa é termos 68, como eu tenho. Eu já não tenho tempo a perder. Eu só faço mesmo hoje as coisas em que acredito. Aos 40 anos fazia montes de coisas em que não acreditava, ou que acreditava pouco, quer dizer, hoje já não posso fazer isso, não tenho esse luxo, não posso dar-me esse luxo, percebe? Então eu quero crer que sim. Agora, mas não sei, eu não sou futurologista, pá, não tenho bola de cristal, nunca fiz adivinhação, porque seria péssimo, mas quero crer que sim. Que estamos a caminhar para isso e o exemplo desta conferência, eu aderi a esta conferência, que, como eu disse logo ao princípio, hoje de manhã, de que a Joana é o corpo e a alma, a verdade é que eu aderi a esta conferência porque acredito que isto pode ser muitíssimo útil. Porque se eu não estava aqui, estava a fazer outra coisa qualquer. Não sei o quê, mas estava a fazer outra coisa qualquer.
Eu gostava de aproveitar para agradecer, como paciente, à Joan, que tem feito um trabalho absolutamente extraordinário, ao Sr. Professor Vasco Carneiro, à FLAD e a todos os envolvidos, porque é engraçado que eu tenho reparado que, até no meu círculo de amigos e família, quando se fala FLAD, quando se fala no seu nome, juntamente com esta doença, mas se calhar aqui há alguma credibilidade. E não só tive a oportunidade na minha vida profissional de trabalhar também na área da saúde e falei com vários médicos por quem eu tenho imenso respeito e muito conhecidos em Portugal, e a reação deles foi espantosa. Não puderam cá estar, 2 ou 3, porque já tinham a agenda preenchida, mas o interesse genuíno, eu senti um interesse genuíno, mas que fantástico que vocês estão, que isto está a acontecer. E, portanto, queria deixar realmente o meu agradecimento como paciente e pelos pacientes todos em Portugal e no mundo, porque é das primeiras conferências internacionais sobre esta doença. Portanto, thank you.
Now I apologize for our international guests because I think they did not understand anything except Luís and Diana. But this summary in Portuguese was necessary for the Portuguese who doesn't understand English. And now I ask Nuno to come here, please. Nuno Sepúlveda is a PhD in mathematics and is epidemiologist. He works, he works now in Warsaw University of Technology, Center of Statistics and its applications at the University of Lisbon also, which is one of the sponsors of this meeting. Our role in this end of the first day, Nuno, is to talk about the reflections and implications for clinical practice and policies in Portugal. And I invite you to talk about an issue, you know, we are working, that's the epidemiological study you are working for in Madeira Island. Okay?
Good afternoon, everybody. I think everyone is a little bit tired, but I'll try to be brief. You know, this reflection about, when we say about reflections and implication for clinical practice and policies in Portugal, I think to convince, you know, the politicians, you know, to change the situation is actually to tell them this is actually really a problem. And for that, we need to have data. And the data has to be done in this kind of like epidemiological settings. So I foresee some difficulties in doing this kind of studies. Luís Nacul and Iliana Lacerda can testify the difficulties of doing an MECFS epidemiological study in the UK. Because most of it is because we don't have a biological biomarkers. So the epidemiological study has to be done in a different way. So we have to exclude the diseases that can explain fatigue, and that will, you know, I would say that we have to have like almost like two components. Probably one that is like community-based. So you have to go to the communities, apply the diagnostic criteria in a more like a broader sense, in a way, and then try to exclude afterwards. And then a little bit more active, let's say, sampling, but actually you contact patients' associations or something like that so that they can provide the contacts of people that actually usually are excluded from these studies. So if you do it like in a community setting, it's going to be very difficult because if you ask people to participate, most of the people that are going to participate are the ones that are, you know, they don't have any debilitation. And so in this situation, the disease, you have to have some kind of a different approach. So the Professor Jaime Branco, you know, contact Região Autónoma da Madeira. We discussed a little bit about doing this epidemiological study. First, we had a very ambitious goal to actually do it in the whole country, but we came across that the best solution is actually trying to demonstrate the principle first, and so for that we need to have focus a little bit more like in a smaller scale population, a little bit more controlled. So island settings are perfect for epidemiological studies. And I think Professor Jaime Branco may explain you a little bit more about.
In epidemiological terms, the islands are laboratories, and you know about that much more than me. And the disease, COVID-19, in the Madeira region was very well managed, very well managed. And as you know, during the majority of the time that pandemics were declared, it was not possible to make the travels to Madeira and being outside Madeira. And well, even the population that went to Madeira and leave Madeira were minimal at that time. If we make only the study of the population of Madeira, where there are a very, very good registered of the patients. It's more technical, more easy for us, and in financial terms, it's very, very cheap. And that's the motive to do this study, firstly in Madeira, and after I think Madeira must reflect what is happening in the rest of the country. We rheumatologists have done a national epidemiologic study of rheumatic diseases, and Madeira Island, the results in Madeira Island were very similar to the continent. It was not the same in Azores, but in Madeira the results were similar to those of the Portuguese continent at that time. And I don't see any reason to be diverse in this matter. I don't know if you agree or.
No, I totally agree. And when I was working in EROMIN, the European Network on Chronic Fatigue Syndrome, I was in the epidemiological group, and we gathered all the epidemiological studies done in Europe, and it mostly was like in Norway, Iceland. This was the only country that actually did at the country level, and then the 3 regions in United Kingdom, or England specifically, right? So I think it's exactly Madeira is the perfect setting to do this study, and like you said, if the island can represent the whole country, I think it's, like I said, data provides informed decisions, and that's what we need. We need, as researchers, we need to provide evidence that this is a real problem.
May I ask a question?
Of course.
So when you choose patients for your studies, do you have a clinician that's excluding other causes?
That's a good question.
Yeah. And applies would they, like, because in the States, when we are involved with studies, with someone like myself or Cindy Bateman or somebody, applying the IOM criteria, the Canadian criteria, and really vetting them. Because when you said earlier that you were going to select people from the support groups, I wondered if you also had the requirement that a clinician had to vet them to make sure that.
For this particular epidemiological study,
right.
The register is already done. Okay. It was at the moment that patients were diagnosed by the local medical doctors, of course, and afterwards, if they develop a post-infection syndrome, another syndrome, and that's long COVID, okay? But always done by medical doctors.
You feel confident in the diagnosis?
Yeah.
Okay.
Well, the results are in the Public Health Department of Madeira.
Okay.
No? And we are going to collect them from there.
If I can add a little bit, just for you guys to see the scale of this problem. There was published, actually I'm living in Warsaw, so in Poland, and there was a study done in Poland, where actually they just did in the city of Bydgoszcz, so in the north of the country, and they wanted to make a survey, and they advertised in the radio and in the television, so that they say, okay, we are doing this study, can you please report to go to our website and see actually if you think that you have ME/CFS. They had 1,000 people actually reporting that. But then, coming to your question, they were asking people that actually they agreed with let's say the questionnaire that is in agreement with the diagnostic criteria, but then they were asking people to go to the clinic. And so in the end, they were only 60 out of the 1,000, because they had a lot of diseases that actually the people didn't even know. They mostly neurological conditions known.
And now, if you don't matter, I will invite Joanne. Can you come here? And because I think the second issue we must debate of the interest of this first day to Portugal is the awareness. The awareness for the whole population, the awareness for patients and families and caregivers, the awareness for doctors and other professionals, the awareness for politics, the awareness for media. Well, what do you think about it?
Well, I think we've had many patients crying in the wilderness for many years. I think Monica is testament. Perhaps she's probably one of the case studies here in Portugal, living with the illness now for close to 3 decades, and clamoring for help. And so I think in the last year or so, we've seen a lot of momentum in civil society with the formation of new groups, Enfrentando em Movimento, the establishment of the work group with MIOS, and then just groups of patients coming together over the last 6 years to provide advice where clinician guidance was lacking, where scientific information that was filtered and filtered through the eyes of practiced clinicians and patients that have been living with this illness and are thoughtful about this. So I think we're really at a turning point, and now that we have these wonderful allies internally within Portugal and internationally, we can bring the awareness and the various efforts that are being carried out internationally to reverberate within Portugal and vice versa. So I think we're in a very good spot. I think so. Much better than we were 5 years ago, 10 years ago, 20 years ago. And I think also now we have very important allies in the Brazilian community. We have to recognize that this is a problem that affects many Portuguese-speaking people. We have a dearth of materials for training physicians in Portuguese, resources, publications. And so in joining together with the Brazilians and with other Lusophone communities, we've been able to really multiply our work and our projection. Because this illness has struck so many in the health professions, particularly in the Brazilian group, we have dentists, we have neurologists, we have nurses, we have scientists that have come down with this illness. I mean, Brazil is a very big country. And so they're now also working with us to advocate for better treatment, care, and awareness for Portuguese-speaking communities everywhere.
Thank you, Joan. And profiting for your international experience, living and working abroad, what do you think about what must we do to increase the awareness of these or other diseases?
It's a complex. It's a complex question. I'm not a medical doctor.
Ideal for this.
But I think everything is about education. Ultimately, it's about training, and the awareness has to come exactly from the medical schools in the first place, because they are the ones that they're going to deal with patients, and so exactly coming back to the policies, the patients themselves, they have a voice. But I think the governments, unless the patients will go out, like I've seen in some documentaries, but that the patients go to the front of the parliament and they put all the shoes in front of it, and they say millions missing. But at the end of the day, I don't know. NICE as patients' representative, right? But the medical doctors have a very strong voice. So if we reach the medical community, they can lobby for that. Because patients themselves, unless they block the highway, it's the only way that they can be heard in a way. So,
thank you. Well, we are ending this first day of our conference. And I thank you and for your yeah.
At the risk of being expelled for talking too much.
Okay.
There's one issue that I think is needs to be addressed, which is the language barrier. I am fortunate to be an English speaker, but no one is obliged to speak English. And there's a wealth of information. I certainly follow a lot of organizations in the United States. I'm so very grateful for all the support I've had, and in the UK equally. But I'm very aware that for a Portuguese speaker, that may not be so accessible. And there is a Europe-wide language barrier because, you know, Turkey, Spain, France. So that, I think, maybe is an issue that could be addressed in some way in spreading the word, is, you know, trying to get the message across. And, you know, there's a wealth of information here. We have come such a long way, incredibly long way. And people are suffering unnecessarily to a certain degree. As you know, this illness has different levels of severity. But there are certain things that can be done to prevent damage to a certain extent. And there's a wealth of information that needs to be accessed worldwide, really. So, communication.
Thank you.
Can I just add? So, you know, at least maybe we didn't reach the right audience, but actually you can go to the Euromin website and you have information in Portuguese. We've done the translation. The Euromin, the European Network on Chronic Fatigue Syndrome. You have a lot of documentation in all the European language that at least that they were represented in the network. So you can have that at least the documentation. But one thing that you all have to think about is that you know, when you talk about global burden of disease, ME/CFS is not there, and this is a problem, and this is a big problem. It's not represented as a disease. Yeah. So if you want to do like cost, you know, kind of like burden of the disease in the population, this is going to be a blockage because you don't have data. So as long as you don't have that recognition, we have to create it.
Thank you. Any other question or comment? If not, well, I thank you for your presence and participation in this first day. And, well, I have a message for those of you who are going to return to the Hotel Açores, and you went by the bus. The bus is at 6:30. I think. I don't know if it is possible to anticipate because we have the handed. No? Okay. It's 6:30 here. For all the others, I hope to see you in the morning tomorrow here at the same place, and have a good dinner, a good night. Thank you very much. See you tomorrow. Well, very good news. The bus can be anticipated, so you can ask him to come. Okay, because people are ready to return. Okay.